Uh, uh, can you hear me? Can you hear me? You say testing, 1, 2, testing. Good. We'd want to call the session to order. And I want to request all participants to take their seats. Those who are outside, could you make your way into the plenary hall? Yeah, I would want to recognize the participants who have joined us online. We are just about to kick off, albeit according to the program that has been projected. We have been taking registration over the last half hour or so. And I would also want to let you know that we will have the official opening a bit later because our executives from the Ministry of Agriculture, Livestock, Fisheries, and also from the Ministry of Health have been held back because of some urgent assignments and commitments this morning, but they'll be here by 11:30. So we have had to tweak the program brief a bit so that we start off and then we'll get to that later. Now, I still want to have most the participants who are outside the hall to come in, please, so that we kick off. Thank you very much. Colleagues, distinguished delegates, our partners present, our colleagues from the counties, our colleagues from academia, our colleagues from industry. I would want to welcome you here for the AMR Forum, which has been organized by the National Antimicrobial Stewardship Interagency Committee Steering Committee, which has found it important to have this day so that we can officially start the process of reviewing our National Action Plan. Details will come a bit later. So, to begin, we will have an opening prayer by Cynthia, and then we'll continue the program. We'll have the objectives of today's forum outlined, and then we will get presentations based on specific outcome areas that we had projected in the last 5 years before taking a short health break and having a short plenary. And then we'll move on to the official flagging off when our senior officials from the ministry will be here to give us their blessings. Within which time also, I do recognize that we will have remarks from our partner organizations, and also we'll have official remarks from the ministries of agriculture, ministries of health, and also the senior leadership from there. And then later, we will go through presentations by the counties and their experiences. And then we close the day with discussions, and we agree and actually map the way forward. So I'd want to welcome Cynthia to take us through a short prayer. Welcome.
Okay, let's bow down and pray. Our kind and everlasting Father, we thank you for the gift of life that you are given unto us. We thank you for the gift of today, Father. Father, as you see, this is the first time this event is happening here in Kenya, Lord. We kindly ask you for your guidance. We kindly ask you for your protection. Lord, as we are going to make deliberations today, we kindly ask you to guide us in every decision that we are going to make, so that it will affect us positively in the next 5 or 10 years, Lord. As people, some of us are still traveling, may you give them journey mercies, Lord. All these I ask, believing and trusting unto your able name. Amen.
Thank you. I think we are blessed and ready to kick off. Now, it's always good to know one another, who we are, but considering the numbers, we may not do that, but you will recognize that we have presence physically and also presence remotely. Our online participants, we also welcome you to this forum, and you will note that the NASIC has been very flexible and adaptive to technology, to the extent that for the last 3 years, from 2020, this is the 3rd year, we've been able to utilize the virtual space and reach out as much as possible, and also continue the work of implementing our policy on AMR. So I would want to invite Dr. Simon Kibias, who is the head of quality standards at the Ministry of Health, to welcome you to this forum. And he's been one of the key pillars in ensuring that we are able to drive this agenda and ensure that we meet the objectives that are set out for containment and prevention of antimicrobial resistance. Welcome, Dr. Kibias.
Thank you, Dr. Asekele, who is the Vice Chair, Codex Alimentarius. I hope I pronounced that very well. But I would like to recognize him as one of the experts that have really helped us in this area of One Health. This morning, I'm privileged, I'm honored to stand before you to give this few remarks ahead of the program. My name, as you have been told, is Dr. Simon Kibias. I'm a public health specialist working with the Ministry of Health at the national government. And currently, I'm the acting head of the Directorate of Health Standards, Quality Assurance, and Regulation, where the main players of AMR, the Department of Health Standards, and the Division of Patient and Healthcare Safety, headed by Dr. Evelyn Wesangula, sits. I would like to take this opportunity to thank God for this day. It's another beautiful day that we are blessed to have. I would like to take this opportunity also to really thank the Ministry of Health officials that and also other ministries, departments, and agencies, especially Ministry of Agriculture, Livestock and Fisheries, and other MDAs that have been championing AMR in our country. Yes, I would like to recognize our developmental partners, other key stakeholders, all from academia, from private institutions, private sector, and so on, who have been very key in this area of AMR, and especially One Health. I think a lot will be shared with us in this AMR forum. So I would like only to touch on the fact that today is the beginning of review of progress made in our National Action Plan for AMR. I would like to say that AMR in our country has been a success project and has been recognized regionally and globally, since we ascribe to the International World Health Assembly resolutions on AMR, IPC, and even in the East African community. Last week, we had our 22nd Senior Council of Ministers of East African Community session, and the AMR was recognized as one of the pillars of One Health. And countries have national action plans in place, and they are active. Why are we on national on AMR? Why are we focusing on AMR? I would like to summarize it like this, that if East African community, Kenya included, has to position itself globally as a medical tourism region, we must address the issue of quality. I'm happy to report to you that our Kenya electronic quality model of health recognizes the quality of care as the key in the delivery of the highest standard of care possible. And AMR is key in ensuring that we do not get hospital-acquired infections through a robust infection prevention control program and the rational use of antibiotics, the scarce antibiotics. So Kenya is playing its key role in, through you people, whatever you do, to ensure that Kenya joins the East African community in ensuring that we have a safe health environment. And in so doing, we ensure that the quality of care in our region is of the highest standard possible. And I do not have to say much because a lot of in the program, if you see, Dr. Sekele has already implied that there will be a lot shared with us. But I'm here today to thank all of you who are here physically present for showing up today to this very important forum, because I'm sure by the end of today, you will be able to articulate AMR, the quality of care, and the reason why we want to position the health sector right at the center of the economy. Yeah, I'm sure you know that there is no UHC without quality. If you look at the strategy for UHC for Kenya, one of the A's is acceptable. The UHC must be acceptable, and acceptability means quality. So with the quality care, we will be able to reduce wastage in the health sector. We will be able to attract medical tourism, and we shall earn a lot of revenue from that. Do you believe it? Yes? I think we are tired spending more than 10 billion referring patients abroad. From where I sit, I usually sign letters on behalf of the Director General for Health for clients seeking treatment abroad. Sometimes what is bothering them, and especially so when we deny them the permission to travel out, they start complaining about the quality. Say, yes, the service is available here, but the quality is low. I don't want to risk my life. What did you do? So you start canceling and start explaining. Yeah. So we really have to. We probably already have equipment in our country that are of international standard. Yeah. If you have been following in the recent past, we now provide PET scans. There is a cyber knife coming. We will have all the equipment required, but we need to address the quality aspect in order for us to play our role in the region as the lead in healthcare. So what we are discussing today is very key. It's very important. Nobody will come to Kenya if there are reports of hospital-acquired infections. Yes, I will not spend my millions to travel through the 780 Airbus if I'm a rich man from another country to come and get treatment and then go back with an infection which is not treatable because you have acquired multi-drug resistant agents. So we really have to be conscious of the fact that you can have money, but you may not be able to cure yourself from a multi-drug resistant infection. Isn't that not true? Yeah, this pandemic has taught that we really have to avoid certain pathogens, or else money will not save us, not even the influence or positions If we can't learn from this pandemic, we'll never learn. Yeah. So One Health, I really would like to thank those who have been championing One Health, AMR, and IPC, because without them, we probably would not have been very prepared for this pandemic, because they played a key role before. They taught us how to be prepared, how to respond, and even during the response, they were there to give us the first guidelines on IPC, the first guidelines on how to manage, to isolate, and so on. So they continue to play a major role. And personally, I've been very happy to have a very robust team that I would like to recognize today and say thank you for the good job you're doing. You have done a lot for posterity, and I think going forward, prioritizing AMR is a priority for all of us. So mine is to wish you, those who are here physically, enjoying the large screen and the cup of tea here or coffee, and those who are joining us online, we are all one team, and all the ideas that will be coming from you through online platform, most welcome. We shall be listening. So let's join hands and contribute in this forum. And I take this opportunity to just wish you a fruitful forum discussions. As we wait for our seniors to come, we shall also give them a chance to address us. Thank you so much, and feel most welcome to this forum. Thank you.
Thank you very much, Dr. Kibias. As I'd said, you know, he's the quality champion. So he actually backstops whatever we do and puts into a clear lens, and we get to know, are you having quality reports? Yeah. Are we having the outcomes we expect? Are we making progress? Thank you very much for your stewardship in this area. So going forward, we will have Dr. Emmanuel Tanui, who will take us through the objectives of today's program activity, so that we understand what we want to achieve today. And then thereafter, there'll be a short brain teaser, which we will run. Joseph must be preparing for that. And then we will move on to the next session. Welcome, Dr. Tanui.
Thank you very much, Dr. Zegele. Good morning, everyone. Yes, as you heard from Dr. Zegele, my name is Dr. Emmanuel Tanui from the AMR Secretariat. My task this morning is very simple and brief. I just want to remind us about the expectations for today, what we are hoping to achieve, so that by the time we are getting to the end of today's session, we are hoping that we'll achieve our objectives for today. So I'll share the screen so that we can be together as we are going on. Yes, so we have about 4 broad objectives for today's session. We are all aware that the cycle of the AMR policy and the National Action Plan that we developed in 2017 is coming to an end, and we want to take stock of our progress and successes so far. What is it that we've been able to do in terms of the interventions that we had put in place in 2017? So we'll have a scorecard that will basically give us a general rating, and we discuss what is it that is good that we had put in place, what were the things that we think that we can improve in our next cycle of the National Action Plan. And then finally, what are the lessons that we've learned and the activities that we plan going forward. So we'll have that session in the morning, and then we're also going to hear about some of the activities that our partners had committed to do in what we had coined as call to action. So we are hoping also our implementation and development partners to talk about the areas of work in AMR. Then we have been generating evidence, information, and data all the way from the counties. So the counties will also have a session that they are going to talk about the different areas of antimicrobial stewardship, surveillance, awareness, and all forms of research. So we are going to share the local evidence, because a number of times when we make presentations, even in international fora, people tend to say that we have very little local evidence in place. But I would like to say that we have a lot of data that has been generated in AMR. What is missing is for us to collate this data together so that it can inform our next steps. So we are going to have the counties share their experiences and success stories in the different thematic areas of communication, IPC, AMS, and surveillance. Then finally, we are hoping that we are going to embark on our way forward, the next steps, how we are going to review the policy. What is our plan for the next 5 years? Because for now, I'm sure we have learned a lot of things from the previous cycle. How are we going to implement the next cycle of the policy? And our sustainability plans in the long term, because sustainability was a big challenge in the previous cycle, where we had put a lot of activities in place, but very little interventions on how we can get this budget fully supported financially and also in terms of human resource. So we are hoping that we'll get also commitment from leadership, counties, and so forth in our next cycle. So basically, that is how our day is going to be. Those are the objectives that we hope to achieve. So at the end of the day, if we are going to have outcomes addressing these objectives, then I would say the forum has been successful. So I want to invite all of us to feel free to present, discuss, ask questions about any of the presentations so that we can have some learning process. Thank you very much.
Thank you very much. Asante sana, Tanwi. At least we all know now what we hope to achieve today. I want to recognize the presence of one person who was very key in the beginning. Dr. Rachel Kamau. Dr. Rachel Kamau, I recall the very first meeting when we didn't have an app or anything. She was leading the process on the human health side. And we walked through the journey together. I think karibu sana. And her efforts, she has served as the CEC Nyeri. And you recognize that Nyeri was the first county to establish a CASIC. So her leadership is well appreciated and recognized. Now I would want to call Joseph to come and run the Mentimeter with the questions. Yeah, it's Joseph. Yeah. So that we get to tease our brains a bit. Joseph, karibu. You want to use? Nitoe.
Good morning. My name is Joseph Junge. I work with Find. We've been supporting we've been working closely with the NASIC team to support them in the surveillance of AMR. So we have been able to develop a surveillance system that is able to collect data from the the animal sector and human health sector. So my assignment for today, thank you, Dr. Evelyn, for the early morning assignment, is to help us, or rather to have some brain teasers. So I would request us to go to using our computers or our phones, we go to menti.com. The code is up there, 5736-8582. Once we are there, then I can run. I only have 3 questions. So once I have a good number of us registered, I think I'll be able to run it down. We are currently at 4, so let's keep going. Yeah, menti.com, and you put the code 5736-8582. We are just about a score that is 18. All right, maybe do I run it at 50 or 60 maybe? All right, for each question you have 20 seconds to read the question and pick your answer. The faster you respond you rank higher. So we are at 66. Anyone who hasn't registered yet? I see a hurdle too. All right, I think we are good now. So as I said, answer first to get points. So this is it's quite a common citation in most of the literature around AMR. So we have that 10 seconds. All right. Let's see. So 45 people got it right. I think that's quite commendable. Out of 69. Yeah. Yeah, so that's quite commendable. Let's okay. Let's see who that was. Let's see. Oops. My internet decided to go bananas. It's bad. Okay, let's see who was. Yeah, we have AMR Steward was the fastest. I don't know. Do you want to do you want to know who that was? Or we wait until the end, right? Okay, okay. Let's go to the next question. Question 2 out of 3. And again, the same instruction, answer first to get point. I think Dr. Tanui somehow mentioned this in his opening remark. I'm sure even Dr. Azegele did the same. So above 70% and above, I think would be acceptable. Yeah. Okay, let's see. Okay, we have 60. That is good because it's 60 out of 77. So I don't know what percentage that is, but I think that is okay. So let's move on before my internet decides to. Let's see who is maintaining the lead. If the MR steward. Yeah. Yeah. Okay. Well, number 2 is also coming very closely, so it's only 3 points shy. So, Yamat Stewart, I think everybody is after you. So, whoever you are. Huh? All right. There's the last one. There's the last one. So this is the last one. Just a minute. How many strategic objectives for countermeasures on AMR are there in the NAP? The NAP that we are reviewing, that was developed in 2017. How many strategic objectives are there? Okay, let's see. Wow, that's 66. Okay, that's 66 seems to be consistent. Even the other one was 66. But all right, so I guess that was it. Let's just see if there is the last 2 slides before I exit. I think I'm having some delays on my end, but I think that should be it. Those were the questions that I had. I would have really wanted to show the, who was number 1, and maybe we can be able to clap for them. But somehow this thing keeps reloading. Yeah, the internet is not very friendly. Yeah, that's what I'm doing, just checking. Yeah, so we have AML steward still wow, that's quite, all right. So do you get the pleasure to know who? All right. Yeah, I think it would be good to know as you come. All right. All right.
Thank you very much, Joseph Njunge, for that. It's nice to have a brain teaser, isn't it? And it's information you have. Isn't that so? So let's give him a clap also. So yeah, it's It's always good to challenge our minds. It's information that is with us, but we take it for granted. So at least I'm encouraged that those present here and those joining us online were able to really tell us what they know. And we've done quite a bit of surveys in the process in the last 5 years, and we'll share as we proceed. And I think this is the time that we are going into that. Now we are getting to the next session where we want to get to share the local evidence that we have from based on the objective areas that we had purposed to do. So we're going to take strategic objective 1 and 2. We have Ramona Ndanyi and Susan Gidhi to take us through this area. Welcome, Daktari.
Thank you, Dr. Zegele. Ladies and gentlemen, good morning. So there's a team of us from NASIC who are going to take us through this presentation, taking stock of what we've been able to achieve since the time we said. So my name is Dr. Ramona Ndanyi, and I work with the Directorate of Veterinary Services, a member of the AMR Secretariat, a member of NASIC. Yeah. Presentation one. Okay, thank you. So we'll take us through what we've been able to achieve since the time we enacted our National Action Plan and our national policy for AMR. I will start off by giving a background, and I'll do this very briefly in the interest of time. We all know that antimicrobials are the cornerstone for our health systems. And when we talk about health systems, we talk about both humans and animals, because that's where we use antimicrobials. Not to forget that also in the agriculture sector, there are antimicrobials that are used in the crop sector. We use antimicrobials for prophylaxis, for surgeries, and for therapies. And the current topic we are dealing with, the current issue we are dealing with, is very important because due to the way we're using our antimicrobials in all these sectors, we are developing this scourge, that the threat that we want to address, or we've been addressing for quite some time. The effectiveness of our antimicrobials is compromised, and there's been increasing resistance worldwide. Kenya is not left out. And this resistance, as I said, is associated with inappropriate use, misuse, abuse. And the spread of resistant organisms also occurs through poor infection prevention and control practices. As a result, the standard treatments that we use both in animals, humans, and in crops are becoming ineffective. And we have seen infections that persist, are unable to be treated with the common antimicrobials that we have. And I think most of us who joined us during our WOW, we actually had live experiences shared of what we are. For us in the country, We started the journey of addressing AMR way back in 2011 when we had our first situation analysis between 2009 and 2011. But at that time, we were only working with the Ministry of Health. Eventually, we also had partners who was looking at AMR within the agriculture sector, mainly FAO. So we now came together as using a One Health approach and formed a multi-sectorial advisory committee to address AMR. This was then culminated into the formation of what we called NASAC in 2014. And eventually in 2017, we were able to now come up with our AMR national policy and national action plan. That is the one we are discussing today, the National Action Plan. You realize that the National Action Plan was running from 2017 to 2022, so it's actually due for review this year. AMR is a shared responsibility, and that is why we actually use a One Health approach. Currently, the two lead ministries are the Ministries of Health and Ministry of Agriculture, but eventually we've also incorporated the Ministry of Environment and Ministry of Education. So in the subsequent National Action Plan, in the subsequent national policy, we will see a lot of involvement of all the other sectors. The next slide just shows us how we ensured that we incorporated One Health. Our National Action Plan and our national policy was endorsed by both the Ministry of Health, that time was Dr. Cleophas Mailu, and Ministry of Agriculture, Cabinet Secretaries. That time it was Mr. Willie Bett. So what are our objectives in the National Action Plan? We have 5 objectives. The first one is public awareness and education. We want to improve that. The second one, surveillance and monitoring. Third, infection prevention and control. The fourth one, appropriate use or prudent use of antimicrobials is research and development. So the subsequent slides that you're going to present is just to give you a snapshot of what we have been able to achieve in these specific objectives. So the first objective of public awareness, what have we been able to do, completed, based on what we outlined in our National Action Plan. So one, we wanted to increase public awareness and understanding, which is very important. We cannot address an issue if there is no awareness and there's no understanding of the same. So we started by creating or developing our communication strategy. Is this on? Sorry. Our communication strategy, which was launched in 2019. Sorry, this is not working. So we developed the communication strategy, which now outlines how we intended to create awareness and understanding. We've also been celebrating the World Antimicrobial Awareness Week annually since 2014. And in 2021, we were so glad that we managed to actually have a number of counties, 9 in total, also celebrating the WOW Week. So we moved from just having the WOW Week in one county, and now we have been spreading out. We've also developed a number of IEC materials on AMR, which have also been distributed to various areas. AMR events, most of us may have seen them reported in public media. There's also been a survey that was carried out the citizen-generated data in several counties to establish a level of awareness in AMR. And the photos can just show you some of the evidence of what we've been able to achieve. Still on public awareness, we wanted to ensure that AMR is adopted as a core component of health professionals. So we have an AMR curriculum with modules for pre-service, specifically for the pharmacy students and in-service cadres. We've also trained and sensitized healthcare workers and veterinary officers in AMR. And education and training of AMR professionals, we've been able to sensitize and train healthcare workers and veterinary officers. Sorry, I think I'm repeating myself, but just to emphasize, we've done quite a number of those trainings. And we also planned to establish multi-sectoral One Health committees. So the first committee we established was the National Antimicrobial Stewardship Interagency Committee, that is NASIC. It is in place and it is active. We also, because all this work is carried out at the county level, so for coordination of AMR activities at the county level, we've also been able to establish a total of 14 CASICs. CASICs is a County Antimicrobial Stewardship Interagency Committees. These are in Machakos, Kiambu, Embu, Nyeri, our pioneer, Makueni, Murang'a, Uasin Gishu, Trans Nzoia, Bungoma, Kisumu, Kakamega, Bomet, Kilifi, and Mombasa. And we'll hear more from them later in the day. So what is pending in implementing the activities we outlined in our NAP and public awareness? What is pending is increased public awareness and understanding. From our developed communication strategy, we do have some components that are still pending. One, you realize we only have 30% of the counties that have CASICs. So going forth, we need to improve on the number of counties that will actually have their coordination structure in place. We also need to improve on development of the IC material, for example, because most of the ones we've developed are only in 2 languages. And for us to be able to reach out to other audiences, then we also need to ensure that we speak the language. What's also pending is AMR as a core component in health professional trainings. We still are trying to incorporate AMR modules in other health professional curricula, including the animal health curricula, the medical curricula, and the other paraprofessionals. And lastly, what is also pending is establishment. Okay, I already mentioned this. We want to ensure that we increase the 30% CASICs to most 100%, God willing. So the photo that you can see down there is a snapshot of results from the citizen data that we got, and it just goes to tell you how not informed people are about appropriate use of antimicrobials. This just gives you a snapshot of what we've been doing. So I'd like to now invite Susan Gidi to take us through the next objective, which is surveillance and monitoring. Thank you.
Good morning, all of you. My name's Susan Gedi. I coordinate AMR surveillance in the laboratories. And as Dr. Ramona has said, we usually use One Health approach. So I'm going to take you through the achievements, both in animal health and human health. And the goal of our surveillance is to continuously monitor antimicrobial resistance and use of antimicrobials appropriately and appropriately understand the threats and spread of AMR. And for us to achieve this, we have to build capacity, both professional and also in our laboratories, in terms of mentorship, reagents, equipments, and all that is meant to be kept in place for us to get quality AMR data. So what we have completed is development of AMR surveillance guidelines with the purpose of standardizing our microbiology work. We've managed to complete the national AMR surveillance strategy, both in human health and animal health. And this strategy usually guides us, it takes us through the steps that we are supposed to take as we continue with our AMR surveillance activities. From the animal health, we've also completed the protocol for active AMR surveillance in commercial chicken population in Kenya. We've also completed the bacterial isolate referral guide. For us at the national reference laboratories, we usually check the quality of the performance of the sites that are undertaking AMR surveillance. So they usually get isolates to the national level for quality check. And we came up with this guideline so as to guide on what the sites are supposed to send to the reference lab for quality check. We also came up with the National Antimicrobial Resistance Training Curriculum, which is also One Health. And all this is to make sure that we are standardizing all the protocols for AMR surveillance. Also to standardize, we came up with the ECHO, that's Extension for Community Health Outcomes. This is a virtual platform whereby we mentor all the surveillance sites and even the sites which are planning to join surveillance for them to standardize our work, to get expertise in microbiology work. And at this juncture, I would like to appreciate Professor Refadhi, who is here. Just stand and wave to the cloud, who has really been taking part. She has really been taking part faithfully in our ECHO sessions, and I know majority of the counties, they recognize her. She has been our smart matter expert with any case that comes from the site. We also appreciate Linus from CDC who has been supporting us in learning this system, and also Jennifer Johegu who has been coordinating the ECHO sessions. So through this platform, we realized we cannot make to go and train people on the bench. And so we came up with these sessions, which happens after every 2 weeks for only 1 hour. And we are able to continue mentoring our surveillance sites. So the other achievement, for us to start the AMR surveillance, we had to come up with the AMR National Reference Centers. And we were able to establish the National Public Health Labs and also the Central Veterinary Labs as our reference centers for AMR surveillance. The other achievement was establishment of AMR surveillance lab network. So far from the human health, we've managed to prepare 16 labs that we are expecting to be sharing data at the central data warehouse. And out of the 16, we have 10 labs which are already sharing data. And with this data, we were able to also respond to the WHO data call, 2021 data call, and we were able to share our resistant data. From the animal health site, we have 6 surveillance sites, which are making the network for the AMR surveillance. We've also managed to complete our dashboards for analyzing and correcting our AMR data from the sites. From the human health, we have the LIMS, that's the laboratory information system. And our surveillance sites has been they've been interconnected such that they're able to share the data at the central data warehouse, which is based at National Public Health Labs. From the animal health side, they have C-Lab, and with this C-Lab, they're able to collect all the AMR data for analysis and also for policy. The other achievement is we've managed to come up with a One Health dashboard. With this dashboard, we are able to see the reports from human health and animal health. So at the click of a button, you'll be able to see all that you need to see on the surveillance. The organisms that are being isolated, the resistant profiles, the kind of samples that are being processed and so on. Anything that you'd like to see on this surveillance, you're able to see using this One Health dashboard. So these are some of the reports that we've managed to do after analyzing all the data together, this from human health. And we decided we have so many analyses, but we decided to share Staph aureus and E. coli, which is common both in animal health and human health. And you can see the resistant profiles. The red bars are showing the resistance to the antibiotics which were tested. That's for Staph aureus. You can also see for the E. coli from human health, the red bars, and you can see the emerging resistances, which calls for Antimicrobial Stewardship Committee to take up to the task and try to talk more on the misuse and the correct use of antibiotics so as to prevent these emerging resistances. From the human health, this is data from Staph aureus in poultry. And you can also see the red bars, which are showing the resistant, percentage resistant to the antibiotics which were used. Same case to the E. coli patterns in poultry. This is the kind of data that we've seen. You can see the red bars, some like tetracycline has a very high resistance at 66%, and the others which are showing emerging resistance. So what are we planning or what is pending? The first one is implementation of the AMR surveillance strategies. As I've said, we have 16 counties from the human health that they are in our network. And you can see out of 47 counties, that's very few. So our plan is to scale up to, if possible, all the 47 counties so that the data that we are getting is representative. We can make a policy out of it, but 10 counties, it's very few. The other one is from the animal health, is implementation of the poultry protocols. Then sample referral guideline for animal health is in the process. The other planned activity is training more mentorship on technical personnel on surveillance and laboratory operations. The other one is promoting the use of laboratory data for clinical decision making. So we are planning to start training the sites in coming up with antibiograms so that they can be able to see the resistant profiles and clinicians can use these antibiograms for decision making. The other one is expand and maintain capacity in national and county human veterinary and food safety laboratories to conduct antibiotic susceptibility testing and identification. So in a nutshell, that's what we've managed to do for the surveillance. And I'll call upon the person who is presenting on infection prevention and control. Thank you.
Thank you very much, Ramona and Susan, for that. I think we give them a round of applause once again. I will not open the floor for questions for now, but just jot them down, keep them, just hold on until we are through so that we can save on some time. We are also on Twitter. You know, some of us, we were born before Twitter. Now, I've just been shown how to use the hashtag. It's hashtag AMR Forum KE. So if you follow me, you'll find my tweet, and then you retweet, and we keep tweeting. So I want to invite Veronica to take us through the third objective on infection prevention and control. Welcome.
Okay, thank you, Dr. Aaron, for that introduction. My name is Veronica Kamau from the Ministry of Health, and I'll be taking you through infection prevention and control. So as we are all aware, infection prevention and control is quite key, especially if we are to keep infections at bay, and if we are also to reserve and preserve and salvage the antibiotics that are actually remaining as we continue with our practices, as we continue serving the Kenyans, as we continue serving our farmers and each and every person. So it is my hope and my wish that we are all aware about infection prevention and control, because these are just protocols, standards, and procedures that are put in place to control infection from one person to the other, and also the hygienic in our farms, so that at least we can control the infections of the animals. So I'll go actually to see how best have we been able to implement on infection prevention and control. IPC core components in Kenya, we realized after we came up with our policies that it is important for us to involve the management, leadership, and governance of the IPC services. Remember, health is a devolved function. So we have to have a way of actually from the national up to the county levels, so that we can have some guidance in the kind of structures that are there, so that we can also render the services. Advocacy is quite key, behavior change and communication for infection prevention and control. And we are all aware that these are some of the things that we actually realized during the COVID pandemic. And it's actually, despite of whatever was to come to us, our IPC structures stood a great role in actually preventing the COVID-19. So we realized that IPC is for all of us. Healthcare workers' education and capacity building for IPC is quite key and critical. And this, for sure, we have educated, and we continued educating the healthcare workers and capacity building them for IPC even during COVID-19. And I always say, once we started with that moon suit, because that is what we had observed, but that is where our knowledge was. But as we continued, we are now aware which kind of PPEs do we require at certain levels. So education has also been key and critical as to understand the scenarios that we are in and how best we can be able to articulate and give the services so that we can actually retain our healthcare workers healthy and prevent them from infection, and also prevent them from spreading infection to the patients. The patient and the health worker safety in the healthcare settings, this is actually quite important because we need the patient and the health worker to be safe at our settings. And I would also say that last week we were actually coming up with the policy for the health worker and the patient safety, and we validated it last week, and we are hoping that within the next 2 weeks, we'll be able to print so that we have incorporated the kind of inputs that we were given by our stakeholders. Availability of IPC supplies, equipment and infrastructure is quite key, and it is critical because if we don't have this, even if you have very good guidelines and protocols, there is no way you will be able to practice the infection prevention and control. So that is an area which we have dealt with on, and we have continued advocating for supplies. IPC surveillance is also quite critical because what is not measured, you cannot not actually be able to know what is this that you are still struggling with. And thanks to the lab, because they have put things in place. And we always say IPC and AMR is just like a grab and a hand, because if you don't have the two, you will actually end up abusing the other. The M&E for IPC programs, This one we have gone quite further, and I'm happy to report that from the human health part, we have managed to have some few indicators. We have counties that are actually piloting, and the counties that are piloting on some few indicators in the KHIS will also chart a way forward for the other counties. So as I had said, we have some core components. This is just a pictorial that we have to have the surveillance. We also have to have the guidelines and the M&E. But one of the things I would really wish to report on and maybe dwell on a bit, it is the bed capacity. Because we realize we are consumers of health in this country, but bed capacity we have continued struggling with, and this is one of the areas. So where do I have the demarcation if I have two patients sharing a bed? And who is this? Because we know NHIF actually reimburses as per bed. Who is who? So you can see we have something that we are still struggling with, and how I wish we can come up with a mechanism that within our counties, if our patients are covered by NHIF, they can actually be treated from any part of that county in particular. So this is an area we have seen that I would say Nyeri has actually started implementing it, and it has done so well. So the bed capacity also wears in the healthcare worker, hence compromising the IPC and hence the misuse of antimicrobials. Because if we don't actually observe the infection prevention and control, we'll end up abusing, and we'll end up even cross-infecting the patients, and they'll get healthcare associated infections. So these are some of the activities that are completed. We have implementation of national IPC strategy. We have our strategy, and we have revised it. This is our second edition. So we are having the one for 2021 to 2023. That's the current one in place. Then we have for the national guidelines that are there, and the policy. The policy actually gives a way of how the structures should be informed from the national to the counties in Kenya government. We have managed to have 15 counties who have CPCAC. CPCAC is the County Infection Prevention and Control Advisory Committees in place, and they are operational. We also have 47 IPC coordinators. I don't know whether I should thank COVID or what I would say, but at least we saw this action very well during the the onset of the pandemic, and this one has done so well, so that at least we are able to communicate. I had mentioned about the M&E, IPC M&E framework, which is also in place, and we have started implementing it in the 4 counties that are doing the pilot. The capacity building, you can see, this is a continuation that without capacity building, will not be able to update. And we normally capacity build our healthcare workers as per the new guidelines, and also as per the basic COVID-19, we also developed a training, which was also based on IPC, and it was critical for us to be able to advise and to be able to chart a way forward for the country. We also have an ECO IPC platform that the IPC coordinators and anyone who deals with infection prevention and control, they meet every 2 weeks, and different topics are also discussed. The strengthening of standard of practice. These are the standards that we have incorporated into the accreditation and the quality assurance standard, and the joint health inspections. We've discovered that they are quite key and critical for us to be able to continue, so that once our inspectors go to inspect the healthcare facilities, they are able to see whether we have the standard in place for IPC. For those are 2 pictorials. The one is at Ramu. We are actually having a training, and the other one is at Vika, where they were doing a CQI project on IPC. For the animal health, they haven't been left behind. Infection prevention and control, it has also been quite key and critical, that strengthening hygiene and food safety measures in food value chains and the environment is quite key, and they have sensitized national government personnel, food hygiene, existing standard guidelines and regulations. And they also developed farm biosecurity guidelines for dairy, poultry, and big value chains, high risk food value chains with the high AMU use. So, and they also trained the public and private sector personnel on the hazard analysis critical control points in meat processing and the dairy processing establishment. And you can see in those, that is a poultry farm and biorisk in the lab has also been actually observed. So infection prevention and control ongoing and planned. We'll continue advocating for more counties to have the IPC structures because IPC is not a single-handed. We really require that IPC and we need the program to be running in place so that at least we can have the county being responsible for their own IPC programs. Finalization of the healthcare associated surveillance guidelines. These are in place and they're in draft. This is a way that will give us a way of actually be able to observe and be able to monitor how many of our patients are acquiring healthcare associated infections. So these guidelines are critical and I'm hoping that they will be revised before we observe the WOW week. Establishment of a healthcare system is quite key and this one is already done, so it is in pilot. Then integration of IPC content into the e-learning modules. This is also ongoing. And then we need to identify and promote use of rapid test kit for hygiene surveillance in food establishment. And I'm sure this is also ongoing. Then we need to sensitize of food industry personnel on food hygiene, existing standard guidelines and regulations. And we also need to strengthen the use of vaccination in animal and health sector. Then last but not least, we also need to develop and disseminate national vaccine schedules as a way of utilizing vaccines in reducing the animal infections. I think that's the end. Thanks so much for listening.
Now, she's saying she has to prevent infection from passing from me to her. She's a champion on IPC, and I think you've appreciated what they've been able to do. And I think this, going forward, there's quite a bit that will have to be undertaken. I just want to call upon Dr. Karim Wanga, to take us through the strategic objective 4, optimized use of antimicrobials in human and animal health. This, once we are through with this, we'll take a tea break. And then when we resume, we'll do a short plenary session. Thank you. Karim is with the Pharmacy and Poisons Board. He's the one leading the TWG on optimizing use of antimicrobials. Thank you. Karibu, Bwana Wanga.
Good morning. As you've heard from Dr. Azegele, my name's Karim Wanga. I am a regulatory officer and scientist within the Pharmacy and Poisons Board. And I work in the Department of Product Safety. PPB has many departments, and I'm based at Product Safety. So I'll look at the objective, strategic objective 4, which is appropriate use of antimicrobials. I know all of us at one point or another have either visited a doctor or even went to the counter, one of those pharmacies, either downtown or uptown, and asked for an antimicrobial. So the question you need to ask yourself, when you use that antibiotic, antifungal, antiviral, was it appropriate or was it not appropriate? So in this area, we have several strategies, and one of the strategies is actually to develop guidance and policy documents to be able to provide the guidance or policy direction on how to carry out intervention to promote optimal and appropriate utilization of antimicrobials. So in view of that, we have been able to develop quite a number of policy documents. One of them is National Antimicrobial Stewardship Guidelines for healthcare settings. Also, guideline for prudent use of antimicrobials in animals, antimicrobial use protocols in animal health, the clinician's handbook on diagnostic stewardship. The Kenya Essential Medicine List of 2019 has now incorporated and integrated the AWARE classification, that is access, watch, and reserve within the categorization of the medicines on the essential list. And we have the National Integrated Antimicrobial Stewardship Plan. So those are some of the policy documents that we have developed, of course, to guide the sectors on how to carry out interventions to ensure appropriateness of use of these very valuable products. It looks like a slide I'm missing. Okay. So what are some of the stewardship programs that we have been able to develop and implement? One of the programs includes the Antimicrobial Stewardship Training Program, both basic and advanced. And this is targeted at both pre-service and in-service. Capacity building of healthcare professional workers, which include training and mentorship. Sensitization of county and sub-county leadership on areas of antimicrobial stewardship and AMR in general. And all level 6 healthcare facilities and about 30% of county referral facilities at level 5 have already established antimicrobial stewardship programs. Some of them as subcommittees within their medicines and therapeutics committees. The other key area is strengthening of regulation and monitoring of consumption and use of antimicrobials. So Pharmacy and Poisons Board had been able to issue some regulatory advisory to healthcare professionals on appropriate use of antimicrobials. And one of the pictorials actually is one of the regulatory advisory that has been issued in the past, targeting both healthcare workers and the public. Of course, discouraging the issue of self-medication, over-the-counter access of antimicrobials, and ensuring that healthcare professionals actually follow the law and the regulations that are available on the use of antimicrobials, which are classified as Part 1 poisons, basically meaning you need a prescription to be able to access these products, these valuable products. Again, we have developed an M&E system for reporting prescribing practices by healthcare facilities. Also been able to carry out point prevalence surveys to be able to check patient level and at facility level, what are the prescribing patterns? What are the indications for the antimicrobials? Is there utilization of culture and sensitivity, and so on? Again, around regulation, recently, we're happy to report we have enactment of some new rules, pharmacovigilance and post-marketing surveillance rules. Within these rules, now it is required that downstream, so downstream, I mean distributors, wholesalers, retailers, and healthcare facilities, and even local manufacturers are now required to share data, both supply data to the market, consumption data, and use data. And you know what rules mean? It means they are enforceable. So, and also the rules say the Ministry of Health, together with Pharmacy and Poisons Board, will prescribe a system of reporting of this data. So in future, once we have been able to sensitize the stakeholders we are going to be sitting together to be able to establish a system to ensure that we pull data from the downstream facilities. So for both use and consumption. So some work has gone into estimation of national level consumption of antimicrobials. This work was guided by the WHO AMC methodology, focusing on import data. What has been finalized is what we call J01, anti-infectiveness for systemic use. Specifically, we have other different categories that have been looked at, but not finalized. Looked at consumption between 2018 and 2021, again, focused on import data and some sub-analysis to check the results. A quick view of the results is that in summary, we have a measurement unit or a matrix we call DID. DID is the DDDs that are consumed or defined daily doses that are consumed per 1,000 inhabitants per year. So that is a measurement, is a standardized metrics that is used at a global level to be able to measure consumption. So from this study or from this survey that 2018 for import data, we have 63.63 DID. And going down to 2021, where it is 17.66 DID. In total, 121 DID for the period of 4 years. And that has also been disaggregated in terms of oral and parenteral consumption. But then again, you can only make sense of this data if you compare ourselves with other countries with similar population, around 50 million, to see whether we are consuming more, consuming less, and even down to the molecules and pharmacological classes themselves. So you can see there is downward trend, but we are still exploring this data. It's not final, because we are looking what could be the factors that might have contributed to that dip in consumption. Of course, considering we had that disruption of supply chain during the COVID-19 pandemic and many other factors that have come to play. But again, we are saying this is very preliminary. We should be able to explore further and see what could be the issues around those trends. It's very early for us to celebrate to say that our consumption is going down. It's just to be cautious. So again, as you can see, that just tells us in terms of parenteral and oral, what are the percentages? I'll just look at 2021. Our oral consumption was 73.36%, and our parenteral was 28.64%. So, which is good, but you can see we actually from 2020, it shows 2021, we have a higher percentage of parenteral as compared to 2020. And I think best practice is we need to use as less as possible of parenterals and maybe more of oral formulations. I'll not go into very details of these, but in terms of aware categorization, where we have access, watch, and reserve, our topmost aware antibiotic is overally, and this is overally. If you go into the years, it will be different, but generally from 2018 to 2021, the topmost is amoxicillin. It's the top access antibiotic. In terms of watch, again, the topmost is ceftriaxone. And in terms of reserve, the topmost at 2 is linezolid and minocycline. So again, as I've said, this is import data. And remember, Kenya, we consume 70% of our consumption is import, and then 30% is locally manufactured. So we're yet to explore the data from local manufacturers, but there's a plan to be able to get that data, and then holistically we'll be able to look at the picture. But that is the preliminary finding. So we have drug utilization, the topmost 75% drug or antimicrobial utilized in the country. Again, you can see among the top 75% or among the 75% drug utilization, DU75, we have amoxicillin, azithromycin, amoxicillin beta-lactamase inhibitor, cefuroxime and doxycycline for oral formulations. And then for parenteral, we have benzyl penicillin and ceftriaxone. So these molecules, as we mentioned them, we should be thinking, obviously they are the highest drivers of our consumption. And if you triangulate this data with the resistant patterns, then you should start seeing something that is happening around these molecules. I'll not go into very deeper details of the subgroup classification at ATC3. I think I'll classify that. But in terms of the top 10, again, most consumed antimicrobials, we have a mix of both access, watch, and some uncategorized. And we really need to review this group of uncategorized, meaning we have some combinations of the market that are not categorized within the AWARE WHO classification. So basically, maybe not recommended combinations. And maybe even at regulator level, we need to see, do we really need to register or allow these products on our Kenyan market? But of course, again, top on the list is amoxicillin, benzyl penicillin, ceftriaxone, coming down to doxycycline and levofloxacin. I'll have to skip some slides because I think in interest of time, but we're able to also now on the issue of essential medicine list, we realize there's quite a number of antimicrobials that are not on the Kenya essential medicine list, and they are also not on the WHO essential medicine list, and yet they are on in our market, they're in circulation and they're being imported into the country. So those, I think, at MTC level in MOH, we should be able to discuss and see, are these products, do we need them in this country? Do they have indication? And if they don't have indication, I think that's a very low hanging fruit that we can be able to make intervention to actually stop and restrict import of those products into the country. So for point prevalence survey, again, we had several facilities that participated in PPS. The list is there, KNH, GOTRH, MTRH, and other facilities. In terms of results, so a point prevalence survey is a snapshot of use of antimicrobials in the clinical areas in a facility, inpatient. And you go in on that day, collect data on that day, and finish your survey on that day. So based on these findings, it just shows that around about 50% of patients who are in those clinical areas, on the day the survey was done, had been put on an antimicrobial agent, around about 50%, which is, if you ask me, is quite high. Again, I've just picked out some results for the two facilities. At KNH, one of the most used antimicrobial from that survey was ceftriaxone. Has the highest bar. And then for GOTRH, again, the highest is ceftriaxone. Yes, so you can see ceftriaxone is, yeah. For results, again, it also found, this survey found that for all the facilities that participated, we had patients who had missed their doses. Because one of the PPS, one of the things you want to look at, you'll want to see, it was indicated the doctor had prescribed, but they did not receive the dose as when they were supposed to receive their doses. So we have some missed doses, and we have some facilities had a big number of patients who had missed their doses for one reason or another, and others had fewer patients who had missed their doses. Again, utilization of culture sensitivity, we realized we had many patients in the ward, but just about, for some facilities, around 20% only had utilized culture sensitivity. For another facility, only 3% had used culture sensitivity, despite the fact that quite a big population or a big percentage of these patients had actually been put on antimicrobials or they were receiving antimicrobial treatment. So that means a lot of empirical prescribing within our healthcare settings. So I shift a bit from use and consumption to monitoring. Also, what I do in PPB is quality monitoring of products on the market, including antimicrobials. And recently, we have been very deliberate to ensure we have antimicrobials among the list of products that we're able to sample and test. And some of the molecules we have sampled include azithromycin, metronidazole, gentamicin, ceftriaxone, and benzylpenicillin. And we're happy to report that from the samples we have been able to collect from 2021 and be able to test, the compliance has been 100%. But that does not mean that we're gonna sit back and say, we're okay, we continue sampling and testing. Because you can easily say there's resistance if your product does not have doesn't meet the specification in terms of content of the active ingredient. So it's very key that our products, our antimicrobials, actually meet the specifications in terms of the active ingredient that they have. So that is from market surveillance to check quality of the antimicrobial circulating on Kenyan market. Quickly for animal, again, we have a number of, the report on terms of quantities of antibiotics imported in terms of kilograms. You realize that regulation of medicines for animal health is done by veterinary medicines department, and for human health is by Pharmacy and Poisons Board. So this report is from veterinary medicine department, and those are the quantities of imports of antimicrobials into the country for animal sector. Again, also the monthly quantity of antibiotic sales at retailer level, survey being done to just check the quantities in kilograms that have been sold at retailer levels for use in animal sector. And that's just a nice picture. And then poultry sector, again, the single antibiotic preparation commonly used in the poultry sector, and combination antibiotics that are commonly used in the poultry sector. So I'll quickly go to next ongoing and planned. We plan to establish, or rather continue the work on establishing central level database for import of antimicrobials and also locally manufactured, so that we're able to monitor over time what is consumption. And those of you who might be in the space, you are aware that consumption drives resistance. So it's very important for us to measure consumption to be able to see the trends. And going down to molecule level and pharmacological classes. Establish central antimicrobial consumption surveillance system. Again, the rules have been established, and now we have the policy direction to start setting up systems to be able to collect this data. Hospitals need to establish and operationalize antimicrobial stewardship programs in committees. And of course, they need the support of the management and all the facilities as well. Legislation and regulation, AMU, and also AMC, compliance to prudent use of antimicrobials. Very soon we shall be, at PPB, we shall be carrying out AMR-focused inspections at retail level, retail pharmacies, just to check compliance with the available laws and regulations. And then, of course, the review of standard treatment guidelines for infectious diseases, advocacy, and collaboration. So quite a lot of work that remains ahead of us. So I think that should be the end of my presentation. Thank you, and look forward to collaboration.
Hey, thank you very much, Karim.
You want to greet me because we have said IPC should be.
No.
Oh, vaccines are working.
We are all, don't you trust them?
They are working.
Good. Thank you very much. I think that's a clear snapshot of where we are at, and the kind of work we've put into trying to bring out the information over the last 5 years. It was heavy on the, if you noticed with the hospitals, where quite a bit of point prevalence surveys have been undertaken. The other survey that was done within the animal health sector, it's quite some voluminous report, which is available, but I think with time we'll keep extracting and sharing as we go on. And then also moving forward, we also hope to undertake another round of surveys in both sectors so that we are clear with how we are consuming these antimicrobials. So as I promised you, we'll break off now, more so for about 20 minutes. I don't know whether you'll be able to get a cup of tea within that time. And then we congregate here at around 20 past 11. And then we go through the session, and I hope our executives from the ministry will be here so that we go through the next session. So you're free to have a cup of tea, and then we resume at 11:20. Thank you. Yeah. Thank you for your patience. Ladies and gentlemen, I'd want to recognize the arrival and the presence of the Chief Administrative Secretary, Ministry of Health, Dr. Rashid Aman. Welcome, sir. And the presence and arrival of the Principal Secretary, State Department of Livestock, Harry Kimtai. Welcome. Yeah, now, Chief Guest, we have been through a brief session in the morning, and we have been able to share a brief and feedback to our stakeholders here who have been a major part of our journey in implementing the National Action Plan and giving feedback on the progress, the bit of the challenges we've experienced, and also pending activities. As we move forward, we will also be able to show the scorecard, where we know whether we made it, we didn't, or we are still also struggling to proceed. Before you in this room, we have teams from the national government, and I think just to quickly recognize them, the team from the national government agencies could you just stand and yeah, and we acknowledge you. Just before I proceed, I also just remembered I had recognized the presence of the Director General, Ministry of Health, Dr. Amoth. So for those who don't know Dr. Amoth, he's here with us. I know he was very popular during the Corona time. And his voice every evening was ringing in our heads. Yeah. Now, I also want to have the teams from the counties who have been on the forefront of implementing the National Action Plan. Could you stand to be recognized by our guests? The county teams, we've been able to mobilize quite some teams from the counties. Thank you very much. Yeah, I also want to recognize our partners from the pharmaceutical industry who have been very much supportive. Although we insist we don't want to use antimicrobials, but I mean, because they'll have less sales, but they also recognize the importance of making sure that what they produce can be used for longer. Could you just stand so that we can recognize you, all the teams from the pharmaceutical industry? Biomiriu, I thought they were here, and the rest. Oh, diagnostics. Oh yeah, that whole team. Yeah. Yes, and then also we have our partners from civil society and also non-governmental organizations who are present here. Could you please stand so that we can recognize you? Yeah, these all teams have been very instrumental in working together, and the NASIC Secretariat can tell you how challenging it is to coordinate these teams. Yeah, is there any group I've not been able to recognize? Sponsors. The term sponsor is not very good. Eh? We usually do not like using that sponsor or donor. Okay. Thank you for making time to come. I'd want to move straight to the program. I'll want to invite Dr. Evelyn Wesangula to take us through the scorecard of our performance in the last 5 years. Karibu sana Daktari. Evelyn is the focal point person for AMR. She's the Ministry of Health. She has been a great champion and also a big motivator to a huge number of our young teams and she's been able to mentor them into this space. And she's very well known across the world, not just here. Thank you and welcome, Evelyn.
Thank you very much, Dr. Zegele, and big appreciation to our leadership that's here in this room today, led by our Chief Administrative Secretary, Dr. Rashid Aman, our PS, State Department of Livestock, our Director General, Dr. Patrick Amoth, our Head of Directorate, Dr. Simon Kibias, and Dr. Soti. If it was not for your leadership and allowing us this space, we probably would not be gathered in this place today, talking about the progress that we've made over the last 5 years. Your leadership has really motivated our work a lot, and that's given us the room to be able to implement the action plan and the policy that we set out to develop 5 years ago. So over the next couple of minutes, I just want to run us through the scorecard. Where do we think we are after 5 years? And hopefully that will set the stage for us to discuss our next steps. We have learned a lot because it was the first time we were developing an antimicrobial resistance policy from a multi-sectoral perspective. We had to start somewhere in terms of developing a blueprint for the country. And then secondly, starting the implementation. And now we are measuring our progress 5 years later. And that's what I'd like to share with us this morning. So it will just be a brief overview on how we've been able to work around it, definitely reading from the monitoring and evaluation framework. And I must say, the M&E framework came in about 2.5 years after the plan had been developed. So you can imagine how the team was trying to work backwards and forwards at the same time. But all the same, we had a document that has guided our evaluation in terms of performance. So it's a puzzle. And why do we say the monitoring, evaluation, accountability, and learning process is a puzzle? It's because of the multiplicity of interventions that are expected, the multiple layers of strategies, plans, policies, guidelines that were developed within one action plan. It was not a clear action plan in the sense that it's a sector-specific plan. That's a bit easier to implement. But when you have a plan that cuts across sectors and disciplines, the monitoring of that plan becomes more complex. So we also realize that monitoring our implementation across the 5 objective areas was critical for our program's success. So we needed to find a way of aligning each of these moving pieces of the puzzle. Because if we missed one, like we're going to see, some were missed, then we find that our work or our picture is actually not complete. So the journey of tracking our performance actually started in 2016, 2017, when the tripartite, then the WHO, FAO, and OIE, before they changed the name to the World Organization of Animal Health, began to document progress that countries have made over the first year of either developing their action plan and then after implementing. And as you can see, in 2017, we had a C. That meant that at a country level, we had developed our national action plan in November of 2017. We have been consistent in terms of completing our annual performance at a global level. And by 2017, 2018, we had moved to D, where our national action plan had been approved by the government. And it also reflected the global action plan objectives at that point. We had an operational plan and had monitoring arrangements. And I think the keyword here is monitoring arrangements. When we completed this tracks assessment last year, and we do it jointly, we had moved to D, where we said the National Action Plan has funding sources identified. And I think Dr. Zegele and I kept arguing, do we have funding sources identified? It was not specific to say whether or not it was government funding or it was development partner funding. As long as you had identified the funding sources, yes. Was it being implemented? It was a yes. Did we have the relevant sectors involved and a defined M&E process in place? So we scored an E. But by the end of the presentation, I know it is an E with a lot of room for improvement still. So that was the journey. And this is the document that has guided our reporting at the end of every year. And we keep checking our performance across different countries. And as you can see, we are now also beginning to look at countries that have developed action plans. And apart from developing these action plans, are actually funding these action plans, because we know having a plan is one thing, implementation requires funding. And you can see the number of countries that actually have NAPs that are funded are very few. So that means many countries are still struggling to try and implement their action plans. How are we faring with respect to the rest of our neighbors? It's good to know, because it also motivates us, it challenges us to do better. And you can see a lot of the countries around us are green. Some have not developed their action plans. Those that are in red, and there are some where information is not available, meaning they probably did not participate in this tracking assessment. So these are our action plan objectives. I think we have sung about this the whole morning: to increase awareness, to strengthen our surveillance and monitoring system, to strengthen our infection prevention and control processes, to make sure or strengthen appropriate use of antimicrobial agents, and also enhance research and development in the area of antimicrobial resistance. And these objective areas actually cut across all the sectors. Again, in 2017, we undertook the joint external evaluation to identify our country capacities and also conduct a gap analysis to find out where we are. And this all formed part of our situation analysis. And I put this here because now I know we have a new joint external evaluation tool and would like to carry out an in-country assessment to see how we measure up against where we were in 2017. And you can see a lot of our scores were 2. That meant that we had limited capacity to conduct AMR detection, surveillance of infections caused by antimicrobial resistant organisms, healthcare-associated infections. At that point, we scored a 3, some form of capacity because our infection prevention and control program at a national level was there earlier, and it's as old as 10 years. And in terms of antimicrobial stewardship activities, we also had very limited capacities. I think at that point, we only had about 3 hospitals that had reported to have antimicrobial stewardship programs in place. We looked at the implementation stages, and it's been a journey trying to understand the multiple sector requirements, the expectations, and gauging this against reality, like availability of resources, not just the funding, but even human resources. And I think where we are at now is between initial implementation and the full implementation, where we had to do a lot of adjustments in terms of looking at the drivers, managing change over the last 5 years, deploying data systems like we saw in the morning. A lot of data systems have been deployed, and also working on our improvement cycles, knowing where our gaps are and strengthening that. So as we worked on our M&E framework, we asked ourselves several questions. Where do we want to go as a country? And what is our driving motivation? What's our reason? What kind of results do we want to see at the end of a 5-year, 10-year process? And what do we need to do to get there? I think when we started developing the NAP 5 years ago, we probably didn't have a lot of these questions clear in our minds compared to what it is right now. There was a big urgency to have an initial blueprint, but I think by having that, it has actually helped refine our thoughts much better. So right through the pandemic response, we were able to develop an M&E framework, and we were also able to leverage the COVID-19 response funding. So that was a good thing that happened to strengthen our common data management systems, develop our indicator manuals, look at our tools and our registers, and also try to customize some of the indicators that we want to monitor into the Kenya Health Information System. So I go straight to the first outcome. And if you look at this particular outcome, we had some scores that were noted. The color yellow says this activity is ongoing. Green means that that has been completed, and yellow, if you see a red, that means that activity was not done at all. So we try to look at this across the human and animal health component, and a lot of our information going forward is going to touch on human and animal health because we realized the environment in our first NAP was not very prominent in terms of the work that needs to be done around that. So you can see the blue bars probably on your left or on your right, talk about or try to show what was completed within the health sector and what was completed within the animal health sector. And this makes reference to a number of indicators. So in total, our M&E framework had 91 indicators. And we thought our national action plan was overly ambitious in the first place. 91 indicators and over 150 activities that the national team needed to have done over the last 5 years, not putting into consideration probably the challenges that have been there. So you can see in terms of awareness, a lot of groundwork was done, development of systems, sensitizing different target audiences to be able to take their place. And I'm sure once in a while you see an article on antimicrobial resistance in the papers, or you have a TV interview with one of the professionals or health experts talking about AMR. We've had IC materials developed, and we had a strategy that we developed in our second year of implementing the NAP to guide our discussions. And every year from 2014, we have consistently held the World Antimicrobial Awareness Week, which has actually led to an increase in terms of raising visibility. And we've also carried out surveys among the general public through the support of the UN's DGs, the Sustainable Development Goals, and Africa Voices. We engaged communities just to hear what they have to say about some of the solutions that we are proposing. And we realize sometimes our solutions actually lie with the public. They have the answers. We don't always have everything that is required to be done. In terms of outcome 2, which focused on surveillance, one of our critical areas of implementation was the establishment of a joint National Reference Center for Antimicrobial Resistance. Over the first 5 years, we've been building this surveillance system. We identified the central data warehouse, which is situated within the National Public Health Laboratories. And independently, the National Microbiology Reference Lab and the Central Vet Investigation Labs have lab information management systems that are collecting data from the different sectors. So that has been successfully done. We've been able to now start monitoring the prevalence of AMR in selected priority pathogens, both across the human and animal health sector. And again, now we have sites that are now linked to the central data warehouse where we can be able to monitor their activities real time. You can see a red, and we argued about the red and asked ourselves that this is something that warrants a red or a yellow. And we say the AMR research agenda has actually not been established at a national level. Yes, we have a lot of research that's been conducted, but who's guiding the researchers? And for us, that's a point to note in terms of action. So that's how our surveillance and monitoring system is structured. Our central data warehouse, like I've said, is housed within the National Public Health Labs. We are able to generate human health reports and animal health reports. And now working on, we actually already have an integrated dashboard. If you go to what we call the AMR One Health surveillance system, you can actually access both data from human health and animal health. And maybe later on in the course of the day, we can avail the link and we can allow maybe colleagues just to see, but it's still work in progress. And because of that integrated surveillance, now we are able to compare what's happening in human and animal health. We identified 2 priority pathogens that we want to monitor across the human and animal health sector, and that's E. coli and Staph aureus. So once we see this data coming into the system, then we're able to look at the antibiotics in terms of the molecules that are being used in human health and those that are being used in animal health, and begin to make meaningful analysis and see how this is going to impact on the development of guidelines for treatment, and even if we require regulatory restrictions or regulatory advice on what needs to be stocked for human and animal health, we will be doing this from a point of evidence. So surveillance is up and running, but of course not to the point that we wanted it. We had hoped to have 28 sites by the end of 2022, but we are at the 20 mark because of challenges, especially due to resources. We've not been able to get to 28 sites. Outcome 3 focuses on infection prevention and control. A lot of work has also been done in this area, a lot of progress done. Like I said, for the health sector, this is an independent program within the Ministry of Health that has been in existence with complete with a strategy, a policy, guidelines, training, like a training plan. So this is work that has been ongoing, and a lot of the work that we had intended to do under the action plan for AMR on IPC were actually accomplished. But it is one thing to have standards, but in terms of implementation, as you can see from the scores, which we actually conducted an assessment across all the counties in 2021, the performance is still below par. We have only about 2 counties that were at the 80% mark, and you can see some counties were way below 50% in terms of uptake of the infection prevention and control recommendations and their implementation. But we are trying to strengthen that. So we've now developed a national reporting system that will require us to track action on IPC at the facility level and AMR. So we've integrated this and customized our indicators into the Kenya Health Information System to help us monitor across and reach as many healthcare facilities as possible. For animal health, we've put measures in place for hygiene and food safety across the food value chains and also within the environment. These have been strengthened because now we've been able to develop these guidelines and begin the dissemination. and also made hygiene and IPC as a core component of training, registration, and even CPD provision for vet professionals, which I think is a good thing for sustainability and just to further the information. So in terms of those that are aware, you can see this is work in progress. And like I said, every day in this space is a learning day. The national vaccination schedules, however, have not been developed. So for us as a team, this is still another area where we need to take action. Outcome 4 targets the use of antimicrobial agents, both in human and in animal health. And you can see this is one of the areas that we have the biggest challenge. Actually, the bulk of the work in the action plan falls under outcome 4, appropriate use of antimicrobial agents. When we reflect on our regulatory processes, the enforcement, the access, whether it is regulated or unregulated, we all understand the challenge that we face as a country. Yes, we have the guidelines in place. The law is clear that antibiotics are prescription-only medicines, but the enforcement has been a challenge. And even as we go into our next phase of the action plan and policy, I think it would be good to hear from us. How do we want to actually enforce this? Because the review of these policies and dissemination has been done over time, but it's about change of practice, it's about change of attitude, and I think behavior as well. So we are implementing the antimicrobial stewardship guidelines. We have a task to map human resources, because as we carry out this work, we realize sometimes the person who's behind the counter is not authorized to handle the poisons. So we need to map the human resources and also ensure that the necessary human resources with the requisite expertise are deployed to where they are required to be. Quality control has been strengthened through the NQCL and also the Pharmacy and Poisons Board through pharmacovigilance and post-market surveillance. We are able now to get reports of the quality of antimicrobials, and we see recall reports every other time. And when this is happening, then we know that this work is going on. And then again, in terms of building capacity for staff to support prudent use again in animal health is something that we need to look at. We looked at some of these results in the morning, which I think were very interesting with respect to what our top 5 antibiotics are. What are we using or what are we consuming as a country? And you can see for access, the WHO recommends that we classify our antibiotics into 3: access, watch, and reserve. And we encourage the country and all practitioners to use the access category of antibiotics as much as possible and keep for another day the watch and the reserve because of their capacity to quickly develop resistance. So you can see in terms of our access antibiotics, amoxicillin is leading. And then for watch antibiotics, ceftriaxone. And from the data we saw in the morning, whether it was a point prevalence survey or it was a national consumption, ceftriaxone was leading in every hospital where we have done a survey. And I think that's a point of concern for us as a country, because the guidelines actually don't recommend the use of ceftriaxone for some of the indications that it's being used for. And then you can see the reserve antibiotics. We try to reduce or minimize the use of these drugs as much as we can. So looking at the consumption and what we are calling the drug resistance index, where are we? Our drug resistance index, which combines the consumption levels and the resistance levels we are seeing, are putting us at 56.2. That means we are not doing well. The higher the drug resistance index, the higher the low level of antibiotic effectiveness, meaning the higher the chances of us as a country running out of options to treat very common infections. Actually, a report that was released early this year pointed out that 1 in 5 of children under 5 are dying of infections that were previously treatable. So you can see if our drug resistance is moving towards 100, then that definitely shows that we're not in a good place. And there's a direct correlation between consumption and the increase in resistance. And this applies both to human and animal health. Outcome 5, you can see completed is like 0. As a secretariat, like we said, we are concerned because we've not been able to fully engage on this specific agenda to create a research agenda for AMR at a national level to guide the questions that need to be answered that will be of benefit to the country. So we recognize that we actually have a lot of work to do. And key in this particular outcome, because he talks about building a case for investment, our financial security plan is not well developed. In the event that we don't have developing partners investing in this particular aspect, what will happen to the implementation of the action plan? So this is just a summary. And you can see about 30% was not accomplished from the National Action Plan. What we were able to fully achieve is about that. The bulk of the work is still ongoing, and this is out of the 91 indicators that we had done. So that's just again an illustration of what we have been able to achieve across the different objective areas. And we tried to cost what it looks like to finance the action plan. It was coming to about 8 billion, 8.6, that's like 9 billion. Actually, the cost of just setting up a surveillance lab from scratch when we did the initial costing at the beginning of the plan was coming to about 80 to 90 million, equipping it, reagents, capacity building. So probably when we review the plan, the figures might go higher because we now know what else needs to be done. And over the last 2 years, if we try to quantify what the partners have put in plus the government, we have about 2 million, and everything that has been done within that margin. And then the gap of 6 million, meaning that probably if we had it, we probably would have achieved more than what we achieved. So what went well? There was a lot of participation and visibility at the national, regional, and global AMR events by the team that serves here. We had a country situation analysis actually on 2 occasions that gave us a good baseline where we could start. We also had a good policy environment, and I started by appreciating our leadership because they enabled us to go out and have this done. And we had focal points, so coordination was actually a good, happened in an effective manner. And we had very strong interministerial coordination, at least between the Ministry of Health and the Ministry of Agriculture and Livestock. We had very good coordination. We were able to define the roles and who is the host of the Joint Secretariat, which is a Ministry of Health. So we didn't have a lot of issues, and the roles and responsibilities of each sector and partners were clearly spelled out in the action plan. And we had good collaboration. We developed a lot of the strategies that were guiding the initial work, and we continued to engage the stakeholders. And the COVID pandemic had a silver lining because it raised visibility for IPC and AMR. We have a lot of areas that require improvement. One is incorporating the environmental dimensions. We now understand just how critical that dimension is in the ecosystem. We need to cost our action plan from the beginning. I think that is something that we've learned, and also make one that is realistic. And the review of the NAP and the M&E framework must be done concurrently. And then there's a place of dissemination. We wish we would have reached all the 47 counties. So how do we make our dissemination process more effective than it was in the previous phase? And again, the funding, there's so much that the national government can do, but what about the role of the county governments taking this up and funding their action plans for implementation? And then how do we sustain leadership and commitment? Of course, we also realize that apart from the 5 objective areas, our work would not be complete without a strong communication arm, strong IT support. You're talking about data. We didn't think about support units like IT and M&E. We've realized later on in the process just how critical it is to have this on board at the beginning. And I've already talked about the research agenda. So this is really my last slide. A key takeaway from where we sit, we have definitely made progress. But what we know, and I know many of you will also agree with us, is that more needs to be done. There is a reality because we have evidence that now AMR is a leading cause of death, higher than HIV, AIDS, and malaria. It's urgent because unfortunately AMR doesn't parade itself, so it is that silent pandemic that creeps through our system. It's very relevant, and again, most importantly, it's preventable if our actions can be well coordinated. I want to recognize the support we've received from many of our partners. Maybe not all of them are here. These are just a few of those that have continued to support our work. We appreciate the work. We appreciate the commitment that has been shown over the years. Thank you very much. And I hand over to Alan.
Thank you very much, Evelyn. That's actually the scorecard of our work in the last 5 years. And I think we've tried to condense it as much as we could, because if we were to go into details, I think we need 2 weeks and a half. It's been quite a journey, and I hope going forward we'll be able to achieve more. At this point, I know there could be many questions guys have come up with. Let's just keep them. We'll have a session much later to discuss further on this. In the interest of time and being able to engage much more, we have our partners we've been working with, who we have listed to speak, but I'm aware some may not be around or within, but I will be keen to call upon representatives from our partners. All of you have been a part of the process, but we just want to pick on a few so that we can have their testimonies. Do we have a representative from USAID? Or yeah, we have Kusu from MTAPS. Welcome. Thank you. Welcome.
Thank you very much, Dr. Segele. The Chief Administrative Secretary, Dr. Rashid Aman, the Director General, Dr. Amoth, the PS, State Department of Livestock, Dr. Kim Tai, other senior officials from the Ministry of Health, Ministry of Agriculture, development partners, implementing partners, stakeholders, AMR stakeholders from national level, from county level, and even the private sector, all protocols observed. I'm just going to give a few remarks on behalf of Dr. Andrew Thaya and also the USAID MTAPS program. I pass his apologies and convey his greetings. He's not able to join us today because he's on work travel, but USAID has been able to support the implementation of the National Action Plan through different partners, and they are in the room. I would like to request them to just stand up because they are supporting different objectives. IDDS, FAO, AfroHoon, and also now my program, the USAID MTAPS, and will continue to support containment of AMR across those different objectives at national level and in their focus counties. You may see it. And so I'll just give a few quick remarks on what USAID MTAPS is doing. We've been supporting containment of AMR since 2019 in the areas of multi-sectoral coordination and microbial stewardship and infection prevention control, focusing on the human health. And we've had a focus in 4 counties where we are supporting antimicrobial stewardship in 23 facilities. That includes the Kenyatta National Hospital and the Gertrude, and then 20 facilities for infection prevention and control. And over the time, we've also been able to just quickly leverage COVID-19 funding to also continue to support infection prevention and control. We have been honored really to support the Secretariat and all the AMR Secretariat, all the AMR stakeholders under the able leadership of the One Health team that is in the room to achieve some of the things that are being highlighted. Just to mention, like under the multi-sectoral coordination, MTAPS was able to support the MNE framework, and IMS really support for the review of the Kenya Essential Medicine List classified by AWARE, and we want to pledge that we will also be able to support the review going forward. That's to just mention, but a few. I really want to congratulate the country for the milestones achieved so far. And even as we look at the scorecard, we should be able to use that to guide the review going forward. Thank you. And back to you, Dr. Zegele.
Thank you, Dr. Kusu. You could give another round of applause. Next, I would want to have a representative from the Center for Disease Control, CDC. Dr. Linus, is he present? Yes. Karibu sana. Ngumi ama
Good morning. Thank you for this opportunity, and thank you, Dr. Aman, Chief and Chief Secretary, Director General, PS, and all partners, and all protocol observed. As you've heard, Dr. Linus, working with CDC, I lead IPC and AMR activities here in Kenya. And really this is a great opportunity for us to review the past activities that AMR has been doing. For CDC, we really feel privileged because CDC through GHSA was able to support the ministry to actually start up the AMR and IPC program here in Kenya. And we are really excited to see the growth and what has really happened. As you know, CDC main objective is really helping and supporting countries. And under GHSA, we've been doing that in several other countries, including Kenya. And for Kenya, main things is working with various partners who I think they are also here in the house. The partners that we work with in this arena, ITEC, WSU, we really recognize the work that you do. Now, one of the things that I would say that apart from really helping and establishing the AMR activities, part of the work that we've done is capacity building, creating sustainable programs like having the antibiogram that the AMR surveillance is using so that data can be collated and be shared out with other various stakeholders, supporting the use, the strategic plan, and more so in the building capacity for the lab. And of recent, really we want to thank the ministry. We've been working closely with the ministry to have that National Public Health Institute, which we hope that will be able to replica of CDC, US CDC, and support many other activities like AMR surveillance and including the microbiology labs, which really helps us to categorize and be able to inform the clinicians in terms of how the antibiotics should be used. Apart from that, we've been supporting the vet lab, and I think in the month of May, our director was there to add over some of the equipment to the vet lab so that they can be able to diagnose and really do the culture and sensitivity for various organisms. Currently, we also are working with the ministry in various counties in doing surveillance for acute febrile illnesses so that we are able to inform what propagates the ideas of, issuing out antibiotics. Working with our partners, we are establishing the HAI surveillance in 4 counties, and continuing with as the data have been shared this morning about point prevalence survey for antimicrobial. And more so, we also working with other partners supporting the ministry on antimicrobial resistance in communities and in the hospitals. We currently are trying to establish and gather data that can inform in policy, working in our population-based sites, that is Kibera and Siaya, in what we are calling the ARCH, that is the antimicrobial resistant and community hospitals. So with that, again, we continue to support the ministry in terms of capacity building. And as Dr. Evelyn said, COVID came with a silver lining. We're working together with the ministry and Kenyatta University to build capacity on improving and capacity building of professionals who can actually carry on this work on MSc program on health and epidemiology and infection control. So with that, I did want to congratulate the ministry and all the stakeholders for this milestone that we've been able to achieve. And let's continue on, because the journey is not yet over. What we know is that the microbial and microbial resistant is actually increasing, as you have seen the use of the antibiotics. And so we need to continue with this, and let's not be tired, and let's soldier on. So with that, I want to say thank you, and let's continue, and God bless you. Thank you, Dr. Segera.
Thank you very much, Linus. Give him another round of applause. CDC has been a great partner in this work. Cheers. Thank you for that. Now, I would want to call a representative from the UK Fleming Fund program, who have been very instrumental in strengthening our AMR surveillance. Dr. Maurice Bolivar is a project manager on this. Karibu.
Dr. Zagele, thank you so much, my brother, my friend, for a long time. Bwana Waziri, Bwana PS, Director General, Dr. KBS, and all dignitaries, asanteni sana. Thank you, because from the Fleming Fund, we have seen a lot of support from your end. Whenever we've needed to do things through the government, we've always got support from you. Of course, through the very able leadership of the NASIC Secretariat that has shown exemplary leadership in this sector of the AMR. As the Fleming Fund, we've done a lot of work in building infrastructure around the labs, renovating the microbiology labs, as well as equipping a lot of the labs with equipment that they would use to do a lot of the work that is needed to be done, both in the human health as well as the veterinary side of the divide. and we are greatly proud of the work that has gone on out there. We have just recently, in the course of this week, had a quick view of where we are at in the vet labs and also some of the human health labs. And I must say, we are ready to start monitoring the AMR area. We've done a lot of capacity building through the partners that we work with. I must recognize the partners that we work through in Kenya in the agricultural sector. We work through ILRI, International Livestock Research Institute. I thought I saw some of them here. We also work through, in the human health, we work through KEMRI. I thought I saw Dr. Onsare somewhere here. We work also through the University of Nairobi and the Aga Khan University. So those are the partners that we work with in order to try and improve the level of capacity building and equipping and enabling, ensuring that things happen within the microbiology labs in our sites. We have also done a lot of work in supporting data collection, ensuring that data is collected, because we know at the end of the day, we need to have data to make decisions. And so a lot of work has gone into improving data, and through other partners, like FIND has done a lot of work through the Fleming Fund to improve data collection and data collation. And so mine is just but to congratulate the Secretariat for this milestone. You have done well. We are proud of you. We'll continue to stand with you. We will continue to see how best we can be able to plug in and address this issue of AMR and AMU in the country. I thank you.
Thank you very much, Maurice. Another round of applause, please. Yep. Now, I think, am I audible? No, I can't hear myself. Yeah, now we are advancing. You know, we reduce on contacts, and then now we just speak here. Soon we'll have to. That was a very common trend recently. Now, I have apologies from the World Organization for Animal Health. Their representatives, they had an assignment out of the country and they could not make it for this occasion. And they also were not able to link with us online. So I was hoping they could pass on their message online. I would want to call upon a representative from the Food and Agriculture Organization of the United Nations who are present here. Ruth. FAO have been very, very instrumental, especially when we started the process of writing out the policy and the National Action Plan way back in 2016. Karibu sana.
Distinguished delegates from the Ministry of Health and the Ministry of Agriculture, Livestock, Fisheries and Cooperatives, implementing partners and colleagues and friends, all protocols observed, good afternoon. I'm Ruth Omani from FAO. I begin by saying thank you to all of you who found time to attend this session, both online and in person. I'm also very delighted as a country we are all gathered here, connected by various roles we play in the fight of AMR, and we are privileged to be involved in this review process. As FAO, we've supported implementation of the NAP as per the key objectives. We've supported awareness creation, surveillance activities, and knowledge management. We pledge to continue offering technical and financial support to the fight of AMR as per our missions and goals. On a personal capacity, I hope that in the future we shall look back at the efforts we've done to support our nation and we'll be proud of ourselves. I would like to conclude by a book recommendation that was recommended to me yesterday. The book is called Feral by George. The book said, "I've already lived beyond the lifespan of most hunters and gatherers. Without farming, sanitation, vaccination, antibiotics, surgery, and optometry, I'll be dead by now. Let's continue preserving human life, animal life, and the sanctity of our environment." Thank you.
Thank you very much, Ruth, for that message. And that was a Food and Agriculture Organization. I would want to call upon the representative from World Health Organization present. Regina, is she around? Apparently not. So just before we move on to the next set of remarks, I would want to also pass on the apologies from the Director of Veterinary Services, who is engaged elsewhere and was not able to attend this session. However, we have enough representation from the Directorate, but just something very key I would want us to share today. We have Dr. Kariuki from the director, is a colleague of ours from the Director of Veterinary Services. At the same time, he has a very, very important testimony to share with us, which could bring the whole issue of AMR closer home. I think he has had an experience, which I think at this point in time, it would be important for us, for him to share with us, and then we move on with the program. Thank you, Adwan.
CS, Health, the DG, and the PS Livestock colleagues. Good afternoon. As you've heard, my name is Kariuki. I'm a veterinarian. I'm one of those guys who say we are the only doctors who eat our patients. Of course, as soon as they recover. Last year, around November, during the War Week, I gave a testimony about my ordeal. And somebody quipped to me that that ordeal moved people to tears. I'm so sorry about that. I hope today you don't move to tears. But I'll be very brief. And like during the War Week, when I delved into detail about the ordeal. This started in October of 2020, actually the 6th of October 2020, when I had an accidental slip and fall in my bathroom, and I sustained a fracture of the hip. Anatomically, if you know where the ball joint is and where it articulates with the pelvis, that's where the fracture occurred. And the pain was excruciating, just to say the least. But immediately after that, I sought medical advice from a hospital. And the initial reaction was a misdiagnosis because the clinician was unable to read the radiograph. And I must say I trusted him. Why, I do not know, but he immediately prescribed painkillers and muscle relaxants. But after a while, the pain persisted, and so I sought a second opinion. And this time I looked for an orthopedic surgeon. And we agreed that we would try and mitigate that situation by either doing an internal cooptation or putting in another ball joint. So this was done. The internal competition was done a month later, that is in November. And remember, I drove myself to hospital the first time, during which time there was a misdiagnosis. And after the surgery in November, I realized I was developing a problem. After the surgery, I realized the surgical site continued to ooze. And a month later, it was still oozing. But before it oozed that month, I went back to hospital. And I was almost in a semi-coma, so I was admitted into ICU. A negative therapy machine was implemented to suck off all the discharges. And for 3 weeks, this went on. And I remember looking at the discharge that was coming out from the negative therapy machine. And I was saying, oh my God, what a nice place to get a sample for AST. I was not in a position to do the AST myself. And later on, this situation exacerbated to a situation where I felt that I was going to leave this world because of the septicemia that was progressing. I later on was readmitted to hospital again, this time in January, in a very severe condition. The internal cooptations were removed, and then we tried to control the infection at the site. I was hospitalized for another 4 months, during which time, of course, you can imagine, I was pumped with all sorts of antimicrobials, from first generation to the rest of the generations. Of course, with the other mitigation measures of therapy, IV fluids. And during that time, I got a transfusion of 11 pints of blood. I was released from hospital in May of 2021, completely debilitated and having lost about 30 kilograms of body weight. I remember during hospital, I also acquired the COVID-19 infection. And this one I acquired in hospital. It became very severe, but thank God we were able to manage it. Fluid accumulation in the thoracic cavity was mitigated by the use of diuretics. You and I know we are made of 65%, at least 65% water. And excretion of most of that fluid from the body meant loss of body condition. So I was released from hospital to go home in May, of course on a wheelchair, unable to walk. And I went home in the company of a wound dresser. Of course, my wife, who doesn't have the medical background, had to sit back and watch almost helplessly. But as a vet whose patients don't talk, I could imagine what I could do with myself. Only that the wound was located on a site I could not visualize properly because it's on the lateral side of the femur, of the femoral area. So this wound dresser kept on dressing the wound, visiting me at home twice a week, and putting in new dressings and using iodides to clean up the wound. And after 5 weeks of 2 visits a week, I realized I was not improving. So I called my wife aside and I told her, this is what we are going to do. We are going to dress this wound using sterile swabs 4 times a day. If you're my wife, you better accept this. And you took the vows in time of death, in time of life, and in time of trouble. So she accepted. Thank her. She's not here right now, but I thank her very much for taking the issue positively. So we dressed the wound 4 times a day. And after about a month, that was at the end of July 2021, I took it upon myself to do a culture and sensitivity testing. And in the first week of August, the results came back. And there was moderate growth of Morganella morgani and Citrobacter frundi. The sensitivity showed that out of 18 antimicrobials tested, only 1 antimicrobial was working against Citrobacter. Luckily, morgani was sensitive to another about 5 of them, including the one that was effective against Citrobacter. So I decided to take it upon myself to have an intramuscular injection of amikacin. You and I know amikacin is nephrotoxic. It is also ototoxic, but it was the only one that was working. So I took the bull by its horns, administered a 5-day course of IM amikacin, and waited. By the end of August, we started dressing the wound only twice a day. And during that time, I also consulted the orthopedic surgeon, whose opinion was that we open up again the joint, the site, irrigate it, and probably put in an antibiotic releasing cement. I also consulted another orthopedic surgeon for a second opinion. And this second orthopedic surgeon was brutally honest. And he told me that there's no point of doing it. And I agreed with him because I did not have, at that time, any cardinal signs of infection. There was no heat, no swelling, no pain. And I shared with him my concurrence. At the end of October, we started dressing the wound just once a day. And this is because the oozing had completely diminished. And just to be sure, I took another culture and sensitivity test. And the results came out in the first week of November 2021, during which time the wound had become sterile. There was no growth at all. And we had managed to control it. Now, if you look at this, and I think Evelyn was very clear on the 5 objectives of AMR. You can see from my story, the drivers of AMR, consequences of AMR, what we need to do about AMR. I had promised myself I will not politicize this issue, but I'm thinking if I was the president, I would start AMR from the president's office, because this is something that can happen to you, to anyone, any one of us. This was actually something I thought that would go away by itself. But you can see we need to do a lot of R&D, research and development. All these chemicals we are having are showing resistance. Out of 18 antimicrobials, only 1 was working. And that was August last year. By now, probably it's not working. And during that time, I've also heard of 1 or 2 people who have passed on. And I suspect it's because of AMR. You can see the other issues of diagnosis, the importance of AST, culture and sensitivity testing, instead of doing a broad, what we call a shotgun therapy approach to therapy. It's very important for AST. All the stakeholders involved, we must join hands in the One Health approach, because there's a very, very thin line between human, animal, and plant health. All these organisms, the same organisms that are affecting the veterinary field, are affecting us. I had done some work on Campylobacter starting 2015, 2016, 2017. And I had just concluded my studies on AMR on Campylobacter. And little did I know that I would be the victim of the same studies that I was doing, Same recommendations I had put in those studies. I became a victim. And now, who is better to give a testimony than myself? So as you can see, now I don't have a hip joint. I'm operating without a hip joint. People have encouraged me to try and look for mitigation overseas. I'm saying no. I'm waiting for us, the research and development component of the objective, to identify novel methods of therapy. Because right now, if I go in, I get even the vancomycin resistant Staphylococcus aureus, for instance, where will I be? And I'm happy that I'm alive. I've recovered. Now I can almost drive. It's just that I'm slow in everything that I used to do. But I'm able to do most of the things. I'm able to adapt. I'm doing a lot of physiotherapy. And I'm hoping to live without a hip joint. But I'm hoping to be able to achieve all the objectives I want to achieve apart from others, which are not necessary. Thank you very much.
Thank you very much, Daktari. I think that brings everything very closer home, isn't it? We all agree it's not what you are seeing here, scorecards and everything. Somebody would just imagine those are just figures and probably something hyped. True, this thing is with us and we are really, really vulnerable. So now the session you're going into, I said earlier that the Director of Veterinary Services will not be present with us. However, just a short message from him, having been one of our great champions in the whole process. I have been representing the ministry and at the same time, the Director of Veterinary Services at the NASIC Secretariat level. And indeed, as a department, rather as a directorate, we have seen a lot of work done within the implementation process of the National Action Plan. Something that I would say, starting off, is I would want to really appreciate our leadership. The Chief Administrative Secretary, Health, Rashid Aman, you've been very fantastic over this period. A lot, we've really been encouraged. Every other time when we knock on your door, you're always there to welcome us. I remember one day I came into your office, we had not met in a while. I went right ahead, talked to you, and you wondered, who's this guy? He looks familiar, the sound is there, but could you remove your mask? And true, he realized, oh, this is Azegele. And he could relate very fast. Our principal secretary, always on point. Right now, if he gives you a talk about AMR, you'll think he's a scientist. He's actually an accomplished economist. And he's been very much alert and very supportive. He's guided us through, he's encouraged us, he's also opened doors that we were not able to open. And anytime you go to him, you say, ni pesa inatusumbua, itatafuta, you go right ahead. And we've been able to move. So I really, actually on behalf of the NASIC Secretariat, we are very appreciative. Dr. Amoth, we rode heavily on the COVID pandemic issue. We used to know as much as whatever was going on, there was a lot of pressure, but you realize around the time, a lot of the only antibiotic used most, and I think we all know, azithromycin. Anybody I think that the sales of that drug just hit the roof. But a lot of colds, common colds, disappeared because of the hygienic measures that were in place, the IPC programs that were enhanced, and the hype about cleanliness. The only thing we have not worked very well is environmental cleanliness. I think if we clean our environment, we'll even do away with most of the other diseases that we have. So generally, I would want to say we've had great cooperation. We have worked very well with the Ministry of Health. In the beginning, of course, with Rachel there, she could talk a lot about hospital care, and then she remembers there's a vet. What happens in animals? Then I explained. And then later she got to understand how the two are related. And we charted the way forward on how to do our national action plan and policy. And we deliberately did a policy because government programs in Kenya can only be driven when we have a policy framework in place, and then we go with the national action plans and strategies relevant for implementation of the policy of government. We could not pull the gap, the global action plan, and try to implement it. For sure, our executives would ask us, is it within our policy framework? Is it priority for government? Yes or no? And that's why you saw the commitment that was there from our cabinet secretaries responsible for health and agriculture signing. So I think that has been a great journey, and to date, we are now quite encouraged with what we have seen here. And we are keen to ensure that going forward, we are going to even have now the other sectors as we had committed ourselves, environment. And in 2017, we didn't have much information on environment and also crops. We have been able to do various studies supported by various partners. And at the moment, we used to have what we call the tripartite. Now it has transformed to quadripartite. Quadripartite because now we have the environmental sector joining in, and that is UNEP. And I think we have the representative from UNEP here. You can give her a round of applause. She's Bathsheba Muridi. Thank you for coming around. We have, I think, a representative from NEMA. I don't know whether they are present. We were expecting them, but the PS is away. Oh, where? Thank you. Thank you very much. So those are just the bits, I would say, from the NASIC Secretariat point of view. We have a lot we can say. We have a story we can give you. We have experiences we've had. We have had the experience of coordinating different sectors, different disciplines. We've seen competition among partners for space. They want to, especially when you're here, they will all want to show that we are, but it's important we've been able to pass the key message. Whenever we organize something, it's for the country and everybody has his space, and we move the agenda together. We put resources together, we get better results. If you use it alone, you won't get much traction. So with those few remarks, I'd want to also appreciate my colleagues from the Secretariat who've been working so hard. We hope to get a new team as we move into the next phase, to move in and run with the whole process. Now, I would want to take this opportunity to invite the Director General for Health, Dr. Amoth, who will then invite the Principal Secretary, State Department of Livestock, and the program will move on, and who will also invite our chief guest to address. Thank you very much. Karibu Bwana Amoth.
Okay. Thank you, Dr. Zegele. I want to assure you that my popularity has not decreased an inch. You need to check the latest opinion polls from TIFF and Infotrack. Our chief guest, Chief Administrative Secretary, Minister of Health, Dr. Rashid Aman, PS, State Department of Livestock, Bwana Hari Kumtai, Development Partners present, colleagues from the UN family, colleagues from the Ministry of Health and from the county government, civil society, the Fourth Estate, ladies and gentlemen, good afternoon. I have a long speech here, which I'm tempted not to read because our chief guest, in my well-informed opinion, will probably be able to talk about things I have read before you. So in this, because of time, I would rather make a few off-the-cuff remarks and thereafter invite the peers to be able to speak to us from the livestock perspective and hand over to the chief guest. We have clearly been told of the burden of antimicrobial resistance. I think the testimony of Dr. Ndegwa, Dr. Karaoke is real. So this thing is not abstract. And there are very many untold stories similar to what Dr. Karaoke has told us. Those who are not able to get that level of help that he got to be able to share with us his testimony. So then this calls upon all of us to be able to come together through the multi-sectoral approach to tackle this hidden pandemic. I think the pandemic is already here with us because from his testimony, from a panel of 18 antimicrobials, only one could be able to tackle his condition. That tells you the burden of the problem. Of course, the problem is greatest in low-middle income countries because of weak healthcare systems. And we all know that it takes a very long time to be able to develop new antimicrobials. The kind of investment required to be able to develop a new molecule, it takes a very, very long time. And for the pharma industry to be able to recoup their investment, then it is protected by patents, which ordinarily last from 15 to 20 years, making those molecules then invariably very, very expensive and inaccessible. By the time those molecules reach low-middle income countries, probably they have been in use in developed countries for 3-5 years. And for us, because of our limited resources, therefore, we need to be able to enhance antimicrobial stewardship and rational use of antibiotics to be able to protect the basic molecules that are available within our healthcare system because of the resources that we have. As a country, as we journey towards UHC, then this issue of antimicrobial resistance becomes the core point of discussion because we are talking about infection prevention control. And prevention and health promotion will be the key for us to be able to achieve universal health coverage. Unlike the developed countries, which can be able to throw money at each and everything, we are not that privileged, and therefore the basic things that have worked before, and I think Dr. Hari talked about it even during the COVID-19 pandemic, we saw fewer and fewer cases of other respiratory tract infections, diarrheal diseases, and therefore this is a war that we can be able to win by investing in the very basics of health promotion and health prevention. And this will require a multi-stakeholder approach. It requires a lot of community awareness. We need to be able to prime our people that you can go to the hospital and you come out without a prescription. It's not that if you have not been given a prescription, then you have not been treated. We need to change our notion that health is not just about popping pills right, left, and center. We can be able to do a lot more by simply doing basic things of hand hygiene. Sanitizers are now almost a universal phenomenon everywhere we go. And that way, then we can be able to put the scarce resources at our disposals into better use to be able to improve our population health. With those few remarks, it is now my honor and pleasure to invite the Principal Secretary, State Department of Livestock, Fisheries and Cooperatives to make his remarks and thereafter invite the chief guest. Bwana PS.
Thank you so much, Dr. Moth. I can confirm that your popularity indeed is still very high, checking from the latest opinion polls, which sometimes you don't trust, but we believe they're right. Our chief guest today, Dr. Rashid Amana, the Chief Administrative Secretary, the Ministry of Health, and also has become a very good friend of mine. And when I was walking in with him, we reminded ourselves of how we've carried this baby since we joined in. And I remember it was one of my first assignments dealing with the Ministry of Health. And I really want to say that we're very proud of you, the Secretariat, because you've really made us proud that this baby is being celebrated today, looking at the past 5 years, what we've done. The FAO country representative present here today, the representatives of the CEOs present here today, senior national and county government officials present here, members of the civil society who have also been partners and supporters in propagating and taking this information down to the communities, our very supportive development partners, and their representatives who are here today. Ladies and gentlemen, good afternoon. I'm honored to join you this morning to start off the process of reviewing the policy and national action plan on the prevention and containment of antimicrobial resistance. The occasion gives us the opportunity to review progress, challenges, and lessons learned over the last 5 years, which will inform the next phase in combating antimicrobial resistance. Indeed, antimicrobial resistance is a global public health concern that has threatened the very core of the modern medicine and effective treatment of infectious diseases. Today, our office have just confirmed to us that this is real and it's not localized, it is also global. Effective antimicrobial drugs, vital for both preventive and curative measures protecting patients from potential fatal diseases. The misuse and overuse of the antimicrobials in human medicine and food production animals have put everyone at risk, considering that the very few antimicrobial agents are being developed. Ladies and gentlemen, the livestock subsector has a significant role in control of AMR in Kenya through the prudent use of the veterinary medicines used in the treatment of animal diseases to mitigate potentially deleterious effects on food safety, environmental safety, and international trade. The livestock subsector remains, as we all know, a major driver of the Kenyan economy, contributing about 12% of the gross domestic product, and it employs 50% of the agricultural labor force. Now you can see how we have to balance all this because we need the growth of our economy. So AMR threatens sustainable growth of the livestock subsector in ensuring food security and trade across different economies. The AMR agenda is and will continue to be a priority since it threatens the achievement of the key government goals of food security and universal healthcare coverage. Ladies and gentlemen, the implementation of the policy on AMR in the last 5 years has enabled the government to enhance its capacity to tackle this silent pandemic. The various strategies, guidelines, procedures, codes of practices and protocols developed during this period have enabled focused implementation of AMR policy. Consequently, and significant progress has been witnessed in behavioral change among the general public, enhanced capacity in AMR surveillance, targeted infection prevention and control programs, and enhanced antimicrobial stewardship activities across the human and animal health sectors. These achievements will not be possible without very close collaboration, cooperation, and support from our development partners. I want to acknowledge the ongoing support by the UK government through the Fleming Fund, the FAO, WHO, and World Health Organization of Animal Health through the Multi-Partner Trust Fund, the civil society organizations, academia, food and feed industry, and also members of the pharmaceutical industry who are also present with us here today. This partnership underscores the fact that AMR requires a multisectoral, multidisciplinary, and indeed the whole societal approach to prevent and contain emergencies and spread of resistant pathogens. I look forward to your continued collaboration as we review the National Action Plan. Ladies and gentlemen, as we approach the end of the current implementation phase, we need to draw from the challenges and lessons learned to inform our interventions in the next phase. There is need to build on networks established between and with the sectors to enhance coordination and collaboration among the multiple disciplines required in strengthening the One Health approach towards addressing antimicrobial resistance. It is my hope that the review will also incorporate aquaculture, crops and environmental sectors incorporating requisite action to ensure resistance genetic elements are not circulating in the environment. I do commend the NASIC Secretariat for being adaptive to the changing technology in facilitating virtual participation, and I've just seen there 148 participants. That is really commendable. And enhance presenting an opportunity to more stakeholders to attend this event. Ladies and gentlemen, as I conclude, I wish to state that I have full confidence that the resources of this formidable collaborative network will be brought to bear fruitful in reviewing the National Action Plan to address the emergencies and the spread of antimicrobial resistance. This will guarantee that the government effectively executes the dual mandate of ensuring food security and universal healthcare coverage. It is my humble pleasure, therefore, ladies and gentlemen, to invite our Chief Administrative Secretary, Dr. Rashid Amana, to give his keynote address. Thank you and welcome.
Thank you. You know, we are in an electioneering period, huh? And I want to talk about popularity because I saw the DG talk about that. I hope my popularity is at the same level as his because we were together on the Corona campaign, where I think that is where we came to the forefront, right? Thank you. The Principal Secretary, Department of Livestock, Harry Kimtai, Director General for Health, Patrick Amoth, Dr. Patrick Amoth, representatives of the Ministry of Health, Ministry of Agriculture, Livestock, Fisheries and Cooperatives, state departments and agencies, development partners, AMR stakeholders, distinguished guests, ladies and gentlemen. Good afternoon. I am delighted to be here today to be part of this National Antimicrobial Resistance Forum to take stock of progress made in implementing the National Action Plan on the prevention and containment of antimicrobial resistance. It's 5 years after its official launch, and I believe this is a good time to reflect and plan for the future. This indeed is an event with a difference and a great milestone because Kenya has registered significant achievements, as we heard, in the implementation of the National Action Plan and continues to be a point of reference regionally and globally on best practice in implementing the plan from a Okay. And I want to commend the team here. I think the presentation, the overall presentation made by Dr. Wesangula really shows us how far we have come in this area and how we have been able to achieve what we have achieved. And I think we have achieved quite a lot. Yes, there's quite a bit to be done, but we have achieved quite a lot. And what struck me most was the fact that we are a trendsetter in the region, having done what we have done. I want to commend you again for this One Health approach that you have taken, where you have stuck together as different ministries, different sectors, to really produce what you have produced. And I want to commend you for that. I say this because we have not been successful in other areas that cut across different sectors, where we have tried to put up legislation that cuts across different sectors. We have run into problems because we find the different ministries, each one wanting to control some part of it. So I think this is a very good example, and I encourage you to continue in that way. And I'm very happy also to hear that you have brought on board environment, because that is what I felt in my discussions, even with Dr. Wesangula. I felt that that was a missing link that we need to bring on board. So I think with this approach, I look forward to seeing you move on and really achieve all the targets that you have set for yourself. First of all, I would like to express our sincere gratitude to the organizing teams led by the Ministry of Health, the Ministry of Agriculture, Livestock, Fisheries, and Cooperatives, the Ministry of Environment and Forestry, and all development partners for their contribution to the success of this process, which I have followed with great interest. It is indeed a privilege and a sign of recognition of the country's commitment to the fight against antimicrobial resistance. As you have heard, AMR is one of the most complex public health threats, with root causes in multiple sectors ranging from health, food safety, and agriculture to environment and trade. It presents the global, regional, and national communities with extensive challenges, considering its depth and breadth. Studies have predicted a continued rise in antimicrobial resistance globally, leading to 10 million people dying every year and a 3% reduction in gross domestic product by the year 2050. The Graham report of 2022 estimated that at least 1.27 million deaths per year are directly attributable to AMR. In 2019, the highest rates of AMR burden were in sub-Saharan Africa, where 6 pathogens accounted for 73.4% of deaths. One in 5 deaths caused by AMR occurred in children under the age of 5, often from previously treatable infections. This new evidence shows that AMR is a leading cause of death globally, higher than HIV, AIDS, or malaria, as we heard. This is a warning signal that AMR is already putting extra pressure on frontline health workers by making common infections harder to treat and preventing them from saving millions of lives. Dr. Kariuki, I think your testimony was very, very powerful. I'm sorry that you went through that experience, but I think it's important that you're able to share that experience, because we need to highlight the importance of AMR. We need to put it up on the list of agenda that as a country we need to address. And I have seen that AMR is becoming increasingly higher up on the agenda, even on the global scene. And I truly believe that we have great opportunity to be able to exploit this, and especially during these post-COVID times, because we know what COVID has done. It has highlighted these areas, including IPC and R&D, and I think we need to work hard to see how we can exploit this opportunity that exists at this point. In addition, with the increasing levels of international travel and trade, antibiotic resistance is one of the biggest threats to global public health, food security, and development, and if unchecked, will greatly hamper the achievement of sustainable development goals. The complexity posed by AMR has demonstrated that no single government department or independent organization can tackle it alone, and that containing, controlling, and preventing emergence of AMR demands engagement and well-coordinated actions across multiple levels, sectors, disciplines, and with a broad range of stakeholders. From the 2021 AMR surveillance report, Kenya is no exception to this threat, with increasing rates of antimicrobial resistance being reported in our hospitals and communities. In response to this, the Ministry of Health, in partnership with the Ministry of Agriculture, Livestock, Fisheries, and Cooperatives, have been part of the regional and international efforts to reduce antimicrobial resistance and ensure the availability of effective antibiotics now and into the future. In response to the AMR threat, the two ministries have consolidated national efforts to implement sustainable measures to mitigate any further emergence and spread of AMR. Using this One Health approach, the ministries developed the policy, and from that, the National Action Plan and the implementation of the policy is well underway. And I take this opportunity to thank the lead ministries and implementing partners for the support provided towards the achievement of the set goals. Taking into consideration the complexity posed by AMR, implementation of national action plans is not an overnight success. It takes functional and integrated systems with well-coordinated, appropriately resourced governance structures to successfully and effectively implement the interventions in these plans. At the national level, governance and coordination mechanisms are implemented through the National Antimicrobial Stewardship Interagency Committees, or the NASIC, and the supporting secretariat. This has been cascaded to the devolved units at the county level, with the implementation of the National Action Plan being carried out by the County Antimicrobial Stewardship Interagency Committees. To date, 14 counties, I will not name them, they're listed here, have established their CASICs. The challenge here to the Secretariat is to ensure that all the 47 counties do develop their CASICs. Of these 14 counties, 8 have already developed their county-specific action plans on antimicrobial resistance. I commend you for this because I think this is progress, work in progress, and I believe we should be able to get the 47 counties on board and have them develop their action plans and have them incorporate these action plans with the budget from the counties. The government, with the support of development partners, has taken several measures across various sectors to intensify action against AMR through the implementation of the National Policy and Action Plan on Antimicrobial Resistance and accompanying strategies on surveillance, communication, infection prevention and control, and antimicrobial stewardship. This will go a long way towards addressing the challenges identified in the situation analysis on awareness, surveillance systems, infection prevention and control, rational use of antibiotics, and research and development. As much as notable progress has been made, there is still a bit of work and ground to cover. In view of the ongoing COVID-19 pandemic, several studies globally have indicated a high rate of antimicrobial prescribing and self-medication for those with symptoms of COVID-19. Much of which is unnecessarily promoting antimicrobial resistance, as most of the initial illnesses being treated have been from COVID-19 viral infection. Optimal utilization of laboratories is critical in ensuring that the continuous engagement of patients, the clinician, and laboratory teams supporting the judicious use of antimicrobial agents continues as guided by the National Antimicrobial Stewardship Guidelines. Dr. Kariuki talked about how he took his own personal initiative to do the AST. I think we need to improve our health systems and our health diagnostic systems to make it much easier to be able to identify the problems at source. Right now, AST, of course, is based on culture, but there are new technologies, molecular technologies. We have been able to go through COVID-19 using molecular technologies, and it is possible to adapt these technologies also to antimicrobial resistance so that you cut down on the time and are able to get the results of the resistance and guide treatment in that way. So I think that there are opportunities here to build on and improve those diagnoses and make it much more timely. Inaction will have dire consequences for human, animal, plant, and environmental health. Hence, the call to accelerate action in curbing the growing threat of AMR in the next version of your National Action Plan. That version, as you're reviewing, and I think this is one of the things that you're kicking off in this meeting and will be continue to develop your next National Action Plan, which should target eliminating or significantly reducing over-the-counter sales of antimicrobial drugs that are important for medical or veterinary purposes, reducing the overall need for antimicrobial drugs by improving infection prevention and control, hygiene, biosecurity, and vaccination programs in humans, agriculture, and aquaculture. In addition, we need to end the use of antimicrobial drugs that are of critical importance to human medicine in promoting growth in animals, limiting the amount of antimicrobial drugs administered to prevent infection in healthy animals and plants, and ensuring that their use is performed with regulatory oversight, ensuring access to quality and affordable antimicrobials for animal and human health, and promoting innovation of evidence-based and sustainable alternatives to antimicrobials in food systems. I heard during the presentation by Dr. Wesangula, and I reflected and see the role of regulation, drug regulation, play an important part in this program. I know that the Pharmacy and Poison Board is already on board with you. I've seen on the program that Dr. Wanga or Karim Wanga is around, but I believe we need to work harder in terms of regulation. Yes, we have regulation on paper. Maybe we don't implement it well, but we need to do a great deal in improving that. I also believe that the multitude of types of antibiotics and brands and generics that we have do play a role in contributing to AMR. And therefore, in regulation, we need to look at this. We need to look carefully what type of products we put on the market. Distinguished guests, first, oversight and governance are critical in the effective implementation of proposed interventions. We need to ensure that there is effective governance and professional oversight of the sales and use of antimicrobials and stewardship of antimicrobials in all sectors, including the development and implementation of evidence-based guidelines for treatment, control and prevention, and secondly, work towards elimination of marked reduction of over-the-counter sales of antimicrobials by implementing stringent rules to strengthen and increase professional oversight. Second, we need to establish mechanisms to improve and broaden appropriate access to good quality antimicrobials. We need to fix the supply chain in its entirety. Local manufacturing and production of health products and technologies also should be enhanced to support self-sufficiency and reduce costs of providing care and treatment. Third, we need to encourage and support the strengthening and improvement of comparable national and international surveillance systems to enable us to establish antimicrobial use and resistance baselines and set progressive, ambitious, science-based, and nationally relevant targets for responsible and sustainable antimicrobial use across the sectors. Indeed, the central role of data to address AMR cannot be overemphasized. Surveillance data is important, and so is data engagement from citizens on AMR. Finally, we are all fully aware that no single government, department, or independent organization can tackle AMR alone, and that this demands well-coordinated actions across multiple levels, sectors, disciplines, and with a broad range of stakeholders, including the citizens. We note that there is inadequate financial support currently available for sustainable implementation of the National Action Plan on antimicrobial resistance. Therefore, we need increased investment urgently to support delivery on our National Action Plan from our various government sectors, our county governments, and our development partners. To achieve this, there is a need to present a strong economic case for investing in containment of antimicrobial resistance with robust estimates of costs and benefits of implementing national action plans on antimicrobial resistance to galvanize this investment. And I think this is a key statement, because this is what will catch attention. If you can put a cost to these things and demonstrate, then it will catch attention. Government and all other people will pay attention to it. As I conclude, we recognize the growing commitment and interest in supporting the implementation of the action plan by development partners led by FAO, WHO, WOAH, UNEP, this is the quadripartite, as a strong indicator of willingness to work together with government to realize the goals of the policy and maximize on the results for the benefit of Kenyans, men, women, and children in a sustainable manner. This calls for greater collaboration, communication, coordination, monitoring and evaluation of the multi-level interventions, underpinned by the core principles of country ownership, accountability, One Health approach, alignment of approaches anchored in systems thinking and sustainability of actions. We all have a role to play, ladies and gentlemen, and I reiterate the government's commitment to this cause and emphasize the crucial role that government plays in the coordination across multiple actors, because collaboration is truly the heart of this venture. With these remarks, it's now my honor and privilege to usher us into this phase of reviewing the National Policy Action Plan on the prevention and containment of antimicrobial resistance. Thank you for your kind attention.
Thank you very much, Chief Guests, for those very insightful remarks. And that sets the pace and the stage for us to move. We've been given permission. I'm not sure whether the checkbook is with us or with you. So now it's lunch hour. The top table, the secretariat, partners, I want us to meet downstairs for a group photo. The rest of the team will proceed for lunch. And then you're welcome for lunch. I hope you can spare time to kule kitu kidogo before you. Oh, good. So I think we could proceed downstairs for our group photo. Our Chief Paparazzi is here. And then we proceed for lunch. Thank you. We should be back here at 2:30 and proceed with the program. Now, colleagues, I think it's last time I called the session to order. We have had a very good morning. It was cold, but I don't think I felt cold. Now that the executives have left, I'm feeling cold. I've had to wear my jacket. Anyway, that being said, I want to call upon, where is Zaituni? Yeah. The name has been fronted. Zaituni is the local person in Nzoia County. We've been talking a lot on the phone, on Zoom. Today I put a face to them. I want to invite you here. You will take us through the afternoon session, coordinating all the county presentations. Oh, sorry. I have been corrected. I've been corrected here. You know, I didn't check my text messages. We have Dr. Wambulwa standing next to me here. Goma County. Oh, Kakamega County, Western Kenya, the land of Ingo. He's going to take us through, he'll be chairing the session, narrating this session through presentations from respective counties. I believe they've been shared and to be seamless. So thank you very much, and I want to thank you all for also being very cooperative during the morning session. I hand over to Dr.
Good afternoon. So we want to proceed. I'm Dr. Wambula Bernard. I'm the county pharmacist and the county AMR focal person, county government of Kakamega. So you are welcome. We want to listen to our colleagues from Bungoma, Trans Nzoia, Kiambu, Kisumu, Kilifi, and Murang'a counties. They are going to showcase what they have been doing the last 5 years in terms of implementing the 5 objectives in the National Action Plan. So they'll tell us whether they have established CASICs. They'll tell us what they are doing in terms of AMS. They'll tell us what they are doing in terms of diagnostic stewardship. They also tell us what they are doing in terms of IPC and AMR surveillance. So at this point, kindly be informed that each presenter will have 10 minutes to present. And then once we've done all the presentation, now that there are only few, we'll give them a chance to respond to the questions. So just keep your questions somewhere. Once we are done with all the presentation, then we'll have time to ask questions. So at this point, I want to welcome Dr. Emma Nyaboke from Bungoma County Government. Karibu Daktari.
My name is Dr. Emma Nyaboke. I'm the CASIC focal person for Bungoma. It is a pleasure to be here. I'm very happy to interact with all of you. So much has been said from the morning, and I think with all the efforts from the national level, at the county level, we also came up with a work plan, which is aligned to the National Action Plan objectives. The Bungoma County Work Plan was launched in 2021, January, courtesy of USAID and FAO. We also had a team from NASIC and the Bungoma CASIC team. So for us, the implementation approach we took, we decided to take an incremental approach where we first started with the county referral hospital in terms of putting on the structures, and we also appointed champions for the Bungoma County Referral Hospital. Currently, we have strong lab capacity and we have fair microbiology utilization. And at this time, I think we have been doing this for the last 3 years. At this time, we are moving on to the other hospitals, the other level 4 hospitals. We are bringing on board the other county hospital, which is Webuye, strongly, through sample referral mechanisms and a lot of sensitizations in these other level 4 hospitals. We also have continuous sensitization and surveillance in the animal health department. Yeah, so in terms of the specific objectives, awareness and maybe knowledge around AMR, we developed some protocols and IC materials at the CASIC level, which were distributed to the public and private facilities across the county. And we have also done sensitization of animal health workers and also the healthcare workers on prudent use of antibiotics. And currently we are working on a CAP study, which will just assess the knowledge and attitude in the agrovets, private pharmacies, farmers, and general population. We are still doing these, and also maybe even disposal of the medications that are used, especially for animal health, how these animal health practitioners actually dispose their medications once they go using these medications at the home levels. Yeah, so this is under the support of WAP. It's still ongoing. We have not completed this. Yeah, so maybe the highlights that we had in terms of awareness was the World Antimicrobial Awareness Week in 2021. And these are some of the activities that we were able to do. We appointed technical working groups for each object, and we were able to sensitize them here, as you can see at that photo. We were also able to have some private practitioners from pharmacies and agrovets for a one-day sensitization. We were also able to have a farmer field day where we had the animal health practitioners actually passing knowledge about antibiotics to the farmers around the region. On appropriate antimicrobial use, we have appointed AMS teams and champions for the level 4 hospitals, as we said. We have the Bungoma County Referral Hospital, Webuye County Hospital, there's Kimilili Sub-County Hospital. We also have some bigger private facilities within Bungoma County, in which we have also done a lot of sensitization and also appointed champions for those hospitals. So the champions have really done a good job in terms of pushing the agenda, even when the CASIC team is not there. So the awareness or the antimicrobial use technical working group has also been going around doing CMEs, that is continuous medical education on AMR in these facilities. There's also continuous mentorship program at the County Referral Hospital Lab, courtesy of IDDS. And currently we are working on a points prevalence survey for Bungoma and Webuye hospitals, the two bigger hospitals in the county. And I think from the results that I've seen from the previous points prevalence surveys that have been done, the results could actually be almost the same, because we have collected data almost halfway, but I can also confirm that at this point, we're also dispensing or prescribing ceftriaxone the highest. We are looking forward to see what the other results will look like. So we have also done strengthening of medicines and therapeutic committees through Afya Ugavi, and there also has been a promotion of farmer-led extension services. So in terms of surveillance and research, we've appointed a technical working group, a One Health technical working group for surveillance. And of course, we've been having a lot of support from IDDS in terms of strengthening the lab capacity. We have also we are currently working on a sample referral mechanism, where we were riding on an existing sample referral mechanism for HIV and TB program supported by Dumisha Afya, and in collaboration with IDDS, where we've added a few days to the riders so that we can have them transporting the microbiological samples from the peripheral facilities to the mother facility where we have the automated machine. So we have also analyzed the existing data that has been collected in the lab, but from the last meeting that we had, we realized that there was a gap because according to our data, mostly our data was biased towards inpatients. So we could not generalize it to the general population because most of the time the outpatient department was not contributing much data. So we are still giving ourselves some time so that we collect some more data to come up with a conclusive antibiogram for the county. So the key achievements we've had with the support of IDDS and NASIC, that is in terms of capacity of the lab, we have had accreditation of bacteriology tests. We have adequate supplies. The county purchases their supplies, but sometimes your side comes in to supplement. We have an uninterrupted bacteriology services. We have an automated machine, which was a challenge before when we had a manual machine. So currently, I think from 2022, we acquired an automated identification and AST machine, which has made the work much easier and reduced the turnaround time. The equipments are being maintained. There is a retrospective capture of data on WhoNet. We also have a presentation of these cases in the AMR eco sessions, and there's increased demand for bacteriology. And a major achievement is that most of the private facilities of almost level 4 in the county are able to refer their samples to the Bungoma County Referral Hospital for testing. So that is the workload in terms of surveillance. In 2020, we had a total of around 1,214 samples In 2021, we had 1,035. All this time we had the manual microbiology machine. 2022, we hope that it will go higher now that we acquired the automated machine. So still highlighting the two pathogens that were highlighted earlier in terms of E. coli, our resistance pattern also almost looks the same. We have resistance to the most trusted antibiotics against E. coli, especially in treatment of UTIs. So when you see amoxiclav is what most people are actually using for treatment of E. coli, which is resistant. We also have nitrofurantoin being the most sensitive. Cefuroxime, which is the most used in this case, has also shown a lot of resistance. But as we said, we still want to collect data from outpatients so that we can be able to make a general conclusion on that. Still, the same trend with the national data on Staph aureus. I think there's a lot of resistance to azithromycin and all that, sensitivity to vancomycin, and I think there is also some resistance to ceftriaxone and such. Yeah, so we also have surveillance and research in animal health going on. So we had sensitization of on surveillance using the CABS system in animal health. We have also acquired some data from there. It has not been analyzed on poultry farm AMR surveillance in partnership with ILRI. Yeah, so in terms of infection prevention and control, we appointed the county focal person, and we also have facility focal persons. We were able to celebrate the Hand Hygiene Day, dissemination of IEC materials on IPC, advocacy to hospitals to provide PPEs for waste handlers, and to secure waste disposal areas. So a major weakness that maybe we noted with IPC is that in Bungoma County, we didn't really have a partner for IPC, but we did a baseline survey, and we were not performing very well. Maybe if I can just skip to this. We were not performing very well, and we noticed that the county has actually supported IPC in terms of providing the materials, we have everything that we need to actually work in terms of the PPEs and all that. But management of these waste segregation and all that was a challenge, which was more of a behavioral issue. So as you can see there, we have someone putting hazardous waste to a black bin, for example. Safety injection, someone injects a patient and they just leave. This was an audit that was done, a baseline audit. They just leave the injection there, and there's a bin down here to dispose this waste, but someone prefers to leave it in the sink. So it's more of a behavioral issue that we're working towards approaching, and maybe through getting some collaboration with some partners so that we can approach. A major challenge that we highlighted was that in Bungoma, in terms of maybe waste management, we do not have an incinerator in the whole county, and the burning chambers that we had were not very well maintained. So as you can see, that was one of them that was highlighted. Of course, there are so many other things, good things that were going on, but for the purposes of this, we highlighted the challenges. Yeah, so in terms of research and development, we were able to establish a research unit for Bungoma County, although funding was still a challenge, but we do have a unit that takes charge of or takes the data of all the research that goes on within the county and requires someone to disseminate the data to the county after they're done with the research. So we also have the point prevalence survey going on, as I said earlier, the CAP study that is also underway. And we also have KEMRI in the county, which is also doing studies on AMR, and most of the time they have been able to give us back the data to the users so that they're able to apply in terms of clinical judgments. So maybe an achievement that we are able to do there in terms of development of policy. We had the Webuye County Hospital developing the first drug formulary. Webuye County Hospital is also a level 4 hospital within Bungoma. The challenges that we've had, I actually had to reward my first challenge. I understand that M&E indicators have been developed at the national level,
but at the county level, we've not been able to implement them. So maybe we'll need to do some dissemination to the county level. We didn't have support for IPC for Bungoma County. So that's why we had a lot of poor waste handling in the county, poor maintenance of burning chambers and all that. And then lack of consistent support for AMR activities, especially in animal health. We didn't have very many activities done there. Low uptake of microbiology testing still is a challenge, which needs continuous sensitization to the clinical staff to continue taking up the microbiology testing. And also in animal health, because we do not have a lab in Bungoma County, most of the time we need to refer the samples to Eldoret. So we are not able to, the uptake is not able to be taken high. The opportunities we have is to increase awareness through available slots that we have. We normally have free health talks in the West FM, a local station. We are yet to develop a county antibiogram once we have enough data. And then we need to disseminate the available guidelines, especially for use in livestock and crops. And then we have, we need to do continuous sensitization on both surveillance in both animals and human health, expansion of the AMR and lab capacity to the other facilities, collaboration with the other partners who are interested in IPC. And maybe this can be highlighted also at the national level. We mapped out and we realized that there are so many other partners not necessarily working under AMR who are interested in IPC, like the HIV department, TB and RH. So if they can, we can work together to come up with the common goals so that we can be able to achieve the IPC goals. Facilitation of research around MS and streamlining of M&E. The lessons learned, engagement of sitting authority is always necessary, and I think everyone in the room. For us, we took the incremental approach, and I think it's worked really well for Bungoma because as it is now, I'm confident of Bungoma County Referral Hospital, then we can be able to have champions who will still run the agenda there. And continuous stakeholder engagement and feedback is necessary. You can talk to people, you see change in 1 week, and after that, the actions go down. So you need to continuously engage them. Resource mobilization is also a major driver of the AMR agenda. And there's also need for continuous county review, or that's still kind of M&E monitoring from the national level to enhance implementation at the county level. Thank you very, very much.
So let's appreciate Dr. Nyaboke again. Thank you. So she has highlighted the challenges they are experiencing in Bungoma, and it all revolves around funding. And we have to shift the agenda of AMR to the next level. We must seriously talk about funding. County governments, for instance, in my county, when we were doing our budget, I made a lot of noise, but whatever I got was 200,000 in our budget for AMR, 200,000, but we'll do something with it. It means that we are starting somewhere. So we can have a meeting with that 200,000 and discuss AMR awareness. So ladies and gentlemen, at this point, I want to welcome Dr. Zaitun from Trans Nzoia County to come and make a presentation. Karibu.
Good afternoon, everyone. Good afternoon again. Nikawa mmekula lunch mkaanza kusinzia. Okay, my name is Dr. Zaituni Akaduroit Mullah, the focal person for Trans Nzoia County, and also the secretary to the CASIC, Trans Nzoia County. So my slides are arranged in a particular order, just as a learning point for those who are starting their CASICs. We started by training our healthcare workers on antimicrobial stewardship, which was supported by IPNET at that time. This was because at that time is when we were developing the curriculum for AMR, and we targeted all the healthcare workers, that is the pharmacists, the medical doctors, and the nurses, as well as the clinicians, the other clinical officers. And then we moved to sensitizing healthcare workers. This was also supported by AMPATH. We went through 47 private facilities. We sensitized 47 private facilities and 37 government facilities from all levels of healthcare. And we covered an overview of the AMR, antimicrobial stewardship, antimicrobial surveillance, infection prevention and control. We moved to a workshop that was supported by USAID, IDDS. We focused on diagnostic stewardship for antimicrobial stewardship, and also to enhance sample referral from the peripheral facilities to the county facility. This was mainly because at that time we had very minimal awareness on antimicrobial stewardship at the county level. So we were focusing on creating awareness amongst the healthcare workers. And then we moved to the radio talk shows and the TV talk show. That is myself and Dr. Irina Luala, our focal person from the veterinary section. We focused on rational use of antibiotics, and we also recorded an AMR documentary that was running every Monday from 8 p.m. to 9 p.m. on Imani TV. Then we went through some form of sensitization through the MESP program, and we focused on sanitary and phytosanitary farm measures for the farmers in the field. We focused a few training sessions on antimicrobial resistance and antimicrobial stewardship from the animal sector. And then we progressed to CPD events, and we were invited by the Kenya Veterinary Association to give a talk on an overview of antimicrobial resistance and the implementation of the National Action Plan at the county level. My counterpart from the veterinary section was not available on that day, but since we are working in a One Health team, I managed to give that talk. The next thing that we did was a CPD webinar, which was supported by Kemri Wellcome Trust, USAID, IDDS. And our main focus was bacterial pneumonia in our setting and the AMS opportunities that were available to us in terms of both antimicrobial stewardship and diagnostic stewardship. We also did CMEs for the various facilities. We started at the Kitale County Hospital, which was a public facility, and then one of the sub-county hospitals, that is Kapsara Sub-County Hospital. And then we were invited to a private facility, which sees pediatric patients to facilitate a similar CME. And then this is when we were now starting to pick up as Trans Nzoia County. We participated in the WOW, maybe not as strongly as we should have because we did not have funds available at the county for this event, but we were supported by the MTAPS program by giving us some t-shirts, and I used my own funds to print the banner because I'm really passionate about AMR. We didn't want to be left out. So this is when we were really now gearing towards the worker. You may notice that I did not mention anything about a work plan or, a working work plan. We had nothing. We were basically, yani sisi, tulianza kazi, and then the work plan found us. Yeah, so through further interactions with other organizations, we managed to meet some people from Kabi, And we came up with a joint advisory service delivery group that was focused on One Health issues, that is mycotoxins, zoonotic diseases, misuse of pesticides, misuse of veterinary drugs, antimicrobial resistance, food and water contaminants. So this program is set to start running from August going forwards for 3 years, and it shall be funded by the BioVision Foundation and WTS. On to strategic objective number 2, that is surveillance. That is our bacteriology team from Kitale County Hospital. The photo was taken on 31st March 2022. The AMR surveillance started way before any CASIC was conceived or anything. I think Kitale County Hospital was the second pilot site for AMR surveillance. And they have been very proactive in matters AMR, only that we were still cruising at a low altitude. I think the CASIC was required to come and motivate the team. So through the MOH, NASIC, and partner support, we were able to have trained technologists. We have 3 currently deployed full-time for microbiology. We have continuous mentorship via the ECO platform. And then we have support from IDDS. We were able to equip the laboratory with state-of-the-art equipment. We do quality management system and standard operating procedures. They're installed in the laboratories. And then we also participate in external quality assessment, and we have performed over 80%. I think at this point, I should just mention that the laboratory is WHO accredited, and the microbiologists are individually WHO accredited. So we really trust our results. Yeah, so the laboratory participates in AMR surveillance, as I had mentioned. So we usually report to the National AMR Surveillance System and eventually to the WHO GLASS system. So what kind of support has IDDS given us? They have really held us strong. In Trans Nzoia County, they have helped us in terms of capacity building of the laboratory personnel. They offer continuous training and mentorship, and they also managed to take 2 of our staff for placement at the Aga Khan University, just to benchmark their skills. They've also helped us in procurement of equipment, AMR surveillance and sensitization. I think we've held several laboratory clinical interface sessions through the support of IDDS, procurement of reagents and consumables. I can confess we have a lot of that. Some is even expiring thanks to IDDS. We need to just pick up the utilization of the laboratory, which we have in the recent past. And then quality assurance aspects, they also help us with that. This was our last laboratory clinician interface that was also supported by IDDS. So in terms of data, this is just a summary of a monthly culture. I chose to focus on 2022. We started at a slow pace and now we are picking up. I think in the recent past, we decided to appoint focal persons in the hospitals in the different wards, just to pick pace, to encourage people to do sample collection. So in terms of samples that we are analyzing, it's a whole range, but we seem to be collecting more blood culture samples as compared to sputum. So maybe we need to up our game on sputum collection. So in terms of where we are finding the samples from, I mentioned that we had to appoint focal persons to bring up the sample collection. So medical ward is leading, and then the OPD followed by pediatrics. In terms of isolate distribution, we are seeing more of Staphylococcus species followed by E. coli. In terms of AMR surveillance in the veterinary section, we did one on poultry, which was supported by the Fleming Fund through ILRI. I'm yet to follow up to see what the results were, but we sampled 106 poultry farms in Trans Nzoia County with the aim of just seeing the prevalence and trends of antimicrobial resistance. Strategic objective number 3, that is infection prevention and control. They started way before the CASIC. We have a vibrant IPC team in Trans Nzoia County. They have done a lot of work. I think since the COVID started, we have trained over 1,500 healthcare workers on matters IPC. And we have tried to have more PPEs available, as well as ensure that waste segregation is done appropriately. So the areas of concern that I have just listed here, we have 2. We are really struggling with surgical site infections, especially in the maternity, where someone comes in and then they develop Campylobacter baumannii from the hospital. So we decided to do follow-ups with the teams in the theaters to monitor. Well, we also decided to do follow-ups to monitor appropriate use of antibiotics for surgical prophylaxis. From the animal sector, we have also done a lot in terms of farm biosecurity measures, disease control through vaccinations, and then also through proper management. That entails feeding the animals, housing, and husbandry. We also did a farm visit to a poultry farm that had a flock of over 22,000 birds, just to check on compliance on biosecurity measures and protocols. We also managed to develop SOPs for animal hygiene in dairy and beef poultry. This was supported by IPNET sometime. That is Dr. Christine Namiti, our Director of Veterinary Services, just showing us some of the materials that came up after they developed the SOPs. We also managed to train dairy dealers on matters IPC, training of food safety inspectors. The training was commissioned by our CEC, Honorable Maria Nzomo. She's very passionate about matters AMR and IPC, so she always gives a helping hand. The trainings were also multi-sectorial, so it wasn't really focused on the people in veterinary section only. Strategic objective number 4, antimicrobial stewardship. We have successfully managed to commission 7 antimicrobial stewardship committees. The first one was at the Kitale County Referral Hospital, and the others are in the sub-county hospitals. So this is just a snapshot of what we did for Kitale County, which was mirrored for the other sub-county hospitals. We started an AMS program, which was anchored under the Medicines and the Therapeutics Committee. It's a multidisciplinary team. And this one was supported through the Pfizer Educational Grant, and it was endorsed by our CEC. So we immediately proceeded to come up with the action plan, which was focusing on the leadership and leadership support, accountability, medicine expertise, to improve optimal antimicrobial use, protocol development, education, and continuous reporting on AMR data. We also did a point prevalence survey in Kitale County Hospital. This was led by Dr. Nancy Koech. She apologizes she couldn't make it, but she's very passionate about antimicrobial stewardship. And of focus, you can see that we had patients who were even receiving up to 4 antimicrobial agents. So basically what we are saying is that we need to put a little bit more effort on antimicrobial stewardship. We did a prescription audit in one of the sub-county hospitals, and of notice was that some patients were on repeat visits and they kept getting the same antibiotic over and over again. So which meant that we needed to ensure that these guys have access to cultures and sensitivity tests. We also had an antimicrobial consumption data or study that was done from the outpatient department in Kitale County Hospital. And we were looking at antimicrobial consumption. This was supported by the Fleming Fund regional grant. And we saw that we were consuming more doxycycline, amoxicillin, followed by flucloxacillin. So this prompted us to come up with a concept note for brucellosis, because that seemed to be the main use for doxycycline. From the animal sector, we are using the CABS mobile application to track antimicrobial resistance and antimicrobial use. We also came up with a template to survey the consumption of antimicrobial agents from the agrovets. I think within a short period of time, we should have some bits of data. In terms of strategic objective number 5, that is in terms of research, Trans Nzoia County won, is it winning or got a trophy from the IPNET conference for having the most number of presentations done, both oral and poster presentations. I can tell you that we have people who are doing a lot of operational research at the county level, and we have a few other researchers that are going on through KEMRI and other organizations, but the CASIC is slowly catching up. So in terms of the concept notes that I was talking about, we have one for brucellosis. I happened to have met a very nice gentleman from FAO, Dr. Mark Nanyingi, and he's very passionate about zoonotic diseases, and he offered to help in developing this concept note. And we are hoping to work with the ZDU, Ministry of Agriculture, Ministry of Health, ILRI, KEMRI, a few other players to actually bring results from this concept note. Then we also have one that is also coming up for antimicrobial stewardship and diagnostic stewardship. We are yet to identify our stakeholders or the partners to collaborate with, but I'm sure we should be there sometime soon. Now, finally, to where we started the CASIC. Si tulianza na kazi and then sasa vitu zingine zikatupata. So the CASIC was launched in January 2020. This was just when COVID was starting to hit us. So a lot of our CASIC members were reassigned to other tasks. I know our laboratory person, Sunday is somewhere here, he was reassigned to COVID, but he still assists us in terms of AMR. So we had an inception meeting that was supported by IPNET Kenya. We did a SWOT analysis of how our county was, and in terms of strengths, weaknesses, opportunities, and threats. And we resolved that we shall come up with our county work plan, which shall run from the year 2021 to the year 2023. So some of the activities that we have done are already part of the activities that we were supposed to do in the county work plan. So we are somewhere in terms of implementation. The CASIC, through the funding from CDC, USAID, and FAO, met in Nakuru in 2 sessions to deliberate on the activities that should be included in the county work plan. And eventually we came up with a very beautiful document that was commissioned by our CEC Health and the CEC for Agriculture. And they promised to give us full support and also hand over appropriately to the next county government, should they not come back in office. Yeah, so this was one of our meetings on 31st March 2022, just before we launched our work plan. So eventually we launched our work plan on 12th of July 2022 in a very beautiful event that was facilitated by FAO. And we would like to thank them very much. That was helped through Dr. Ruth Omani, who I met some time back when she was working for, was it Cargill? Yeah, yeah. So in terms of challenges, we do not have funds. Hiyo tu ndo all the counties are complaining about it. It was very difficult to include some of our activities in the county work plans, but we successfully managed to include some of them. And we are hoping to make it into the CIDP so that we eventually have a vote. And then we also have limited capacity for AMR surveillance in animal health due to lack of an equipped lab. I paid them a visit and their laboratory had a motorcycle in it. They didn't have any equipment in there whatsoever. So we are basically relying on the regional laboratory for AMR surveillance in the animal sector. Then we have low utilization of the bacteriology laboratory by the clinical team. Kila siku we are being scolded by Joshua Odero. We are doing poorly, but you can see we have an upward trajectory, and we can promise that through the CASIC, we will motivate the county teams to utilize the laboratory more. And then we also have a Vitec 2 machine, which was not on service contract, but thanks to IDDS, we were able to renew it. We are hoping the new county government will take up the matter so that we do not stall at some point. And then budgets are not committed to procure adequate reagents and consumables. As I mentioned, IDDS has really handheld us, wametusaidia sana, but should their term end, we shall be caught flat-footed. So basically, we need to address that challenge immediately. So what lessons have we learned? You may ask that question. I think from what I have learned, you first start. You just start from wherever place you are. Just start. And then once you get the rhythm, then you will have gotten it. I know initially it's very difficult to get the different teams to coordinate. It's very difficult to coordinate the human health. Now include other sectors like the veterinary, agriculture, environment, trade, it becomes a little bit tough, but the learning curve will eventually give, and then eventually things will work out. And then we also need to embrace a referral system for the peripheral facilities, just so that unajua AMR haiko in the main facility only. AMR can be anywhere. So we need to utilize even the data from the periphery. We need more data to help us come up with antibiograms. This will at least aid us in treatment selection in the hospitals. And then also we need to embrace joint studies between the human health and the agriculture. There's any endless opportunities in that arena. Thank you very much.
Thank you very much, Dr. Zaitun. I think something that has come out very clearly is the passion, isn't it? If I use my passionometer, her passion for AMR is somewhere huko juu, si ndio? Yes, and that is what we want. Yes, if we don't have the passion, going to the extent of using her money for organizing an activity, my friend, some of us cannot even attempt that. And I'm very impressed by the One Health approach that they took. I think it has come out very clearly, isn't it? Yes. Despite the challenges they're having in terms of financial support, but they embraced the One Health approach. I want to believe you have very many questions for Trans-Nzoia, isn't it? So just write somewhere. We are going to move to Kiambu County, and I want to welcome my colleague, Dr. Kagwa. Is he around or someone else presenting? Welcome, Kiambu County. Karibu.
sorry. Apologies from Dr. Kagwa. He's actually our focal AMR person in Kiambu County, but he had an urgent meeting to attend to. He's also our County Director of Health. So I'm doing this presentation on his behalf. So I hope I will not have many questions. This is actually his presentation, and it's going to be a short one. And we'll just see what Kiambu County has done. On the successes and achievements in implementing the objectives, from objective 1 in improvement of awareness, we have an active CASIC. I think like Trans Nzoia, Kiambu County CASIC came way after the facility EMR teams. They are actually appointed last year between May and November. And so they are still work in progress, and they have done their work plan, and it is just about to be launched anytime, hopefully before, I hope elections will not disrupt the current CASIC team and their activities and their plans. So that should be done anytime soon. From the facilities, we have had induction training of AMS members, and this was done in 2020. Our AMS is 2 years old, should be 2 years old next month, especially in Thika level 5. So we had support from our partners, and we were able to do induction training. And from there, we have done awareness of AMR to the hospital staff through various facility CMEs, including targeted CMEs to clinicians to just improve laboratory utilization, especially of microbiology, in microbiology, because there is very low uptake of culture and sensitivity. So we have also participated in the WOW Week as Kiambu County, especially in Thika level 5, Gatondo, Kiambu level 5, and various other hospitals. We have been able to educate the public and raise awareness within the hospital, and even through a walk in Thika Township. So we have participated, I think, for 2 years now. We have also participated in various conferences where we have showcased our work that we have done concerning AMR. And the latest one was in the IPNET conference that was there in this year, May. There has been mentorship and capacity building of laboratory staff in microbiology. And we really thank the Aga Khan University Hospital for really taking up our microbiologists and mentoring them and doing a lot of capacity building. Now we have a lot of good work that we are seeing from what they have gone through. And this was also thanks to the Fleming Fund. In strategic objective 2, in terms of surveillance and research, Kiambu County and the CASIC here specifically, they participated in the citizen-generated data study, which was a great success. And this one incorporated animal health, the human health, and yeah, it was a great success. There has been a point prevalence survey on antibiotic use, and this Thika level 5 hospital was one of the 7 hospitals that took part in the PPS study by UN and MOH. And the results, I think, some of which we have already seen. There has been participation in the eco platforms where there's been great sharing of information, participation in terms of presentations, and mentorship of our staff. There has been facility antibiotic utilization surveys in many departments, ICU, outpatient department, in the inpatient department. I'm sorry, we don't have any results to show for that, but they have been quite good in giving data of what's going on in terms of antibiotic utilization. There was a study of SSI surveillance on post-dissection infections in 2020 between June and November due to the and availability of funds. It was a short study that really revealed a lot. About 10 to 19% of C-sections end up coming back because of infections. So we're really, as IPC, they're really trying to see where the challenges were. And there's actually another study that Thika Level 5 will be participating in on SSI surveillance for the same, which is about to begin. Strategic Objective 3, in IPC, we have an active SIPCAC, which is also in its infancy. Recently appointed members, they have come up with an IPC work plan for the county, which is really good because the county is aware and they will factor in the activities in the budget. This has been a great activity, and it will go a long way in implementation of IPC practices in the county. Regular hand hygiene audits, these ones have been ongoing for a long time. IPC has really taken root in most of our facilities in Kiambu County, even before AMS teams came up. And so they have been doing a lot of hand hygiene audits and other IPC strategies to just reduce infections in the hospital. So there's very good work from the IPC team. There's availability, although of IPC protocols. Supplies, we have challenges with supplies in terms of consistency, but we are working with what we have. We have equipment and infrastructure that most hospitals have, thanks to COVID-19. We have really improved. There's also improvement in sanitization with segregation and disposal practices, just as part of IPC practices. In Objective 4, in terms of antimicrobials in human and animal health, clearly my presentation is mostly on human health. Our animal health part of it was not included in this presentation, but a lot is going on behind the scenes. And in terms of antimicrobials in the hospital, we have adopted the aware categorization of our antibiotics according to the KEML 2019. And we are now picking up data on how our utilization is in terms of the categorization. There's implementation of stop orders for antibiotics by clinical pharmacists. In Kiambu County, we are privileged to have quite a number of clinical pharmacists. And so during the rounds or during the reviews by clinical pharmacists, they're able to do a lot in terms of looking at the appropriateness of antibiotics, the dose, the duration, and really do a lot in terms of being on the lookout for any issues. There's restriction of third-line antibiotics in Thika Level 5 and Kiambu, which is limited to the prescriber, especially in Kiambu Hospital. Only consultants are allowed to prescribe third-line antibiotics, or you have to have culture results, or at least have taken culture for analysis before you're given third-line antibiotics, or there has to be a review by the clinical pharmacist. Strategic Objective 5, in terms of diagnostic tools, we can say that in Thika Level 5, there's an upgrade of the microbiology lab where they really improved our infrastructure. The equipment in the laboratory, in our laboratory, is state of the art. And even in terms of commodities, thanks to the Fleming Fund, we can now be able to do quite a number of cultures, including blood cultures. In terms of challenges, human resource is really a big one, where required specialists or disciplines in the CASIC or the MS team sometimes is lacking. The uptake by our colleagues, especially in the hospitals, the consultants or the physicians sometimes is lacking. It is sometimes seen as a pharmacy kind of activity. So some really just sit back. And so we are really trying to do a lot of advocacy to our colleagues. And also in the CASIC team, there's, in terms of representation, sometimes competing tasks, they're not able to do their meetings in good time. And also that slows down implementation of a lot of activities for AMS. Limited technologies for diagnosis. This one is for the clinicians. Sometimes they don't know what's going on with the patients. So it's easier to just prescribe antibiotics because maybe other diagnostic tools are not available in the hospital. Also, ICT software for patient management and data collection is a challenge. If we had a good software system where we can be able to analyze, first of all, get all our data together and be able to analyze that, it will be much easier to do research. Inadequate resources, I think that one cannot be overemphasized. Just to run AMS activities, conducting audits, surveillance, getting antibiotics, improving our range of antibiotics, laboratory supplies. Yeah, we lack in all those resources, but again, we work with what we have. Sorry. Low uptake by clinicians of laboratory microbiology services. This one I alluded to. And so we are reaching them through CMEs and other means. Inappropriate prescribing practices, therefore follows. If there's no proper use of our labs, then we get a lot of inappropriate prescribing. We do not have a facility-specific antibiograms or standardized protocols and guidelines, or even data collection tools. And this is really in our bucket list as the AMS team to use the data that we have to come up with some of this. Ease of access of antibiotics from community pharmacies. This one cuts across, really. So experiences, what we have learned so far, and we are glad that the county and the hospital management teams are able to appoint and recognize the importance of AMS. And really, we are seeing a lot of support coming from the national team to the counties and even the hospital teams. And this goes a long way, even in inclusion of these activities in the budget. So we are also really grateful for support from the Ministry of Health, the NASIC, the CASIC, the partners, all the partners. They really do come in handy. Like I have mentioned, some of the challenges include finances. And so with this kind of support, it gives a lot of morale to the teams, and we're able to implement a lot of the things that we have in plan. We have also learned that public awareness, including education to hospital staff on AMR, should be continuous. We cannot do a one-off thing. We cannot do a wow week and think that is enough. It needs to be continuous. It needs to be regular. It needs to be consistent for us to realize good fruits. We have efforts towards development of antibiograms and institution-based protocols for managing common infections. We really need to work on this. And like I mentioned, this is in our bucket list. operational research in antibiotic use and IPC practices is key, really, in ensuring that we have practice that is evidence-based. So within the facilities, within the county budget, we can be able to do some of these operational researches that do not really require a lot of funding. And then, of course, if we get funds, it will be a good thing because we'll be able to increase our antibiotic selection and range. Our IPC supplies will be able to be consistent. Laboratory will never say they do not have bottles for culture and other technologies for diagnosis, just to ensure that AMS activities are sustainable. And all in all, we have started small. The journey ahead is long. We're looking forward, and we have learned that every step counts. Thank you very much.
So thank you very much, Kiambu County. Every step counts. We are 47 counties and we are only talking about 14, isn't it? But the other counties just know that every step counts. So start somewhere. Start somewhere. 14 out of 47, we need to do something. Thank you very much, Kiambu, for showing us the uptake of CST and the role the clinicians and the clinical pharmacists are playing in your various facilities. So if you look at the timetable, we are meant to take about 1 hour for this session. So the next presenters kindly try to summarize so that we don't leave this place late. So I want to welcome Murang'a County. The next presenter is Dr. Lois Kariuki Wamahiga. Karibu.
Good afternoon. Good afternoon, everyone. My name is Lois Kariuki. I come from Murang'a County, and I'm the AMR for Kopason. I'll go straight into what we've done to achieve our objectives. First of all, on public awareness and improving awareness and effective communication. First of all, let me mention, we have a CASIC in place with a work plan in place. So through our work plan, one of our activities was to establish a TWG for AMR awareness. And we have an already established AMR TWG awareness, led by the County Health Promotion Officer. We've also been able to train professional key stakeholders on AMS and IPC through this TWG. And last year, during the WOW week, we were able to celebrate it by holding CMEs across the county. We were able to have 4 CMEs in 4 sub-county hospitals and CMEs in the county referral hospital. We were also able to have health educational talks through community dialogues. And during that week, we were also able to launch our CASIC work plan. The strategic objective number 2, strengthening the knowledge and evidence base through surveillance and research. I can say that we have, way before CASIC was launched, we have been able to do audits and surveys in at least 2 main hospitals in the county. We normally do quarterly outpatient audits, outpatient prescribing audits on the prescriptions from outpatient departments. We've also been able to do PPSs. I think the first PPS in Murang'a County Referral Hospital was in 2017. And last year we were also able to do another point prevalence survey. After we do these audits, we always accorded the opportunity to disseminate the findings. to, first of all, to our hospital MTCs and to other healthcare workers through CMEs. We've also been able to develop our hospital antibiogram just in Murang'a County Referral Hospital. And I really want to acknowledge our partners who have really supported us to do this, the USAID MTAPS program and IDDS, plus our county administration. So down there is just an example of one of some data from an audit we had carried out. I'll probably talk about it later. The next thing we've been able to do was to strengthen our laboratory testing capacity for AMR. And this has been greatly supported by USAID IDDS, and we really appreciate their support. We've been able to provide continuous mentorship to our laboratories. When they came in, we had about 2 members of our laboratory of our lab who would be able to conduct bacteriology services, but that number has gone up to 6 members. Actually, there are 9 members, only that 3 members have been assigned other duties. We've also been able, last year we were able to come up with an antibiogram for 2 main pathogens, Staph aureus in wounds and pus, and E. coli in urine. We've also been able to establish an efficient referral system from the other facilities to the main laboratory in the county referral hospital. And there's continuous sensitization for all the other satellite sites to be able to get advantage of what is going on in the county referral hospitals before we empower their laboratories. Sensitization is continuous, even to the sub-county lab coordinators and clinical officers, and also other healthcare workers, including prescribers, on collection of bacteriology specimen. And just to mention that our lab is ISO certified and has also been able to get external quality assurance from IQWI Africa and also from the National Public Lab. And we are performing very well. The last time we were audited, we were above 90%. And also to mention that despite our achievements, our lab is not really automated, and we've been able to greatly achieve a lot despite the fact that we are not automated. We've also been able to promote utilization of bacteriology services by holding CMEs on diagnostic stewardship in various facilities across the county. In IPC measures, objective number 3, number 1, we've been able to strengthen IPC governance. We have a very vibrant and active IPC committee in the county, and I want to acknowledge our IPC focal person. She's here with us, Dr. Florence. We were able to inaugurate our SIPCAC last year, and we were able to finalize on our SIPCAC work plan. So the IPC as a committee has a work plan in place and the activities they're supposed to carry on for the next 2 years. We have also been able to establish IPC in various facilities across the county. And as we said, there was a silver lining to COVID. COVID really came in handy. We've also been able to capacity build on IPC, especially with COVID. We were able to train across the board, TOTs, CQI auditors. We were also even able to train members of the public. We went to churches, we went to schools, we talked to head teachers during the IPC COVID-19, during that COVID-19 pandemic. We really strengthened IPC. We've also been able to do a lot of monitoring and evaluation. For example, we carried out a baseline survey on IPC preparedness in level 4 and 5 hospitals. And also we've been able to do surveillance on HAIs and SSIs in Murang'a and Maragua Sub-County Hospital. On strategic objective number 4, optimization of use of antimicrobials, we've had establishment of MTC and AMS committees in 2 main hospitals, and we are trying to push at least to 7 hospitals within the county. So Murang'a and Maragua already have active and vibrant MTCs and AMS subcommittees. We've also been able to train the members of those committees, at least about 40 members of those committees. We've had 2 trainings on the same. And we've been able to develop and create and distribute and display IEC materials on antimicrobial stewardship and how to use our antimicrobials properly. And through the support of MTAPs and the county, we've also been able to hold quarterly county supportive supervision on AMS and MTC and IPC within the county. So this is just a result of an audit just an example of audits that we carry out. These are just some findings of the antimicrobial subcommittee in Maragua, something they had done on use of IV start doses of ceftriaxone in the hospital. So they were able to collect data from the antibiotic register in OPD. And initially when they were starting this audit, that was in June last year, there were about 108 IV start doses of ceftriaxone, 116 IV start doses of gentamicin and benzyl penicillin. Then through the clinical pharmacists and through their MTC, the results were brought back to the hospital MTC, and the MTC was able to discuss and come up with policies stopping and halting the use of IV start doses. And how they did this, they came up with posters. They developed posters, which they put up in all the consultation rooms in the OPD. And they did a post-intervention analysis again. That was in July. And you can see in July, there was such a great and marked change from 108 IV start doses of ceftriaxone to 10, and later to 4. That was in August, a month later. So I decided to share this to just show you AMS in action and what we can achieve through AMS. And through our small antimicrobial stewardship committees, you don't really have to do a lot. You don't need big data, you just need to start small. And through this, we were able to develop an IEC material, a poster, that is what is shown there. And we've been able, through the support of USAID MTAPs, and we've been able to distribute this across the county. And we've also displayed them in conspicuous areas in our OPD and casualty departments. So these are just photos showing the trainings that we've been able to hold, the dissemination of IEC materials, and our quarterly supportive supervision. You've noticed I've not really talked much about agriculture and animal health. Maybe I'll talk about it when we come to our challenges, but we've also been able, despite the challenges, we've been able to do some things together. For example, we had our CASIC launched last year. We've also been able to, establish TWGs within the CASIC, and we've been able to ensure that appointment letters have been given. We've also been able to hold our first meeting together. And our CASIC is quite interesting because we had onboarded environment already from the beginning. And we also realized that we need to onboard some other people who are quite crucial, especially in the county. We brought in someone from the county assembly because in the event our partners are no longer there, we really need budgetary allocation from the county assembly. And we really want to, first of all, one of the things we really want to do through our work plan is to sensitize our MCAs. Hopefully when we get the new county government, which I know Muranga, we are getting a new, we are going into a new dispensation, we'll be able to sensitize them, and it can also be easy for us to lobby for budgetary allocation. We've also been able to jointly develop a proposal for conducting a baseline survey on antimicrobial consumption and use in community pharmacies and agrovets across the county. And we are calling upon partners to support us with this so that we can do it jointly, so that we can have some baseline findings. So that's just a photo showing the launch of our CASIC work plan, and plus how we launched our CASIC, the CASIC in Muranga County. to the challenges and experiences that we've had so far. Just the common ones: erratic supplies of commodities, IPC commodities, antimicrobial supplies, which really drives, if you have erratic supplies, it will drive you towards certain antibiotics that probably you're not supposed to use, including lab infrastructure and space. We have limited resources in terms of limited resources for conducting supportive supervision and trainings, public outreach. We've not really been able to reach out to the people of Murang'a. We really wanted to look out for a slot in one of the local radio stations. We've not been able to do that. We also don't have an information management system. And of course, as I mentioned, infrastructure. We also would like to highlight that only 2 sites are supported in Murang'a for IPC and AMS, and would really appreciate if more sites would be supported. Meanwhile, we are going to work with what we have, and we are going to spread across the county slowly and step by step. Limited administration support, just as my colleague, Dr. Salome mentioned, sometimes you don't have buy-in from everyone, everyone with all stakeholders. They really believe AMR and AMS and IPC are pharmacy-driven agenda, and not everyone will onboard, and we really need everyone. For example, I'd give an example like Murang'a. We have an MTC in place, but we really don't have a chair or someone to spearhead, because they probably believe just the pharmacy department should do that, yet we need the physicians and all the prescribers on board. Our experiences has been, and our lessons, as I mentioned, it is important for all of us to get sustainable ways of surviving beyond partner support. As I mentioned, this is a county affair. We need to also engage the politicians and engage everyone on board in the county, so that we can be able to survive. And it's not that we are writing off our partners. We just need to survive even on our own. We can't forever live on milk from our partners. So political goodwill is also very important, as I had mentioned, and buy-in, so that we can also it would also make it easy for us to lobby for allocation for our activities. Need for induction is equally important, because especially in healthcare facilities, we have new people coming in every 6 months. Every year we have interns coming in. So it is important for us, and what we've realized, it's important for us to have an induction program on IPC, on AMR, so that we can continue being consistent in the gains that we have made and the gains we are going to make. And just to mention, the last but not the least would appreciate partner support for our departments of agriculture and environment, so that they're able to kick off their their activities also, and that we are able to work collaboratively. So thank you so much. Yeah.
Thank you very much, Murang'a County. I think what is coming out clearly is that you must start small and get somewhere. And that is what we are seeing from Murang'a County. And I really like the issue of the AMS in action, just focusing on the issue of IV start dose. And they were able to make very serious interventions. So I want to believe we'll have to be patient. We finish and ask questions. So without wasting time, want to welcome Kisumu County. Who is the presenter? Yes, welcome. We know we are not doing well in terms of time, but again, this is a very important discussion. So you'll have to sacrifice, my brothers and sisters. Sindio? Yes. I know you have other competing tasks or duties, but you'll have to sacrifice. We want to bring the AMR agenda to another level. So it requires some commitment and sacrifice. So we'll have to go beyond the time indicated in the timetable. Welcome.
Good afternoon, everyone. My name is Mitchell Okumu. I'm the AMS focal person for Kisumu County. And I have been accompanied by the IPC focal person, Mr. Ephraim Odeng. And today we'll be presenting the successes, challenges, and lessons learned from AMS IPC activities in the county of Kisumu. Now, Kisumu County is located in the western part of Kenya with about 1.2 million inhabitants, according to the census report of 2019. And we have 7 sub-counties, that is Muhoroni, Nyakach, Nyando, Kisumu East, Kisumu Central, and Seme. And USAID MTAPs have been supporting 6 out of the 7 sub-counties. And I would really like to appeal to them to support the Muhoroni sub-county so that it could be complete support in the county. This is a brief background on some of the AMR profiles based on some studies that have been done in Kisumu County over the last 2 years. And you can see that resistance has been reported for the penicillins, the tetracyclines, the fluoroquinolones, the macrolides, the 3rd generation cephalosporins. And what caught my attention was this case in Uzima University, where the isolated Staphylococcus aureus from mobile phones of students, microbiology and biomedical laboratory students. And they found that even vancomycin, the Staphylococcus aureus was resistant to vancomycin. And as we are well aware that vancomycin is a reserve antibiotic. So as far as the objectives are concerned, so far we have been able to do AMS and IPC training supported by USAID and MTAPs, USAID MTAPs. We have done a World Antimicrobial Awareness Week activities, and we've done CMEs and patient health talks. With regard to the strategic objective 2, that is strengthening the knowledge and evidence base through surveillance and research. We have been able to do some point prevalence surveys, and some of the results were shared here earlier. We have also been able to develop antibiograms in the hospital, and we have disseminated the findings. We also do regular antimicrobial consumption and audits. And we have also been able to do diagnostic stewardship and strengthen laboratory capacity. However, we still have a few gaps, which my colleague in IPC will go into the details. So I would like to invite the IPC coordinator to take up a presentation of the subsequent strategic objectives. Thank you.
Thank you very much. My name is Ephraim Odeng, the IPC coordinator in Kisumu County. I'll continue from where Dr. Mitch has left. Strategic objective 3, reduce the incidence of infection through effective sanitation, hygiene, and IPC measures. We have conducted hand hygiene audits, and these are being reported on monthly basis from a number of our facilities. And we have also improved on the infrastructure for hand hygiene. Most of our facilities, we have ensured that there are several hand hygiene infrastructure sites improved. We have really had challenges with incinerators. We have 4 incinerators in the county, but none of them have been functional in the last 6 months. We have just had one renovated in the last 1 month, which is now functional at Lumumba. And this is a great step to ensure that shops are incinerated at the right time. There is adequate provision of hand rubs and all facilities in the county are able to access this adequately. There's enhanced stakeholder engagement for capacity building in IPC. And in the past few months, we have trained quite a number of healthcare workers. MTAPS helps us to train 35 healthcare workers. And we have also had trainings supported by other partners. We have conducted IPC audits in 71 health facilities in the past 1 month. This has been quite strenuous for the health workers because it is not very easy to conduct IPC audits. And this, we will be able to share this data in the next few weeks. Strategic objective number 4, optimize the use of antimicrobials in human and animal health. What we are going to present here is mainly done in the human health. We did not have inputs from the animal health. We have had MTC and IPC committees established in focus households, especially the 8 MTAP supported facilities. We have also had AMS activities supported in one community pharmacy in town within the town center. And quarterly AMS IPC supportive supervision is being conducted. And this has really boosted the activity of these particular facilities that are being supported by MTAPs. There are AMS-centered ward rounds, especially at the main hospital, that is the main referral hospital at GOTRH, where the clinical pharmacists are very much supportive in ensuring that there's appropriate use of antibiotics. Our major hospital, GOTRH, came up with a formulary that was developed with support from USA MTAPs and was launched in the month of May. And this is a great step in ensuring that there is appropriate use of antibiotics. We are conducting surgical site infection monitoring at GOTRH, KCRH, Hero, and Kumbewa. These are the facilities that are having theaters. This is being conducted mainly in the maternity wards for post-cesarean section patients. These are some of the photographs from some of the activities that we have had in the county in terms of IPC and CASIC. The first photo there is when the MTAPS team met the county director of health. And the second there is the CEO of GOTRH during the launch of the formulary. And the others down there are still talking on the same. Objective number 4, optimize the use of antimicrobials in human and animal health. I think I've talked about this. And I just want to add that the One Health CASIC was inaugurated on March 2022, and a work plan is being developed that combines agriculture and environment together with health. The One Health AMR focal person has been appointed, and he has just spoken to you. Sorry, the One Health AMR focal person has been appointed, and this is cutting across for health, agriculture, and environment. One Health CASIC action plan currently in development with the support from USA MTAPs. The photographs there are some of the photos for the CASIC inauguration and work plan development. You can see Dr. Zegale there, he was our guest during the launch. And the lower pictures there for the work plan development, the various groups that were represented, health, agriculture, and environment. The challenges that we have experienced in implementation of AMR National Action Plan. Number one, as several officers exit the service, either through retirement or getting other opportunities, there has to be movement of staff. And this really affects especially the people who have been trained. Then there's regular AMS, IPC, MTC meetings because of the various commitments that are cross-cutting. There is generally resistance to AMS and IPC interventions. You find that while we have really tried to sensitize members of the healthcare team, there are various, still a number of healthcare workers who have not been sensitized and really resist these interventions. And for example, you will find some senior consultants still insist on administering antibiotics for SVD mothers, use of surgical blades for shaving before surgery, and this really interfere with the implementation. There's poor waste segregation practices, and I've mentioned the incinerators were not in very good state, and the burning chambers, most of them are not in good state, but this really need to be worked on so that we are up to the task in ensuring that the safety of the public and the healthcare workers. There is very minimal use of the prescription pads because they are unavailable, and there's low fill rate, and this really need funds to be able to put in place and implement. Culture and sensitivity is only done in our major referral facility, that is JOTRH, and then Avenue Hospital, which is one of the private facilities that is being supported by MTAPs, and this leads to slow turnaround times. This really also needs to be improved. Our experiences, the lessons learned, human and financial resources are most important resources. Without this, it will be very difficult to ensure that AMS and IPC activities are upscaled. And therefore, we have to invest in human and financial resources. We need to really incentivize champions in AMS and IPC, because this will be very motivating, and the people who have given their time to improve in these areas will continue to provide better services. We have worked with some of the local NGOs like SWAP to improve and find solutions for the shortages for some commodities like jig that we have been able to generate in Nyakach and Nyando sub-counties, and this has really helped us in ensuring that these commodities are available throughout and are in use. The need to include all other stakeholders in matters of AMR is very, very important, as I have already talked about. And evidence-based practice is the best way to change human perception, because if we don't have evidence, then most of the time you will find you are not able to convince the teams to provide the care. And that brings us to the end of the presentation. Thank you very much.
So thank you, our colleagues from Kisumu. The uniqueness about AMS-centered ward rounds. Good, we are going to have the last presentation, and then we do questions. So Kilifi County, karibu. Once we are done with the Kilifi County, Nyeri will share their AMR action plan implementation. and then we'll have time to ask questions. We shall be done with all the presentation at that time. So can someone, did we have an energizer? Someone to help us do some exercise kidogo tu as we wait for Kilifi County. Anyone who is touched from this side? Yes, please. Thank you. Thank you. So, karibu.
Good afternoon. I will be representing Kilifi County. My name is Aisha Mongi. I'm here with my colleague, IPC focal person. Maybe she can just wave, Florence. So by profession, I'm a clinical pharmacist, and I am also the county AMR focal person, newly appointed, exactly 1 week old today. So I think being in this forum today is like nimepata the best orientation package, nimepata leakage kwa mtihani mgumu, lakini I believe we can be able to do something. However, by virtue of being a clinical pharmacist, AMR is part and parcel of us, so it's not something new for me. So I'll be able to take you through what Kilifi County has been doing. So with regard to strategic objective number 1, improving awareness and understanding of AMR through effective communication, education, and training, where I was trained, I was also a facilitator in this process. We've had trainings, capacity building, mentorship sessions conducted on AMS and also diagnostic stewardship, also on IPC. We've also had formal trainings and sensitization workshops, which are conducted to support and strengthen our AMS, MTC committees, and also the CQI committees. And through the IPC committee, they were able to train healthcare workers during the COVID-19 pandemic on IPC. And this was supported by the national, the county, USAID, MTAPs, and IDDS. We've also had CMEs with regard to AMS, AMR, simple health talks. These were done by our colleagues where they have direct patient interactions when the patients are waiting to be seen in the queues to see the medical doctors or waiting for their drugs. The pharmacy staff could come out and just talk to the patients directly. Simple issues, just how to take your antibiotics, umuhimu ya following the frequency, finishing the dosage. And the beauty about health talks, it doesn't require funding. Something that can be done. Then there was the WOW week. I was lucky to attend last year. I actually came on my own just to see what's happening. However, at the county, they did have different activities. You can see there was an healthcare workers from Kilifi County Referral Hospital. They had CMEs on AMR awareness to commemorate the WOW week. Now, to move on to strategic objective number 2, the IPC team, they've been able to conduct baseline and midterm assessments. And we also have ongoing research proposals. These are at the primary stage on antibiotic prescription audits, PPSs, and also rational drug use. This is being supported by USAID and MTAPs. There's also regular antimicrobial consumption and new surveillance exercises conducted with feedback. I think this process has been adapted into the routine work at Kilifi County Referral Hospital. Still on objective 2, the AMS and diagnosis stewardship mentorships have been ongoing, being supported by MTAPS and IDDS. And in Kilifi County, we are lucky. In Malindi, we have our East African Public Health National Laboratory, which is ISO certified. And the lab did well when they did a baseline assessment of the lab AMR testing capacity, which was done in 2019. So they're able to do both automated and manual. Their bacteriological capacity has also improved through the technical assistance and provisions of equipment and reagents from USAID IDDS. So with regard to culture and sensitivity, we never lack reagents. We've been getting very good support from USAID IDDS and very good equipment. So there is also just showing pictures of some of the stewardship trainings and sensitization sessions that have been ongoing. There we have Dr. Nkatha during one of the sessions. I'm also there. Just this is we're having on MTC AMS, and that's our lab person. And this was really important because we realized there has been a big gap between lab and the clinician. So we have been trying to bridge that gap. Then on strategic objective number 3, with regard to IPC activities, we have a SIPCAC. There's been trainings, there are formal appointments. They even have a developed work plan. They have also developed and established hand hygiene programs in all the health facilities. And also implementing the surgical site infection bundles has been ongoing in selected hospitals. Then in strategic objective number 4, with regard to optimizing the use of antimicrobials in human and animal health, our CASIC is there. The members have been appointed. They have a costed work plan which was launched last year, which was supported by USAID, IDDS, and FAO. I had to highlight blood cultures in red because blood also is red. However, we are now doing blood cultures for the first time in Kilifi. We never had this. This has always been a problem where a patient comes in with sepsis, you just go for the common ceftriaxone, you hope for the best. But now with blood cultures, I believe we are going to have change of therapy. And this was supported by USAID IDDS and Biomirios. Then diagnostic stewardship is coming up well in Kilifi County. With support of USAID MTAPS and USAID IDDS, there's more collaborations. Even yesterday, I think they were having a CME on the same. And this has bridged the gap between the lab being on their own and the clinicians being on their own. And now we are sharing more data together. So these are just some of the photos when we were launching the CASIC work plan for 2021 to 2023. Our CEC is there. And these are just slotting in one of the data that was presented to us when we had the diagnostic stewardship CMEs with the lab. This is our own data. This is from this is Malindi data from the outpatient, the samples which were sent. And when this was shared with us, it brought a lot of conversation. And for example, you can see this is a sensitivity patterns of Staphylococcus aureus isolated from past swabs and the sensitivity patterns. The orange is resistant, the gray is sensitive. So when we were looking at that, we even realized like clindamycin is quite sensitive, yet we were not stocking clindamycin. But as of today, we are actually stocking, and clindamycin is an access drug. So that conversation, the fact that lab shared this, it prompted some actions. And that's our lab. They are very proud of it. It's ISO certified. And this is the microbiology department. Now, on objective number 4, to optimize the use of antimicrobials in human and animal health, I am yet to meet the focal people from agriculture and livestock. However, with this objective, we revived our hospital MTC's AMS, which had become dormant. Formal appointments were given. The focal persons were appointed, both in health and agriculture. And small interventions were done, like revision of our antimicrobial tools. For example, our prescription pads. We discovered if you want to carry out a prescription audit, our prescription pads did not have a place where the prescriber would write, why are they prescribing the antibiotic? Is it pneumonia? Is it tonsillitis? So if you want to do an audit, it would be hard for you to critique or to find out why. So our MTC secretary was about to print, and we decided to change and just add a small place where diagnosis has to be written. So this will help in our audits. And then also from the lab, there was an outcry. We cannot use the same general lab request form. We need to make special microbiological lab requests such that there's even a place where the person, the clinician who is requesting can even indicate what prior antibiotics the patient has used. So that is something that is being discussed. Then the quarterly county AMS supportive supervision visits have been ongoing, where they provide technical assistance and mentorship to healthcare facilities. And here are just some pictures. County leadership for MS IPC supportive supervision, county with the USAID MTAPs, where they come, we have a sitting, we discuss where are we, what are our achievements, what are our gaps, and what can be done. And now we move to the challenges. So the first one is the CASIC and the SIPCAC. They are there, however, the meetings are not consistent. That is something we'll have to see how to mitigate and make them more consistent. Then another thing is now county supervision of AMR and IPC activities are not optimal. Of course, this will occur if the meetings, if CASIC and SIPCAC meetings are not consistent. Definitely the supervision also would go down. Then there has been a lack of coordination between AMS, MTC, and IPC committees. Sometimes we are running like 2 different entities, yet it is the same thing. So there was a discussion of, during our meetings, we need to incorporate each other, but some members find themselves, they are members in both committees. Then another issue that arises is lack of the current national standard treatment guidelines so that we can adapt them to be used locally. We are still waiting for them because currently everyone is using either the old format or when you go to Mr. Google, you see which one you feel can suit you. Then our medicine formulary, we've not yet adapted it, which of course has affected. We have not yet done our access watch reserve classification. We were waiting for the national one. I think it is there. Once we have it, we need to customize it for our own use. Then the IPC committee, there is the audit tools. They say they are too bulky and the monthly audits are not done consistently. And last but not least, I think this is maybe for everyone, competing tasks. As much as someone is chosen as the AMS or IPC focal person, sometimes they're not consistent because they consider this as an extra task because they have other duties they are doing. But other than that, this I would say is the lesson learned. I didn't put so much on this slide because I felt this sums it all up. To drive the agenda of AMR, there has to be collaboration between health workers, colleagues, with partners, commitment, and teamwork. Okay, that is needed from the ground level up to the top level and vice versa. Only then is when can we move the agenda one step at a time. And that's it.
Thank you.
Thank you very much, Dr. One step at a time. That is the message. And I want to repeat, one step at a time. It is very unique that Kilifi County is among a few counties that have a costed CASIC work plan. I mean costed. Some of us have work plans, but they are not costed. So thank you for that. So we are about to finish. So ladies and gentlemen, we want to welcome Nyeri County. Nyeri is unique because they started this journey ahead of us. So we want to see whether we are catching up or not. You know, it is a marathon, it's not a sprint. So we want to find out whether tunakaribu kufika Nyeri ama bado. So karibu Nyeri County, Dr. Sarah. Yes, Dr. Sarah Kibira, you are welcome to showcase what we've been doing in Nyeri County for the last 5 or so years, so that other counties can try to catch up. Thank you.
So good afternoon. Yeah, my name is Dr. Sarah Kibira. I'm a pharmacist from Nyeri County, and I'm here to represent Dr. Oscar Agoro, who is the county AMS focal person, and I'll be sharing our progress and experiences of implementing the National Action Plan and with regards to our CASIC action plan. So first of all, I need to mention that we started this journey in 2019. Okay, so we are like 3 years old now, and we've achieved a lot. We've also learned a lot, and that will be part of my presentation. So in the strategic objective 1, that is creating awareness and understanding of AMR through effective communication, education, and training. Yeah, we've had several sessions where we have had our health workers from various health facilities within the county trained on AMR and AMS. And this has been supported by our partners on the ground, that is USAID, MTAPS, IDDS, FAO, and county support. It is important to mention that most of these trainings, most of the members were from the health department. But over time, we are also including the other representatives from Ministry of Agriculture, Livestock, Fisheries, Environment. We've also tried to bring on board the representatives from professional bodies and learning institutions. And as in a few minutes, I'll be sharing our challenges in implementing the same. We've also had facility-based CMEs and health talks. And here we have 2 mission hospitals that are taking part in this AMR AMS journey within the county. We also sensitize newly recruited officers on AMS and IPC during induction sessions. And this happens in the facilities. Currently, we've inducted close to 180 health workers, and this includes both clinicians, nurses, medical officer interns, and consultants. So, okay. The other
progress is that we've been sharing our AMS IPC work through meetings and conferences. We've had a veterinary organized a conference where our counterparts have also attended. We've had officers represent CASIC in ECM conference, PSK, HOPAC, and also IPNET. We've also been sharing learning experiences with other counties, and this include Kisumu, Kilifi, Bungoma, Bomet, and Murang'a counties. And this is, it's ongoing. Calls keep on coming, and we are always ready to support them and also learn from them, because just because we were the first one, the pioneers, there's also something good that other counties are also doing, and we are always ready to learn from them. The other one is we've been creating public awareness on AMR through social media, radio talk shows, and also newsletters, and also participating in the World Antimicrobial Awareness Week. And for a while, we've had service delivery level CMEs. This is for the health workers, and also for the patients, we've had health talks, which actually leverage on the national wall activities. So I have two images here. This is the Nyeri County AMS focal person. On the image on my left, this was a talk to the laboratory officers, okay, on AMS and AMR. And on my right, the photo is, this is a publication on the Nyeri County newsletter. This is a bi-weekly newsletter that is published and distributed to the members of the counties, including, the public. And the publication here was on raising public awareness on the use of antimicrobial drugs. This was the first one. We also had a second publication sometime last year. These are the two photos. On my left is a health talk on antibiotic use in one of our facilities, that is Mukurweini Hospital, in the year 2020. And on my right, there's a photo of Dr. Gishomo giving a radio talk show. This was during also WOW. And in attendance, it was also the AMS focal person. So we try to work together. As he gives his talk on animal health, those us in the health sector also have a representative talking about AMS and the impact of AMR. So in strategic objective 2, strengthening the knowledge and evidence based through surveillance and research. So in our facilities, this includes level 3, level 4, and our level 5 facility. There has been antimicrobial prescribing audits that have been carried out since 2019 with regular feedbacks, and this also allows us to draw consumption trends from both public and facility faith-based organizations. So we have one private hospital that actually is active on matters AMS, that is Outspan Hospital. Then we have at least 8 public health facilities and 2 faith-based organizations. The other thing is that through these audits, we are able to learn, the trends that are our prescribing trends, because most, when we receive information from all those facilities, we are able to analyze and see what is happening. In case there is an increase, then we need to know that we need to act so that we can always have the facilities move together. Because we realized, we may not achieve much when one facility is performing very well and the other facilities are lagging behind. We need to coordinate our acts together so that as a county, we move together. We've also carried out point prevalence surveys, and this has been supported by the Aga Khan University and MSD, though we are yet to receive the results. There's also been strengthening of lab capacity within facilities in Nyeri County, And this is in terms of reagents, training officers. These are microbiologists and other laboratory officers on microbiology and sample management. And this has been for both animal and human health. So one thing that is worth noting is that in animal health, they are a bit advanced in terms of sample referrals. You know, we understand that their patients are in the field, yeah? So they cannot be coming to the facilities, yeah? And I think that has necessitated the streamlining of sample referrals, yeah? Yeah, so at the county, we established a county veterinary lab that links to the regional veterinary investigation lab. And through these sample referrals, they have been able to develop antibiograms that actually guide antibiotic prescribing. And they also share this information with the Central Veterinary Investigation Lab. For human health, we have two IDST machines, one at Outspan Hospital and another one at the Nyeri County Referral Hospital that actually will improve, you know, AST in the county. So for human health, there's a lot of patient referrals, but we're in the process of streamlining sample referrals for the convenience of our patients and also so that we can get more data, because one of our challenges has been very low workload. So we have antibiotic resistance trends, but no facility has actually been able to develop an antibiogram per se because of there are various issues. We have reduced workload and also sample collection techniques. And during our trainings in all the facilities, when they're talking about AMS, we also include diagnostic stewardship because they go together. Because initially we noted that most of the facilities, the samples that were being taken for microbiology had a lot of contaminants. Yeah, so we kept on learning along the way and improving the same. So the photo on my left, we have Mr. Patrick Amau, who is a microbiologist at the Nyeri County Referral Hospital. And the machine he's demonstrating on to Dr. Nkatha is the IDAST machine from BD. On my right, we have Dr. Oscar Agoro and representative from USAID MTAPS, and this was during a supportive supervision of AMS, AMR activities. So in implementing strategic objective 3, that is to reduce the incidence of infection through effective sanitation, hygiene, and IPC measures. Yeah, we've been strengthening county IPC governance structures from the county level facilities. That is through trainings, formal appointments, and developing IPC work plan. And I must say, at least we had our first meeting of our CIPCAC members, and we also have an IPC work plan in place. We've also developed and established hand hygiene programs in all our health facilities. And this was also include not only training, but also installing automated hand hygiene facilities and monthly compliance audits. We've also been implementing surgical site infection bundles in selected hospitals. And this also included both training and monitoring adherence to SSI bundles. In optimizing the use of antimicrobials in the human and animal health, yeah, as I had mentioned, we've embraced the One Health approach where we have a CASIC in place, inaugurated I think it was in 2020, but our first meeting was in January 2020, actually. And we have AMS focal persons appointed from health, agriculture, and environment. We've also appointed members, as I said earlier, from learning institutions, professional bodies, and this also includes the Kenya Medical Association. Then we've had MTC, AMS, IPC committees revitalized in selected hospitals, both not only in public, but private and faith-based hospitals. And this has been supported by the county and USAID MTAPs. In the animal health, we've also had the officers from the Ministry of Agriculture, Livestock, Fisheries, and also, yeah, those ones, carry out antibiotic prescribing audits in the agrovets within Nyeri County, because they wanted to first of all even have a baseline, then from there they chart the way forward. I think there's something I need to note that through CASIC, we were able to standardize data collection tools for monitoring the use of antibiotics. And this was supported by Fleming Fund through IPNET, I think, yeah. And where we standardized tool for outpatient antibiotic audits, pre-authorizing antibiotics in the watch and reserve categories. The other one is carrying out hand hygiene audits and surgical site infections, and also surgical prophylaxis. So these were tools that were standardized because we realized various facilities within the health, within the Nyeri County, they had their own data collection tools. So we needed to standardize that for our county so that the data that we have represents, what's happening at the county level. Okay, so we have those tools and also the standard operating procedures for data collection. So the photo on my left, this was the first meeting to establish the Nyeri County, to establish the CASIC, that is Nyeri Antimicrobial Stewardship Interagency Committee. That was in March 2019. The photo on my right, this is during CASIC work plan development in September 2019. And actually the lady giving a presentation was from the Department of Fisheries. So this shows that we developed this CASIC work plan together with the other departments. Okay, and that is our CASIC work plan for the year 2020-2022. And the photo on my left shows the county leadership and commitment towards this cause, because on my immediate right, we have Dr. Oscar, who is the county AMS focal person. Next to him is Dr. Rachel Kamau, our former CEC. And next to her is the Nyeri County Governor, Mutahi Kahiga. He graced this occasion, and that shows there's a lot of commitment from the county towards this cause. Then strategic objective 4, that is optimizing the use of antimicrobials in human and animal health. We've had, through CASIC AMS activities, rolled out in one community pharmacy within Nyeri County. It's very active in matters AMS. We've also had entity-specific AMS continuous improvement work plans developed. We had quarterly AMS and IPC supportive supervision. This is supported by the county and USAID MTAPs program. Then the Nyeri CASIC work plan that I've actually shown. So this photo, this shows a supportive supervision at one of the private hospitals, that is Otspan Hospital, which is within Nyeri County, together with the AMS focal person at the county level, Dr. Oscar, and a representative from USAID MTAPs, Dr. Nkatha. So with, maybe I need to mention something on strategic objective 5, that is research. This presentation focuses on what was in our CASIC work plan. We focus on the 4 objectives. But since then, there's a a lot that has been ongoing in terms of research. And it's important I mention that we've entered into an agreement. We have a MOU with Dedan Kimathi University, and we are looking forward to using this opportunity to promote more research on IPC and AMR. The other thing I need to mention is that we also have a study going on currently through Cambridge Wellcome Trust, focusing on the use of gentamicin in newborns. Okay, so for Nyeri, it started in June, this officially, but they have been actually in other counties for quite some time. So for us, I'm sure within the next meeting or forum, we shall be sharing our experiences in terms of research and development, as far as Objective 5 is concerned. So nonetheless, we've been facing challenges in implementing the AMR National Action Plan. And the first challenge is on the CASIC membership, as described in the National Action Plan. It is important to note that the plan recommends that we have the CEC, that is Chief Executive Committee Member for Health, Chief Officer for Health, and Director to be members, which in our case was not practical due to other competing tasks. The other thing I need to note is that we also considered appointing AMS, IPC focal persons at the county health management team level, because there's a lot that goes on at the county, and we need focal persons to actually follow up some of these activities. The other thing I need to mention is that the NAP had not included membership from service delivery levels, which we actually considered. And in our CASIC, we actually have representation from health facilities. We have one level 4 and one level 5 facilities represented in the CASIC. Yeah, and this one has actually helped us because they serve as the link between the CASIC and the health facilities, because most of the activities that actually happen at the facility level are guided by the CASIC work plan. The other challenge is on financing IPC and AMS activities. As most of my other colleagues have mentioned, there are scarce resources, and there's inadequate allocation of funds for IPC AMS programs, even at the county level. The other one was consolidation and coordination of partner support. What we experienced is that at the beginning, we had partners coming in, and it was important for us to carry out partner support mapping, because we realized, there's a lot that was going on, but then we did not want to have duplication, okay? So the partners that were already on the ground, it was very clear what they were actually supporting, and in case another partner wanted to support us, there was a list of what was not supported, so that they can actually take it up, so that we can all the activities revolving around AMS, AMR, IPC actually taken care of. The other one is surveillance, monitoring, and reporting. We needed more locally generated data on AMR. Then initially, there was an absence of standardized data capture and reporting tools. But for this one, at least currently, we are piloting M&E tools for both IPC and AMR. And Nyeri County is also honored to be part of the piloting county. And that is actually going to, bring together, there's a lot of data in facilities, but it is not adequately reported to the national level. So these tools, once the pilot phase is over, they'll be, rolled out to other counties. And this data is actually reported through Kenya Health Information System. So we'll have a repository of data of what is actually happening in the counties, because it will actually also inform a lot of decisions in terms of policy changes, allocation of funds and, training needs, etc. Then the other challenge is the members of the public not adequately reached. Yeah, because number one, it's been expensive. It costs a lot even to have a radio talk show go out to the masses. We've done something about, we have had activities to address the same, but it is not, we've not reached adequate numbers of people in the community. So that photo actually shows the Nyeri County Hospital microbiologist, Mr. Patrick Kamau. Here we were actually introducing the M&E tools I've just mentioned to heads of department within the facility when we are beginning the data collection in the pilot phase. Then we've had inadequate lab capacity in terms of human resource, equipment, and handling of samples. And that includes county veterinary laboratories. We also have the challenge of competing roles for AMS focal person. And a good example is Dr. Oscar, who was not able to come because he's involved in another county assignment. We've also had an ambitious classic work plan. And you only learn when you learn by doing. Yeah. So when we actually had it and we are trying to implement it, we faced some challenges. A good example is when facilities were actually conducting the antibiotic use audits. In the work plan, it states that we were to do them quarterly. But then the feedback that we received from these facilities is that doing them quarterly was actually not realistic because they felt that once they carry out an audit, do the data analysis, get their results, they need to actually give that feedback and identify the gaps where they are, do maybe another round of sensitization and training, and also give the clinicians or the prescribers time to change their behavior. So within 3 months, you may not achieve much. So most of the feedback was like, can we do an audit, do data analysis, then give that feedback and sensitize the prescribers and also observe maybe for a month or two if there is actually going to be change in prescribing behavior before doing another audit. The other one was erratic availability of antimicrobials and lab agent, and this even from other presenters, it cuts across. Then not able to work effectively with the regulatory bodies, professional associations. And, as I had mentioned, the CASIC membership draws representation from these bodies as well, but then we've not been able to have them consistently attend our meetings. So it's been a challenge, but because there are other issues that are pertinent, touching on these areas, but then if they're not there, we are not able to discuss them into conclusion. Then the other one is difficulty in mobilizing the private sector to support AMR activities. And this is both in agrovet and chemists, and obviously, there's conflict of interest. Then also COVID-19 disruption, which actually halted some of the activities planned in the CASIC. We've also had inadequate wash facilities and infrastructure, that is hand hygiene stations and incinerators. So as much as I had mentioned that we have automated hand rub dispensers, they're still not enough. Then data management challenges in the surgical site infection surveillance, that is in both data collection, storage, and reporting. And as my colleague mentioned, I think from Oranga County, the bundles, they are quite large and, not very user-friendly. That is the feedback from the people on the ground. Then the other challenge is suboptimal implementation of some of the surgical care bundles, that is surgical prophylaxis and postoperative prescription of antimicrobials. Yeah, and here is where you find that the officers, they actually know what is supposed to happen, but because they are 50-50, you know, no one is very sure of the IPC practices, yeah? They still cover these patients with antibiotic, even after they have received a surgical prophylaxis and many days after the operation. Then you have outdated and fragmented clinical guidelines. My friend from Kilifi actually outlined this one very well. You know, the comprehensive treatment guideline that is available is, I think, a 2010 version. Yeah, it has everything together. Thereafter, we have pneumonia protocols for pediatrics. We have, you know, how to manage other infections separately. They are all fragmented. So if you are not able to access them, then you either use an outdated one or you go online, find something and apply it in your practice. So that has been a challenge as well. And with all this, we've learned a lot that leadership is key in all levels, both at the county level and cascading, or rather having the same adopted at the facility level, okay? Then a coordination of these efforts at the departmental level, partners, and different levels of ownership of health facilities. Because I'll give a good example. Like when we were carrying out a radio talk show, okay? We had a representative from the Ministry of Agriculture, a representative from the Ministry of Health. If that was not coordinated, then you can imagine with the scarce resources, we'd use the same budget to sponsor, you know, such a radio talk show, okay? Remember, these are things that can take place in one forum. Both, you know, AMR, IPC talk shows for both departments. So we learned that as we are implementing activities. Then the other one is no one size fits all. You cannot say that this is what the National Action Plan says, and this is what you have to follow. Like I had mentioned, I mentioned previously, the NAP did not have a provision for representative from health facilities, yeah, but we were able to consider that bit and bring them on board, which has actually been beneficial because with them on board, then you are able to communicate properly, whatever happens at the CASIC down to the facility levels. Then strengthening lab capacity is very, very important. And we've had one of our officers, a microbiologist, sponsored for a 2-week placement at the Aga Khan University, and this was supported by IDDS, and it has gone a long way in improving our microbiology section. Then, and this is, sorry? Okay. And it's worth noting that she was from the county referral hospital, and the knowledge that she's learned she's been cascading the same to other facilities so that they can actually improve on their lab services. My last one is the use of existing structures and opportunities as much as possible. So this photo is to highlight the importance of leadership in undertaking AMS activities. So we can see our governor, Nyeri County, and our former CEC, Dr. Rachel Kamau, and the members of various MTCs within the facility. This was during a training supported by USAID MTAPs on AMS. Then we've experienced that we need to incorporate AMS IPC into work plans, performance contracts, and staff performance appraisal. And most of the facilities have adopted the same. We have the AMS teams and IPC teams in health facilities having setting targets as far as AMS and IPC activities are concerned. The other one is it's important to generate local data to track progress and also motivate teams. The moment you see the trends from data that has been collected from your facility, you own it and you're able to improve where possible. Also, it's important to incorporate AMS interventions into electronic HMIS system. And I'm happy it is happening through piloting of the M&E tools for the same. Then sharing learning across healthcare facilities. This motivates the teams as they get their feedback and also able to draw support from not only county but also partners. And as everyone has mentioned, small, then you grow with whatever you have at hand. So, and with that, I wish to acknowledge all these partners because with them we've been able to achieve what we've achieved, learn and also share our experiences. Thank you.
So thank you very much, Dr. from Nyeri County. We are going to have only 3 questions because we have very limited time. So my colleague will help me to move the mic around. So you will direct the question to a specific presenter. We'll have more engagements online and during our tea break. So kindly, we'll only have 3 questions. So your hand should go up. So we have to hear. I want to see another hand. Where? Any other question from this side? Okay, so let's go with can you give her the mic?
Good afternoon. I'll pass the mic once I'm done to you. Thank you very much to all the presenters. I'm very proud of you and you know why. My name is Dr. Sylvia Opanga. I don't really have questions, but just to comment that some of the data you presented, it's important that there's training on correct ways of sample collection and identifying the microbes so that you are not growing and testing culture and sensitivity for contaminants. We want true pathogens, so you should be able to, training should focus on that so that you then report meaningful data. Sometimes you can collect all this data, but when you really think through it, it doesn't make sense because you're testing contaminants. The other one, I like what Nyeri has done with community pharmacy. And again, community pharmacy is one of the drivers of AMR in this country. We are really trying a lot in hospitals. So even in your CAR-6, try and just even target 1 or 2 surrounding community pharmacies so that you can also be able to extend those stewardship. If Nyeri can do it, I think we can all do it. Thank you very much.
So thank you for the comment, Dr. Sylvia. Next.
Thank you very much. Let me first of all appreciate the organizers, first of all, for a good job well done. This is the best among the previous presentation I've made so far. Also, let me also appreciate the presenters. They did a good research. I enjoyed it all through up to this particular point in time. And we seek only clarification from Westagula whether we have a policy on start doses, the 3 products, the Prozion and Gentamicin and those 3 products. Do we have a policy on their use in terms of the same? Let me ask you the presenters who did about the risk profiles. Do we have rich versus the poor in terms of AMR? If I live in Kibera, am I more prone to AMR compared to somebody living in Lavington? What is the implication that scenario? And the 2 lastly is if the patient comes to hospital, able to take the lab samples, are we able to track this person in terms of AMR, in terms of identifying containment and ensuring that it does not spread these AMR sensitive materials to other patients. Thank you. My name is Edward Kim.
Let me just get it clear from you. That question, the last part, it is directed to who?
The last.
I think all of them talked about IPC. Which county? Oh, in the morning. Oh, okay. Thank you. Thank you. Thank you for that. So we have another question this side. Then there are more questions from our online chats. We'll read them and respond. Kindly pass the mic. Yes.
Thank you for the wonderful presentation. Mine one, because we are still learning and we are learning from, I want to learn from Nyeri. I am from the laboratory department, and actually the way it has been put, the quality of the specimen received equals to the results we will actually get from the department. And I found that you highlighted sample referral as your strength. And because microbiological samples, if they are not well taken care of, we might fail to actually obtain any growth. And I don't know how you are actually moving up with the sample movement, because if the samples are collected, then they stay within a certain area for more than 2 hours, you'll find that we might not harvest anything. How have you actually made it effective so that whenever a sample is collected, it is moved to or transferred to the testing lab for effective cultures so that we don't fail to culture to obtain an organism? Then two, it is an additional or just a comment from Bungoma, because Bungoma, we've noted that there is low uptake of cultures from the outpatient department, and you'll observe that the data that has been presented with our CASIC team is skewed towards the inpatient. You'll see that we have high resistance, but maybe it is not representing the general population because we are skewed towards the inpatient clients. Is there a way that we can be supported, maybe, because the cost implication is the one that is derailing individuals from taking these tests? Is there a way that partners can support to subsidize the cost of microbiological tests so that we get also the outpatients utilizing these services for us to get enough data that can guide us on development of treatment protocols? Thank you.
Okay. Thank you. Thank you. Let's have the last question from the colleague next to Dr. Esangula. Give her the mic. And then Nyeri, Bungoma, kindly prepare to respond.
Okay, good afternoon. My name is Christina Kuru from Moi Teaching and Referral Hospital. I work in microbiology, and mine is just observations that I saw in the presentations, especially on the reporting of AMR. I saw some drugs being sensitive and others being resistant. Mine is especially on clindamycin. Clindamycin reporting are sensitive because at times it gives a sensitive results on disk diffusion, and then in the real sense it is resistant. So when the clinicians get results for clindamycin testing, they have to check whether the D test is positive or negative. So if they have not done the D test, then they have to request the lab to do the D test so that to determine whether the clindamycin is inducible resistant or it is a true resistant drug. And also my eyes captured the study done in Joho Hospital, Jaramogi Oginga Odinga, about the swabbing of the students' phones Then they isolated Staphylococcus aureus, which was vancomycin resistant. Then my question was, when they get the vancomycin resistant Staphylococcus aureus on individual phones, then that person might be a carrier for Staphylococcus aureus resistant, that is vancomycin resistant Staphylococcus aureus resistant organism. So that person has to be, the owner of the phone has to be identified, and then maybe do nasal swabs so that they can check whether this person is a carrier, nasal carrier, or because Staphylococcus aureus is a dangerous bug when it comes to patients. And then
so maybe you can respond to those ones first.
Okay.
Yes. So let's get the responses. We start with Nyeri County. Nyeri. Then Bungoma.
Okay, for Nyeri County, sample referral has been actually strengthened in the animal health more than the human health. And as I said, it's because of the nature of their patients, okay? So they are doing more sample referrals. However, at the our facility, Nyeri County Referral Hospital, actually leverages on existing programs. And a good example is the TB program that sends samples for gene experts, and we are able to tap into that to refer our samples. In addition, we have had serious sessions on training on how to handle these samples. And these have the sessions have been actually supported by partners. We have IDDS, and we also have the Aga Khan University through the placement opportunities. So mostly that is what actually happened. But then we're also facing challenges from lower level facilities, of which we are not where we actually would want to be, but it is a journey. We keep on improving every other day. So yes, sometimes we get samples that cannot be actually analyzed, but then we keep on training and retraining, sensitizing our lab officers so that, over time we get samples that are actually viable. Thank you.
Bungoma, I want to believe the question has been responded to adequately in terms of sample referral. Bungoma County, Dr. Emma. Dr. Emma.
Yeah, I'm not sure there was a question towards Bungoma, but it was a question from Bungoma on clarification. Maybe my colleague can repeat the question so that we can get someone to answer.
Thank you. It was not actually a question, but a concern or just a comment, because the data we are having, like from Bungoma, you'll find that maybe 90% of the cultures we are doing are from inpatient. And the data we are getting, like the resistant pattern, might be skewed because somebody who is an inpatient, you'll find that this is somebody that has been subjected to treatment for a while, isn't it? And that might give us a wrong impression that this drug has actually come up with the resistant. Is there a way that partners can support to subsidize the cost for culture so that we can also have patients from outpatient benefiting from culture tests, so that we are able to generate data that guides on outpatient pattern? That was actually my concern.
Thank you. I think you are clear now. We'll get the partners are here. And I think they have gotten it very clearly. Before Dr. Wesangula responds on the issue on policy on start dose, and I know you'll have to respond. From our online chat, I think there is a question there for Trans Nzoia. Trans Nzoia County will have to comment. Maybe you can just project that almost every patient is being sent for a Brucella test. I think it was the first. Are you able to project? Yes. Is there a problem with our practitioners in Trans Nzoia? Anytime you feel unwell, they will always ask for a Brucella test. Dr. Zaitun.
Thank you for that question. I wouldn't say there's anything wrong with the clinicians per se, but from the veterinary professionals that we work with in Trans Nzoia County, they seem to think that there's no brucellosis in Trans Nzoia County. That is why we set out with a concept note to just try and figure out the prevalence of brucellosis in Trans Nzoia County. We know that brucellosis is just a group of microorganisms from the genus Brucella, and it can be transmitted from animals to humans, and the animals vary from both domesticated and wild animals. Considering we are living in an area where we have several parks, we cannot 100% surely say that we do not have brucellosis in Trans Nzoia County. So maybe we need to do a more in-depth surveillance on brucellosis to just determine what the pattern is for Trans Nzoia County.
Thank you for that response. And I think it is not only Trans Nzoia County, it is a picture in most of the Western counties and North Rift that there is overdiagnosis of brucellosis. And I think there are a number of surveys that have been done to show the prevalence of brucellosis in these regions. It is not that high, but I think it is the issue of diagnosis based on antibody and sometimes even antigen testing that is not reliable. And of course, culture for brucellosis takes time, waiting for up to 28 days. Someone may not be able to wait for the results. So Dr. Wesangula, you can now tell us whether you respond to his question about IV start policies. Thank you.
Okay, thank you. I think I will just take it back to colleagues from Nyeri and Kilifi who talked about one specific challenge, the lack of guidelines. And I'm sure you heard that, isn't it? That the guidelines that are available are like 10 years, definitely outdated. When you have a gap in terms of providing direction, that is when we end up with people using whatever they think is useful. But I just want to bring it to the attention of the team today that we have actually finalized the review of the clinical guidelines, updated with evidence, and that will be able to provide guidance to clinicians on what to use. So when you have a gap, people will create their own ways out of a situation. So I think in the next 2 months, that policy should be launched and disseminated. But it is not a policy guideline for everyone to get a start dose of ceftriaxone. It doesn't exist. I think it's good to know that, isn't it? Yes. Thank you.
So thank you very much. Up to that point, before I take it back to Dr. Zegel, is there anything that is very burning that you feel you have to mention or comment? Any burning issue? Yes, my brother, give the mic to him. He'll be our last person to speak. Then I take it back to Dr. Zegel.
Yeah, thank you very much for the session. My name is Joshua Odero, a diagnostic specialist with USAID IDDS. My attention was just drawn to a comment from one of the participants who made a point about AST being subjected on contaminants. I think it should be very clear for all of us that the labs that are under surveillance have been supported for capacity building to improve on their detection of potential pathogens. Yeah, so I think that should be very clear for all of us. And from Susan's presentation in the morning, we ran external quality assurance of these isolates from all the surveillance sites in the Republic of Kenya to ascertain that what is gotten from the surveillance sites really correlate with the findings from the national level. Yeah, and before even this data is reported to WHO GLAS, there is a bit of cleaning to just ensure that what goes into the global reporting is indeed true pathogens. And we have renowned microbiologist Prof. Rivathi, who was in attendance here in the morning, and he forms part of that process. And also worth noting that we have biweekly echo sessions where all surveillance sites in the Republic of Kenya do present on cases where we have ID specialists in attendance and smart matters subject expert, Prof. Rivathi, and Dr. Linus of CDC. So I think it is important that we appreciate that we have potential in our country, and the element of reporting on contaminants, we are beyond that as a country. Thank you.
Thank you for that clarification that we have to trust our lab results. Thank you. So let us appreciate ourselves, the presenters, and of course, finally, you'll have to appreciate me. Let's go. I don't know. No, we can do it in an organized manner. We'll just appoint someone to help us do it. My brother from Kisumu, no, you are one of the presenters. So I'll get someone from this table to appreciate all the presenters plus the rest of the team.
Thank you. Thank you for this opportunity. Before I do that, a point to take home. We have been talking mainly of MR on clinical. We didn't talk of chemical. I'm from a chemical lab background. Thank you. So to applaud all the presenters and all the participants, we'll do a 5 factorial. So we'll just go. So let's go. I didn't introduce myself. Lawrence Allow from National Public Health Laboratory. We work with Susan Gidhi. Thank you.
So thank you very much. At this point, I want to take it back to Dr. Zegele so that you can guide us. Sandy.
Thank you very much, Dr. Wambulwa, for taking us through that session. It's just fair enough to now appreciate him. Which one do we use? Inaitwa yeah? Radi ama ile lightning. Una nini alafu ukipiga utaona mikono imeenda na sauti inafuata, ama ni sauti inakuja ndio mikono inafuata. We don't know. So prepare. We'll just hit once. Your treasure. Thank you. Good. Now we are coming very close to the end of today's session, but it will mark the beginning of the next phase. We started it as soon as the chief guest gave his key remarks and flagged us off. So today's work or activity we are just about to conclude it. I would want us to go through, we finish, and then there's tea. I know there are some who've been strolling out, unakunywa, unarudi. Ni sawa tu, lakini bado iko chai. So that when we conclude, you'll be free to leave. We just have one slide, and this is what defines what we are going to do in the next 3 months, between now and end of October. You should be alert that next month, when I say 3 months, it's just to give you hope that we have time. But once you do the elections, you'll realize you have 2 months. And once that is done, you'll realize you're in September. And the moment you plan the activities in September, you'll find yourself in October, a time when you're supposed to be concluding and presenting the new revised National Action Plan. And if we'll be able to tweak the policy, we'll see, because policies are a bit tricky to work through. So, is it here? I'll just project it, and then we follow through. Okay, I had stated that now we look at the next steps. Where are we going from here? As you're aware, we have just had a thorough review of what the journey from 2017 to date. At that time, of course, we were starting from a point of nothing. The only thing we had was situation analysis. Now we have our practical experience, and we need to build on that. So we don't have to really have a big challenge, but for sure, we have to always learn from what we have experienced and then put it on paper and see to it that we have the right indicators, the right activities, well-targeted actions, which will have greater impact, and then also address areas we had not covered. So when you look at that, of course, June came and went. We are in July. We've been able to initiate the communication on policy review. We have the stakeholder engagement, which we'll have to do. And this communication we are yet to disseminate further so that we make sure every stakeholder is on board. We will be doing the plan on how we are going to engage further, whether in professional small groups, wider stakeholder groups and the likes, and then develop a draft revised national action plan and policy where applicable. That we hope to do before the end of this month. Is that too ambitious? What we are saying in the next 1.5 weeks. Wanga, where are you next week? Never to worry, we have what we call digital technology, Zoom, virtual. You wake up at 2 a.m., you are in a meeting. By 4 a.m., you are done with that one. You sleep for 2 hours, you're at 8, you're on another meeting, soon after breakfast. Sometimes you have lunch as you listen in. So that's the way to go anyway. Now, come August, we hope to share the soft copy of these drafts with all of you and other relevant stakeholders to get you to internalize and then also have your comments. Yeah. And thereby, we have another round of probably 2 stakeholder engagements, once to now get the feedback from having reviewed the soft copy of that. That should take us through August. And then in September, primarily we want to reach out across the country with this refined document so that the experiences that we've gotten from the presenters here, and I would say if there's anything to go by, the boy child is in trouble. 1 out of 7, that is too dangerous. We have to work on that. And that will be part of the feedback we are expecting. So anyway, we will engage all counties in clusters or otherwise. And I think the counties that have their established CASICs will be very instrumental in giving proper input because of the experiences you've had, so that we try to have very targeted interventions that will drive the process. Thereafter, that will be September. We will also refine the document at that point in time, incorporate all those inputs, and literally try to polish it to a level where it's near completion. At that point, once we've gotten all these input, we subject it to validation. You're back again, look at it. Are you satisfied with what has been incorporated in the document? Do you think what you provided, your input, has been well captured and represented in it? If it was not considered, why? We will have to answer that. And you will have to appreciate that probably you are thinking either too far ahead or you are being too ambitious, and we refer you to the current NAP and show you how it went. And then, as you know, we had like 91 indicators. That tells you what that means. Thereafter, we will submit now the new draft policy to the respective ministries, departments, and agencies for literally final peer review within the MDAs so that we are clear with the actions, and then also those agencies recognize what is required and then plan accordingly. Because when it's launched, it means you're going to commit resources to have this implemented. Once that is, those are actions within October, we'll submit it to the senior policy level management for endorsement and approval. And that's when you see those signatures that were in the previous just concluded NAP. And we do not know who will be in that office. So you can imagine the number of policy briefs we are going to have in August, as we also share the soft copy, bring the new administration up to speed, make them appreciate the importance and the significance of this silent pandemic and how it's going to affect achievement of the, they call them what, manifestos. Manifesto, because that manifesto is what we convert to the policy, government policy framework for that period. So AMR can make sure you do not move. Na kura zitapotea. Because unajua tu nini hufanyika ugonjwa ikikataa kutibiwa. Most of the time they say this man is resistant to ampicillin, not the bacteria. Now, thereafter, we are targeting to launch this document during the World Antimicrobial Awareness Week 2022. And I think this time we will have literally all the counties with CASIX, we will have those Baruti, yeah, at the same time. You know, it will be the second round, so we may do it at 2 p.m. on the same day across the country. Sindio, we have to be ambitious, sincerely. Mbwembwe, inaitwa mbwembwe, shamra, shamra, what? We make it big. And you know, we can excite the incoming administration, and if we can reach the highest office, that will be a big plus, because that will be among the very first functions you'll have presided over in terms of the healthcare programs that they really have been drumming up in their manifestos. So in summary, this is our timetable of activities. It's as ambitious. It will call for absolute commitment, invest some extra time. If Evelyn calls you, don't ignore the call, just pick it. She may be under pressure, atakuambia yote na ufanye. If I do call, please pick. Because I may be under pressure and I'll tell you something which you need to do, and please do it. And also the other focal persons whom we are going to engage very closely in aquaculture, environment, crop sector. They'll have to really be on point so that all this information takes us through. But having said that, I think it's basically I've concluded the next steps. Unless there's any question, clarification that anyone has, I'm ready, and the Secretariat is ready to respond.
I'm only seeking clarification from the Secretariat. Can we possibly call the document a strategy which is easier to push within this short period of time? Because if it's a policy, a lot of intricacies. So I'm only like suggesting, or I'm seeking whether it is possible, instead of calling it a policy, call it a strategy, because it is within the within the bigger policy of the antimicrobial policy. So my suggestion would have been that you call it a strategy for communication, something like that. Thank you.
Any other comments so that we close it and then I respond? Okay, seeing none, you'll appreciate that we have two documents. The National Policy on Prevention and Containment of Antimicrobial Resistance. The current one, if you look at it, it is not timed, because policies have a longer lifetime and it's a statement of intent. And then we have the National Action Plan to implement that policy, of which we had a time frame from 2017 to 2022. So if you read the policy, you'll find it's still valid, alive. It's just that we want to look at it. If there's anything significant that we need to adjust, we will address that. And policies take a different route. But at the same time, be alert that that policy will be alive until any other comes and is adopted, and that one is rendered nullified. But it will still stand. The actions that we intend to take, those ones are still aligned to the existing policy, and we have the latitude to now increase the scope, but also be careful not to be too ambitious so that we do not lose focus in the key areas that we need to intervene. Thank you very much. And with that, I think I would want to call this meeting to a close by inviting Evelyn to make her final remarks. Thereafter, Dr. Kibias will speak, and then Susan will guide us with the closing prayer. Thank you.
Thank you. Good evening. I know it's been a long day, and when we were doing the agenda, we knew it was going to be long. We couldn't afford to have a 2-day session. We had to try and fit everything within this one day. But I'm glad that a lot of things have come out. And for us, we always say every opportunity for engagement is a learning opportunity for us. We have learned so much. And as we go into the next phase of reviewing the action plan and the policy, our vision and our focus is getting clearer. We are not where we were 5 years ago. We now understand our situation, our capacity better. I think what you're going to be doing over the next 2 or 3 months is just build consensus amongst the different stakeholders regarding the direction we will take and how are we going to get there. I think we all now understand better with the different challenges, the differences in counties like you've seen, just understanding the landscape better now. I think building consensus is probably going to be easier than it was 5 years ago. So the question that I have for myself and for you today is that how do we sustain action even with the changing governments? Because that's the other thing that we are all aware we are likely to face. How do we sustain the momentum? So it's upon each of us that's here today to take this up. Continuous briefings and rebriefing. Let's not get tired about talking about antimicrobial resistance, because I think it's important if you're going to sustain the momentum and secure the agenda as a top priority for all sectors, whether it's public or private. I think it would be important for the champions that are in the room today to just go away knowing that we have to sustain this action and the momentum, and it all depends on each of us and how we take it forward from this point. I say this because we now understand better that the government has competing priorities. We just start from the counties. It might not be your topmost agenda, but it will depend on how well we pitch this to whoever is leading the discussion for the day. And it doesn't have to be in the boardrooms. It can be at the roadside, because the citizens also have power. So let's continue to pitch for greater visibility of this, we say, invisible problem that we are all fighting, to keep this agenda going. And I'm sure by the time we come to the WOW week, like Dr. Zegele says, it's really ambitious. And as I sat there, I thought about 2 months when we did the first version of the NAP. We gave ourselves 6 months, and I think it took almost a year. So we will be ambitious. We will be optimistic that it's possible for us to achieve what we want to achieve. But what we don't want to see is us crossing over into the next year with an outdated NAP, and hopefully provide better guidance to the rest of the country. So looking forward to very strong collaboration going forward. We've noted that we are struggling with multi-sectoral collaboration in different areas, but I believe that we have learned from each other and we're going to strengthen this collaboration. And as I wind up, I just want to say a big thank you to all of you for accepting to be part of this conversation today. It would not have happened if you didn't show up in the morning. I was here very early. I think I was the first to arrive, and Veronica was second, and we kept looking at people coming. But when the room filled up, and I think we were over the number that had subscribed, it's always our joy to see each of us interested in this agenda and really taking it forward. So thank you to the virtual participants for bearing virtual lunches and virtual teas. You know, as people are enjoying a warm cup of tea, I hope you also grabbed something for yourself, for your participation, your encouragement. We've seen your tweets. Some of us are looking for the hashtag, symbol. You can't find it. You can't remember your Twitter handle, or if you ever had one. So I really want to recognize the young people who are in this room today. You're the future of our work. So Cynthia and team, if you're here, just stand up. Edward, let's just appreciate these young people. I think some of them are in that corner, those that have been tweeting, and they told us, don't worry, just retweet. Because when you think about typing a whole paragraph, you even forget. So if they tweet, we retweet. So I hope, Dr. Zegele, you'll not forget, and I think it's one thing that we value. The presence of these young people really keeps us on toes. I want to say thank you to the technical working groups. We have TWGs along the 5 objective areas that have been working tirelessly over the last 5 years. And we appreciate some of them meet as early as 7:30 in the morning so that they can go away and do their other work. And these TWGs have been purely on a voluntary basis. So we don't take you for granted. We appreciate the support. You encourage us to do more. And because of your support, we've been able to achieve all these things which we wouldn't have done on our own. We are a very lean secretariat. And at this point, I just want to request the secretariat members to stand, those of us who are in the room, so that the team can see you. I think some have walked out, but we are not very many. And we can appreciate them for the hard work, the thinking, the guiding, forever being called upon at odd hours, messages flying at strange hours. Some people can be taken in because of discussing work issues after 5 p.m., but sometimes it's so urgent, you can't help it. So I really appreciate the sacrifice that that the Secretariat has made and provided over the last couple of years. To our stakeholders, thank you for continuing to fund our activities. When we started, we had a zero budget. Our first WOW activity was actually hosted at Kabete. Our first audience were actually students. Students don't argue. Kwanza, we were buying them tea and lunch in Kabete. The vet students were so happy, and we were so happy they gave us a platform. And that is where our awareness activities actually started. And now I know there are still some probably who are here. Out of student engagement, the Student Against Superbugs was born, and I can see Dan is here. He's brought this, it's a non-governmental students movement. They are doing their own thing. We're only here to support them. So let's appreciate the Student Association. So they only call us to speak and we disappear. They are now on their feet, up and running, a very vibrant web page. You can visit it and see what they are doing, contribute to building the map as well. So we are grateful for all the others. I won't mention all the stakeholders by name, but now we know we can say we had a budget of $1 billion or $2 When we started with zero, we used to buy our own buns, our own milk for the TWG meetings, you know. But now, thanks to Fleming Fund and MTAPs, we can afford the Radisson, isn't it? Otherwise, we would call you to our very beautiful office and we would fix tea for you. We have a kitchen there. But we are truly grateful. And as I call Dr. Kibias to come and just make his closing remarks, we appreciate the support they've given us. If you don't have support from your leader, you cannot be confident in what you're doing, isn't it? But when you know your leadership is watching you, is nudging you on, is encouraging you to excel, we have the confidence to stand and speak. We have the confidence to engage. We have the confidence to do our best. So Dr. Kibias, thank you for giving us room to excel and room to work and room to even provide advice and guidance on different issues. So as you come to close this meeting for us, I want to request us to appreciate our leadership from across the sector. I think you saw them here in the morning, a clear sign of their passion for this work and their commitment in making sure that this actually moves to the next level. Thank you so much. God bless you as you go back. We truly appreciate and value your partnership. County participants, thank you for traveling all the way and coming to share with us your journeys. And we have learned and will take all your contributions into consideration. Asante sana, Daktari. Karibu.
Asante. Thank you so much, Dr. Evelyn Wesankula. You are truly a champion, a AMR champion. I would like us to appreciate these two persons in today. The first one is Dr. Evelyn Wesankula, who is a AMR champion. How do we do it? The other one is the Dr. Asekele. They are being recognized globally. Sinikweli. Yeah. So their beautiful work has been recognized, and it will not augur well if we don't appreciate them here. So thank you so much. Thank you for your beautiful job you're doing. Now, to the rest of us, waja to appreciate na makofi pia. Good, because a lot has been said. So allow me to summarize it like this. I'm trying to recall what an health economist told us in Geneva sometime back in 2005 when I was doing my master's in public health. That tells you I'm very old, eh? Yes. He cautioned us against allowing antimicrobial resistance, for the very reason that actually he started the story like this. You health workers, you like agitating for pay rise. Then we said, yes, all of us in the class. Then he asked, how do you get your pay? Then we looked at each other, and then he answered it that the money you get paid for monthly comes from the taxes, the revenues that the government collects. So how are revenues collected? From people who work. So if you want a pay rise, you have to prove to the policymakers and the politicians that you are contributing towards increasing the revenue. So one way of increasing revenue, it is in our Vision 2030. If we want to have Kenya a healthy and highly competitive country, isn't it? By making its citizens healthy. So one way of doing that is ensuring that Kenyans are healthy, active, very, very strong, and playing their part in the economy. The other one is ensuring that the same ourselves, we are not consuming a lot of molecules. Yeah. So how do we do that? We prevent. We are currently talking of preventive promotive, a paradigm shift in the way we approach health, well-being, ensuring that we are not every other day trooping to pharmacies. We are not saying we shall close our pharmacies, but we try to reduce the irrational use of antibiotics. I think a lot has been said around there. But the worst of it is if we allow AMR to take place, what we have not said here in details is the second line drugs that you will be prescribed are probably twice as expensive as the first line. And the third line is even probably 10 times. Third line, you can be corrected. Those very rare molecules are very expensive. So the same, if we get very busy spending our foreign reserves in the central bank, buying drugs to stock our pharmacies, because we don't produce them locally. A lot of the foreign reserve leave. So where will your pay rise come from? National Treasury will always say, no, we don't have enough money we have other priorities. So health, and more specifically, because we are talking about AMR now, I want to inspire you, never get tired. I was taught that 18 years ago, but it's remained on my mind. When I worked for TB program for 7 years, 8 years, from 2000 and later on after that, from 2005, 2008, I was now very alert about MDR. And I left the TB program ensuring that we didn't have XDR. We had a few MDRs, but I was working very hard because the treatment for one MDR case that time used to be about $1 million. I don't know how much it is now. For XDR, I don't know how much it is. It's more expensive. And all of us are susceptible, most of us can be susceptible to any XDR disease or MDR condition. Dr. Karaoke gave us a testimony. Thank you for that. We need to avoid that because it's very costly. You make a very productive person less productive. It's very costly, the economy. So we need to keep our economy up and running. And the most specific and very scientific and very accurate way of doing that in the health sector is to ensure that IPC AMR is a priority. It is in your performance contract. It is in your performance appraisal system. Put it also in the QMS, quality management system. Yeah, so that it becomes a procedure that IPC AMR processes or activities are entrenched into our system. That way, you will just see people coming to Kenya automatically. They will bring money. They will come for healthcare services here. Yeah. They will troop in and bring their dollars here. They will come for tourism. At the same time, they come and do their annual checkups here. Some Kenyans here, I don't know, maybe some of you travel out on a tourist visa, but while there, you do your medical checkups in India because you don't trust the system. So it's possible. Yeah. So we need to have a situation whereby the Kenya healthcare system is trusted, is of the highest quality possible. It will be internationally recognized. We have the Kenya quality model care model system, and we can do it. Kiema, we can do it, isn't it? Yes, I'm picking on him because he's in my cohort. Yeah, it is possible. We can do it. I would like to inspire you to continue working very hard to ensure that AMR and AMR is a priority, especially for the young. Yeah, tomorrow belongs to you. Yeah, and for posterity, let's all invest. The fruits will be sweeter tomorrow. Today we can labor too much. We don't see the points. It's not a priority because the treasury people or economists may not see it. But truly enough, when history will be written, people will remember that AMR and IPC contributed to the uplifting of the quality of care in the country. I'm sure as Angular could probably asking ourselves why nobody noticed that the PEPs we are wearing is part of IPC issue, you know? Yeah, you cannot lay claim to some of the successes. Probably you didn't do most of the feasible activities, isn't it? Sometimes public health is very hard to sell. You can imagine you standing in front of everybody and saying, you know, had we not done 1, 2, 3, we would have lost 1 million people. You see that nobody will understand what you're talking about. Kama watu wangevaa masks, wenye wangefariki wangekuwa wengi. Nobody will understand what you're saying. But if you said, you know, there was an accident yesterday, 5 people broke their legs, but we fixed the fractures. And they can see, that one they can see, they will applaud, isn't it? Lakini ile ulizuia, nobody will see. But one day, we are beginning now to speak a different language that when you invest in health, especially prevention, you save, there is a return on investment. Yeah. So we're continuously talking like this. We want the young people here in the house, all the experts from all fields, to talk the same language. That you in health has a space in ensuring that the economy is prospering. Don't occupy that space whereby everybody is bored with you. You're always asking for money, recurrent expenditure. Where when you are to spend too. Are you seeing it? So we need to turn that around. That when they spend on you, they save and earn more. It is possible. Itafanyika. Go think about it. You may not click, it may not click now, but think of why are we having UHC now? Why are we having a paradigm shift from curative to preventive promotive? I finish it like this. With what on behalf of our top management, of course, I have to really thank them for their leadership, like some of you have already done, all the way from the DG upwards, PS, CAS to the CS. This is the last one. When the Kenyan doctors who trained in Cuba were graduating in Windsor, there was a dinner there. Our CS said that Cuba realized that they didn't have a lot of money to spend on curative services. So they went the family medicine way, more preventive. So they have perfected preventing to spend. Okay? So you can imagine how rich we shall be here in Kenya, a very endowed country with everything, if we reduce expenditure on health even by half. Yeah? I know the business people here, who is dealing in importing drugs? Don't wait for me at the car park there. Yeah? You will still have business in another angle. So. You still can do business in preventive promotive health. So let's think investing in health for a return on the economy. So thank you so much. I would like to thank all of you, all the experts in the house, all MDS, all stakeholders from the private sector, from the academia, from research institutions, students. We have farmers here. In some forums, we've had people who are stakeholders who are, we all can be farmers at the same time, isn't it? Yeah, we sometimes supplement our income. So all walks of life. Thank you for being attentive. This is it was a good turn up for this event. And we are so grateful. I want to urge the team within the Ministry of Health, Ministry of Agriculture, Livestock and Fisheries, Trade and Environment to continue the good job. Don't tire. The timeline provided here is doable. I know Sangula has another policy in the pipeline, patient and healthcare policy. We will combine that with the AMR review policy and also the action plan and launch it hopefully by November. God willing. So thank you so much. There's a lot that we can gain if we work together towards under one vision. Thank you and God bless.
I'm advised that Jennifer, will pray for us. Jennifer and Johigu.
Good evening, everyone. Yeah, let us arise and pray. Thank you so much for your patience. And so we have to thank God for this day. So God the Father, Son, and the Holy Spirit, we come before you this evening, giving you thanks and praise. We thank you for the very fruitful day that we have had today. Lord, we thank you for the guidance you have granted us today. We cannot take it for granted. Father, Lord, in a special way, I surrender all the presenters of today, the organizers, the tweeters, because we have seen the event has really been successful and the messages have gone far and wide. Father, Lord, as we plan to revise the NAP, we pray for your guidance that in whatever process we go through, you are going to be with us and that we are going to come with an improved policy to improve the quality of care in all areas using the One Health approach. As we plan to go home, Lord, we pray for journey mercies and ask for your protection. And when we see the success of everything, we are going to thank and glorify you. We pray this trusting and believing in your name. Amen. And may the grace of our Lord Jesus Christ, and forevermore. Amen.
Okay, you may have tea and you're dismissed.